Good morning, all the delegates, esteemed delegates, and the chairperson and the speakers. On behalf of World Federation of Cardiac Imaging and Clinical Cardiology, along with WCCICC 2021 and Nuclear Cardiological Society of India, are proud to present you all a ringside view of the multidisciplinary scintillating hottest webinar ever done in hypertension, which has been scheduled from today morning till afternoon. So here the aim is we have multidisciplinary, we have consultant neurologists, consultant nephrologists, consultant ophthalmic surgeons, consultant physicians, we are all there. So in this connection, we will start now without taking much time. We'll start the first session. In this session, I would invite Dr. Amy Yavalekar, the chairperson. He is a senior consultant cardiometabolic physicians and former professor and head of internal medicine, KJ Somaya Medical College and Lokmanya Tilak Medical College in Mumbai. And Dr. S.N. Narasimhan, the co-chairperson. He is the president. We are very lucky to have him. He is the national president of Hypertension Society of India and also the co-chairman of the Lipid Association of India. With these few words, I would request Dr. Amy Yavalekar and Dr. S.N. Narasimhan to take the stage.
Thank you, Dr. Mahapatra. At the outset, I must express my pleasure to the chairperson for organizing this A to Z webinar lasting over 5 hours. I believe it will be a definite academic feast for all those who are concerned in any way with hypertension. As the first speaker, we have Professor P.C. Manoria, and you are all aware his contributions to cardiology in India. He has been a professor, a prolific speaker, and is a prominent personality at API, CSI, and several other organizations. He has held the first world conference a couple of years back in Mumbai, and I'm sure is going to highlight the newest aspects of hypertension as we proceed from just plain etiological factors, pathophysiology. We now talk of molecular mechanisms. And finally, in the COVID era, we talk about the immune dimensions of hypertension. I believe is going to cover all these aspects, and we are maybe in a position to see hypertension in a new light with the nuances that he is going to elaborate upon. I hand it over to Professor P.C. Manoria, please.
Dr. Manoria, please unmute yourself. Unmute.
Listeners are not able.
Unmute Dr. Manoria.
Is it okay?
Yes, visible, sir, visible.
Okay. So good morning, everybody. For the next 12 minutes, I'll be talking on the nuances of hypertension in the current era, focusing behind the number game. All of us know the numbers of blood pressure are very important and crucial in hypertension. And the guidelines cover the number game with great precision and perfection in terms of diagnosis, initiation of treatment, and targets for BP control. But interestingly, behind the number game, there are a panoply of facets which are important and are of great interest to a clinician. The first issue which I'm going to discuss is the mortality in a controlled hypertensive. All of us know the mortality in a controlled hypertensive is at least 2 times compared to a normotensive, which means if you're a hypertensive, you control your blood pressure to the target level, still you do not come at par with a normotensive patient. And there are a couple of reasons for this. The first is, atherosclerosis continues unabated even in controlled hypertensive. Antihypertensive agent which control blood pressure, no doubt, decrease the hypertension-related complications, cerebral hemorrhage, dissections, left ventricle failure, but they do not provide atheroprotection. And very interesting data emerged from the HOPE-3 trial. This trial included intermediate risk patients, LDL less than 130, annual event less than 1%. And you can see when candesartan and hydrochlorothiazide were taken, that failed to show any reduction in the cardiovascular death, MI, and stroke. But when only 10 milligram rosuvastatin was taken, you can see on the left side of the slide, there was a statistically significant 24% reduction in the cardiovascular events. The second reason is fibrosis occurs in the different parts of the cardiovascular system. And this fibrosis can be beautifully seen by LG-CMR. Fibrosis occurs in the myocardium, as you can see in the slide at the bottom, these white patchy areas. And if the left ventricle becomes hypertrophied and fibrotic, it is very bad for it. It is more prone for development of heart failure, more prone for development of arrhythmia than sudden cardiac death. In fact, all hypertrophied ventricles are being imaged by CMR. In hypertrophic cardiomyopathy, we look at this card to risk stratify these patients for ICD. Patients of aortic stenosis these days, the surgeon also look at MRI for fibrosis to see it is not there, because fibrotic hypertrophic ventricle, the outcome is there. Fibrosis also occurs in the left atrium, as you can see, and it makes the left atrium more prone for development of atrial fibrillation and more prone for thromboembolic events. And all intelligent radiofrequency ablators, they always look at atrial fibrosis, because the chances of sinus rhythm being restored is remote if there's marked fibrosis in the left atrium. And fibrosis also occurs in the large vessels. This is a young compliant artery, you can see. And when the impulse from the heart traverses towards the periphery, it grows slowly, comes back slowly. By the time it comes back, diastole has already started. This results in increase in the diastolic pressure, increase in coronary filling, and therefore offers beneficial effect. On the other hand, if the arteries are fibrotic, the compliance is less. What will happen? When the impulse travels from the heart to the periphery, it goes very fast, comes back fast. And when it comes back, systole is still ongoing, and it produces a panoply of adverse effects: increase in the central systolic pressure, increase in the LV afterload, increase in pulsatile strain, plaque rupture, no diastolic augmentation, no increased coronary filling. Now, is there any solution to minimize this fibrosis? We do not have any dedicated trial, but very interesting data emerged from the long-term follow-up of the ALART trial, the conduction system disease in the ALART published in 2016. And it showed that there is a significant reduction in the conduction system disease with lisinopril compared to CTD and amlodipine, despite the fact that the blood pressure was higher in the lisinopril arm. And more trials are needed in this. The second issue, which is now being increasingly recognized, is increased sympathetic activity. What is its relation to hypertension? All of us know Indians are hypersympathetic, and as you can see in this slide, the prevalence of sympathetic overactivity in newly diagnosed hypertension is 62%. We have also data from the BEAT survey, which showed resting heart rate is elevated in Indian hypertensives. It correlates both with systolic and diastolic pressure, and sustained elevated rate is an independent risk factor for adverse clinical outcome. An increase in heart rate by 10 beats per minute is associated with 14% increase in the cardiovascular mortality and 20% increase in the total mortality in patients with hypertension. And all of us are aware of the Indian Heart Study. It also shows increased sympathetic activity. Now, this is a very interesting analysis from the VALUE trial. On the right side, you can see in patients where blood pressure is controlled, and if you take the quartile of the highest heart rate, there is a 50% increase in the cardiovascular events. This also applies to the uncontrolled hypertension. You can see on the left side of the screen, there's a 35% increase in the cardiovascular events if heart rate is high. And there are data from several other trials. On the left lower panel, you can see INVEST study. As the heart rate increases, there's increase in the all-cause mortality, non-fatal MI, and non-fatal stroke. Data from the LIFE study on the right upper quadrant, all-cause and CV mortality was higher if your heart rate was more than 84 compared to heart rate less than. And the SISTUR study, as the heart rate increases, you can see all-cause mortality is increasing both in men and women. And there are several other publications. If you look at the FINRIS study, for each 15 beats per minute increase in the resting heart rate, the hazard ratio for cardiovascular mortality is 1.24 in men and 1.32 in women. And all of us know sympathetic drive plays a very important role. It initiates and perpetuates hypertension, is responsible for the morning surges. It may also produce non-dippers. It has also adverse effects on diabetes and insulin resistance. It disturbs lipid metabolism and also increases CV morbidity and mortality and more arrhythmias, and renal disease also adversely affected. And we all know in patients with resistant hypertension, we try to do renal sympathetic denervation, clearly indicating that it plays an important role in resistant hypertension. Now, if you block this sympathetic activity, there are a panoply of beneficial effects: homogeneous blood pressure control during the 24 hours, decrease in blood pressure variability, regression of target organ damage, improvement in the metabolic abnormalities, decreased heart rate and decreased myocardial oxygen consumption, decreased coronary vascular resistance, decreased insulin resistance, and decreased LVH. But the big question is whether a therapeutic reduction in the resting heart rate by drugs in controlled hypertensive with increased resting heart rate would improve cardiovascular prognosis. This is still an unanswered question, may be answered in the future. And the second big issue is, can we offer selective beta blockers in controlled hypertensive, as I showed you, with increased resting heart rate, even in absence of CAD, heart failure, arrhythmia, despite lack of recommendations by the guidelines? The other issue which needs consideration is the target heterogeneity in hypertension. The issue is, does the target organ respond in similar fashion to lowering the blood pressure? The answer is no. If it is brain, lower systolic blood pressure is better, lower diastolic blood pressure is lower. If you remember the ACCORD study, it had two groups, 120 systolic, 140 diastolic, 140 systolic. The trial was negative, but when the strokes were individually analyzed, there was a reduction in strokes, indicating lower systolic blood pressure is better for stroke. And the INVEST very beautifully showed, you lower diastolic blood pressure, there is a progressive reduction in the stroke with no J-curve. But when it comes to the question of heart, lower diastolic blood pressure is bad. Even the data from the HOT trial, if you separate non-ischemic versus ischemic, the ischemic is in brown bar. At any level of diastolic blood pressure, less than 80, 85, or less than 90, ischemia, MI are more in the ischemic group compared to the non-ischemic group. And this is the INVEST study, which shows when the diastolic blood pressure is lower, there's reduction in MI. When it is lowered below 70 or below 60, there's increase in MI. So there is a J-curve in hypertension for coronary circulation. And in most of the studies, the J-curve was found to be at the level of diastolic blood pressure below 80 and 70. And you can see if you bring diastolic blood pressure below 60, there's increase in the high sensitivity troponins. And patients who are revascularized, they tolerate lower diastolic pressure better. The other issue is chronic age and vascular aging. Hypertension is an important premature cause of premature vascular aging. And these days we can calculate the vascular imaging by simple non-invasive methods. This is a patient who is of chronological age 54, his vascular age is 57, reasonable. Another patient, chronological age 37, he's 37, but vascular age is 46, bad. Another age, chronological age is 54, vascular age is 70, very bad. But there's no linear correlation between the number of blood pressure and the vascular aging. Other factors like dyslipidemia and diabetes also play. The treatment of hypertension is a long drawn-out process over the years, and therefore special emphasis should be laid on the quality of life. We must never forget, life is not merely being alive, but being well. And our hypertensive patient should not only live, but also feel well, and we should avoid drugs-producing erectile dysfunction in the young hypertensive. There is no doubt that treatment of hypertension decreases morbidity and mortality. It benefits patients, but this does not decrease the number of hypertensive patients. And see, The number of hypertensive patients are progressively increasing in the country. So our aim should be to stop hypertension, and build a hypertension-free India. And this is only possible by primordial prevention. If we practice primordial prevention for several years, we will be able to decrease the burden of the disease. Prevention of emergence of risk factors in population in which they have not yet appeared by individuals in mass health education is primordial prevention. And the best target for this is the primary school children. It's been shown by studies in the United States, study by Fuster et al., that if you target these individuals, they continue to follow lifestyle modification even when they grow older. The incidence and prevalence of lifestyle diseases is markedly diminished. So we must also focus on the primordial prevention. Thank you very much for your kind attention.
I think it was a good coverage of the entire topic within a short period of time. I need to congratulate Dr. P.C. Manoria. I think he had highlighted the importance of resting heart rate, which has an impact in not only cardiovascular morbidity, but also mortality in the long run. And he has shown a lot of studies which were conducted in our own country, particularly the PEACH study and the India heart study, which had gone to prove that resting heart rate is higher in our country. And not only that, it is more the evening blood pressure rise, particularly the systolic blood pressure rise, has been seen to go up in people in our country. And taking these evidences into consideration, I think we need to be very careful in controlling the heart rate also over and above the control of blood pressure. Sir, you have also mentioned that beta blockers probably will find a role in patients in whom you have a resting heart rate which is high, though the current recommendations are not there. What's your comment on that? What beta blocker will you be in a position to suggest?
I think those who have hyperenergic state, we have seen blood pressure is not controlled with other agents, but when we add beta blockers, their blood pressure is controlled, particularly the young hypertensives. So beta blockers, although they are not mentioned in international guidelines, but we are very sure and we use them in our patients of hypertension where there is an evidence of increased sympathetic activity.
And within the beta blockers, what would be your choice, sir?
You can use nebivolol, which has many other advantages. It has a nitrous oxide effect. It doesn't produce sexual impotence. It doesn't produce diabetogenicity. The blood pressure control is better. So nebivolol is a preferred agent.
You talked about the HOPE-3 study.
Yes.
What do you think are the most important conclusive lessons from the HOPE-3 study?
I think the other issue is that if you look at the specimen of coarctation of aorta, these kids usually do not have risk factors for the atherosclerosis. If you look at the aorta above the cord, extensive atherosclerosis, below the cord, no atherosclerosis, clearly indicating that although lipids are very important in atherosclerosis, hypertension per se can also perpetuate atherosclerosis, perhaps or probably by damaging the endothelium, allowing the process of atherosclerosis. That's why the HOPE-3 trial showed that you are an intermediate risk, you have no past cardiovascular event, your LDL is less than 130, N11 is less than 1%, still there was a 24% reduction in the ischemic endpoint. Blood pressure lowering drugs decrease hypertension-related complications, cerebral hemorrhage, dissections, left ventricle failure. They do not benefit the atherosclerotic complications of hypertension. For that, the trial showed that statins are useful. And if you remember the Ascot LLA trial, that also showed 10 milligram atorvastatin in the intermediate risk, total cholesterol not more than 250. Also, there was a statistically significant reduction in the non-fatal and fatal MI. So statins are useful in these patients, even though your LDL is not very high.
Any questions from the floor? Any questions from the floor?
Dr. Manoria, can you hear me?
Yes, Dr. Trivedi.
Dr. Asha Murthy, I have just want as a fantastic lecture covering all the aspects of hypertension and very clear diagrammatic the blood flow in patient with the normal and how the hypertension occurs. I have one question. Do you have increased sympathetic activity plays an important role in the development of isolated systolic hypertension, especially in the young group?
isolated systolic hypertension is an entity which we are increasingly facing, and increased sympathetic activity plays an important role. These patients often respond to beta blockers, although the exact pathophysiology of hypertension is isolated systolic hypertension is being evaluated.
Thank you, Dr. Manoria. I think as the time is turning up, only 3 important messages which you have conveyed. Number 1, primordial prevention is very vital. Number 2, the J-shaped curve. We have to keep the critical figure of 70 millimeters of mercury in mind. And of course, the last, which we see quite often in our practice these days, the tachycardia component in the youngsters. So I believe the tachycardia, resting heart rate higher, is a warning sign. It has to be tackled because it leads to the impending cardiac problems, though not manifest at a younger age. I think these are the 3 important messages, Dr. Manoria, you have given. And on that note, I'll pass on to Dr. Narsingan for the last comment.
I think the excellent coverage of the topic, we need not dwell too much on that because the other speakers are ready to give their lectures. Thank you very much, Dr. Manoria.
Thank you, Dr. Manoria. Thank you, Dr. Mahapatra.
Thank you, Dr. Narasingan and Dr. Yami Yevelkar for chairing the prestigious session. Now we'll move on to the next session on clinical evaluation. In this context, our chairpersons are Dr. Yashpal Sharma. He is the Professor and HOD Department of Cardiology from Postgraduate Institute of Chandigarh PGI, and he's a very eminent interventional cardiologist. Then followed by Dr. R. Rajasekhar. He is a consultant diabetologist and physician, and he has received Master Teachers Award in Epicon 2020, and he has got many awards and everything. And then the next is, I would invite Dr. Bharat Shah. He is the Director, Department of Nephrology from Global Hospital, Mumbai, and he's a consultant nephrologist. So I would request Dr. Sharma, Dr. Rajasekhar, Dr. Bharat Shah to start the session, next session. Thank you.
Dr. Sharma, hearty welcome. My co-chairpersons, thank you, Dr. Mahapatra, for inviting us to chair the sessions. So, Dr. Shah, first chairperson, please. Dr. Shah.
Yes. Yeah, it's a pleasure to chair this session. I think.
Yeah, Dr. Sharma also. Please.
Is this for Dr. Shah or Dr. Sharma?
Both, one by one, you can have.
Okay. So we now have an interesting session, and that's about clinical evaluation of hypertension. And we look forward to listening to different speakers on this. The comment I want to make is very often we get tempted to make a diagnosis of hypertension with one blood pressure reading in our clinic, and we should refrain from this diagnosis. We should try and encourage patients to resort to home blood pressure monitoring. Ambulatory blood pressure monitoring for everyone is difficult. It is difficult to do frequently. And I think home blood pressure monitoring is the best way to determine if the patient is really hypertensive or not. So with this, I would like to invite the first speaker for today's presentation on evaluation of hypertension.
Dr. C.K. Pandey. Over to Dr. C.K. Pandey.
Can I share my slides?
Yes, please.
Yeah. Okay. I think the sharing rights have not been given to me, so I don't know. I am not able to share the slides. Nishita? Nishita? Hello? I have? Okay, I'll just check that as well. Yeah, okay.
You click the green rectangle.
Yeah.
Share slide.
Yeah, I know, sir. No, I know that the thing is, it is not showing here. Absolutely not showing. I don't know.
Host,
What is
the host, please allow Nikita. Please allow him to share the slides.
Okay. Now the presentation is open.
Yeah.
You can see the slides.
Yeah.
Okay. Thank you, Dr. Bharat. I think he has summarized my entire talk in just one line, saying that how HBPM is going to take over. So OBPM obsolete or not? And I guess in a few years it will be. ABPM and HBPM are new gold standards for measurement of blood pressure. Let us see. The Rivarossi invented sphygmomanometer way long back. But look at his original comment on blood pressure variability. It is enough to speak to the patient, invite him to read or look at him suddenly, and perhaps it will take a sudden noise or carriage going past the street to increase the blood pressure. Although this is not the only factor, a simple application of the instrument also can cause temporary rise in blood pressure, the so-called white coat effect that we are talking about today. Well described by Rivarossi way back 1896. We know that 1 in 3 urban Indians above the age of 40 have hypertension. And every 10 millimeter of decrease in mean systolic blood pressure will cause 30% reduction in ischemic heart disease mortality and 40% reduction in the risk of stroke. What does this mean? That every millimeter of blood pressure counts, and therefore accuracy in blood pressure measurement is a prerequisite, immensely important prerequisite to the management of blood pressure, diagnosis of blood pressure, and follow-up and treatment of patients with blood pressure. There are several factors which affect the measurement. What is the setting? Is it office, work, or at home? What is the time? Daytime, not night time, early morning, etc. Observer, who is the doctor? Is it doctor or a nurse or a relative? What device? Mercury, aneroid, or oscillometric that we are using today, and several other factors. So there are some doctor-related pitfalls: missing auscultatory gap, fast cuff inflation, monitor not at eye level, so many, and uncalibrated equipments. The list is endless. Therefore, Norman Kaplan said, the measurement of blood pressure is the clinical procedure of greatest importance, but performed in the most sloppiest manner. Blood pressure measurement now, in the olden days, we had office blood pressure, the only one, and still most practice. Out of office, we have HBPM and ABPM. And they provide a large number of BP measurements away from the medical environment. And now if you see the current AHA and ACC guidelines, class 1A recommendation, out of office measurements are recommended to confirm the diagnosis of blood pressure and for titration of BP lowering medication. So gone are the days where you rely only on office BP. HBPM, is it feasible? Yes, of course, very feasible. What training of the patient is needed? Just 10 minutes of training in the hospital to the patient or a relative is sufficient. Which machine? There are two nice European Society of Hypertension accredited machines, Omron HEM 7130 model and Circa 12080. I will show you. How many readings in a day? One, early morning, the moment the patient gets up. Second, around couple of hours post lunch, and third, pre-dinner. So 3 readings in one day. One day should be working day and one day should be holiday. So 6 readings in a week is more than enough when the patient comes back for a follow-up to take a call about patient blood pressure controlled or not. These are the 2 machines, Omron HEM 7130. That is the only model of Omron approved by the European Society of Hypertension and NICE. Circa 12080 Exclusio is accredited by all the guidelines in the world for exact measurement of blood pressure. This also has got automatic AF detection algorithm. What does HBPM actually do? This is one study published in 2015 in Journal of Hypertension. 831 patients diagnosed with office BP and home BP. When you do, 442 out of that were normotensive. The others had masked hypertension. Whereas by office BP, hypertension 223 were diagnosed as hypertensives. Out of that, 61 turned out to be white coat and others had sustained hypertension. So HBPM reclassifies office measurement and has a better prognostic outcome. This one study you all are aware, done by Dr. Upendra Kaul and all of us, self-measurement of blood pressure is home BP as compared to office blood pressure measurement in a large Indian population, India Heart Study. India Heart Study is one of the largest epidemiological studies in real-world hypertension done in the Asian continent and perhaps in the world. This study, with office measurement was done. People were sent home with a home BP monitoring and training. And after 7 days of watching blood pressure of home, they were called back into the office. Almost 23,000 patients were screened, and finally around 19,000 analyzed. And right from Tamil Nadu to Jammu Kashmir, so many states are contributed. Maharashtra contributed the second highest number of patients, 11% patients in this study. And what we found, that contrary to Westerners, we found in Indian, evening surge is much more common as compared to the morning surge. And Dr. Manoria was alluding to in his talk, resting heart rate of Indian hypertensives is more than 80 as contrary to Westerners, which is usually between 70 and 75. So Indian patients with hypertension are sympathetically driven, majority of them. If you ask me, majority means how many? Almost 2/3 of them. So please remember, though beta blockers have been condemned by guidelines as a 4th or 5th drug in the line to treat patients with hypertension, I don't think India, we can carry on that message. Indian hypertensives are sympathetically mediated, particularly patients who are diagnosed with hypertension below the age of 50. And therefore, beta blockers, like Dr. Manoria said, nebivolol and bisoprolol are one of the best drugs to curb down sympathetic activity and control the patient's blood pressure very well. However, there are some limitations of HBPM, because HBPM cannot give information about nighttime blood pressure patterns, morning surge unless several readings are done, and 24-hour blood pressure variability. Need for ABPM and therefore there, because 50% of controlled hypertensive patients have uncontrolled morning hypertension. 2/3 of CKD patients, Dr. Harsha is here, and most respected nephrologist in the city, he will agree with me that almost 2/3 of CKD patients have non-dipping patterns. 1/3 of hypertensive patients have white coat, and 60% of sleep apnea patients have purely nocturnal hypertension. And how the hell are you going to diagnose that unless you do ABPM? You cannot. So ABPM is also a need in a small subgroup of patients. ABPM, the mean blood pressure level, the diurnal rhythm of blood pressure, mean daytime and nighttime BP, blood pressure variability, and heart rate variability. Everything is very well documented by ABPM. So ABPM gives you daytime BP, daytime blood pressure, nighttime blood pressure, nocturnal dipping, early morning surge, and effect of white coat, and also gives you average heart rate throughout the day. So when you do ABPM, you'll end up in reclassifying your patients. Those who have clinic hypertension and clinic blood pressure is high, but ambulatory blood pressure is normal, they are white coat. Those whose clinic blood pressure is normal, but ambulatory is high, they are masked. And those who are both it is elevated, they have sustained hypertension or true hypertension. So what I'm saying is, it is important in a given situation, whenever you are in doubt, do an ABPM. ABPM also reveals startling facts. 17% are white coat and 10% are masked. In India Heart Study, almost 20% were white coat and almost 18%, double the Westerner value, had masked hypertension. Please note this fact. So IDACO study had shown us that hypertension has worse prognosis, but masked hypertension, second worst, and white coat, somewhere between sustained hypertension and normotension. We know that early morning surge produces cardiovascular events through multiple mechanisms, including shear stress, plaque instability, and endothelial dysfunction. Morning surge is a cardiovascular risk. In a hypertensive patient, the surge has been extensively correlated with cardiovascular events, and in newly diagnosed type 2 hypertensives, morning surge was significantly higher with those with microalbuminuria than in patients without microalbuminuria. So please remember, microalbuminuria is a cardiovascular risk factor per se. So diagnosing early morning surge in patients with microalbuminuria who present maybe type 2 diabetic patients is extremely important to treat these patients better. So when you talk about nighttime blood pressure, there is usually 10 to 20% drop in the nighttime blood pressure in all patients. So non-dippers are called when the dip is less than 10%. Extreme dippers when the dip is more than 20%. And reverse dipper when the blood pressure actually rises during sleep. ABPM reveals startling fact. This another study which was done in 2018 showed in 860 patients with hypertension, 41% are non-dippers and 60% are abnormal dippers. Out of those who are abnormal dippers, 4% are extreme dippers, 14% are reverse dippers, and 41% non-dippers. So ABPM gives you prognostic importance because left more closely correlate with ABPM than with HBPM. Ambulatory blood pressure, therefore, is a more sensitive risk predictor of cardiovascular outcomes such as coronary fatal events and stroke than office blood pressure. So my friends, office blood pressure is okay to do, but please do not rely on it completely to diagnose and treat and assess the control of blood pressure. So when you talk of prognostic value of BP parameters, nocturnal blood pressure has the highest prognostic value. And therefore, ABPM's prognostic value is much, much, much higher than office BP and 20% higher than HBPM also, because nighttime blood pressure is diagnosed only by ABPM. Early morning surge is only diagnosed by ABPM. And extreme dipping, which has the increased risk of stroke, is also diagnosed only by HBPM. So ABPM is the only practical method to determine the dipping pattern. And ABPM then reclassifies your patients into concordant control or concordant lack of control. So when you have office blood pressure more than 180, 110, you don't worry. This patient is a clear hypertensive. But when the office blood pressure and OBPM both are less than, that is office automatic blood pressure and office clinician's blood pressure, both are below these figures, you are probably, there is no hypertension. Anything in between, you have to resort to HBPM and ABPM. And this is a comparison which is between ABPM, clinic BP and HBPM. And it's very clear that dipping status is only diagnosed by ABPM. ABPM gives you concordant values and explanations about true or mean blood pressure variability, heart rate variability, and drug effects as well. So all the current guidelines today recommend ABPM and support ABPM. But because of access and availability, lack of awareness of its clinical significance, lack of counseling and education of the patient, sometimes patients don't accept ABPM very well. Almost 1 in 5 patients don't accept ABPM very well. It disturbs their sleep and the cost. Therefore, ABPM has not become really popular. And the sweet spot and therefore is HBPM. Every single blood pressure patient of mine has been forced, literally begged to borrow a home blood pressure machine. I usually take only one reading after resting for 5 minutes in my office, and they bring their own blood pressure chart from home. And trust me, they are very proud to show me the blood pressure chart, telling me, Dr. Ponde, your blood pressure office, देखो आपका ऑफिस में 150/90 है, लेकिन मेरे घर के सब रीडिंग देखो डॉक्टर, सब नॉर्मल है. So patient also feels that he is involved in his treatment. He is proud to show you that he is taking the track of his record. So patients take the control of blood pressure himself. And that is very, very important. And therefore I say HBPM is a way forward, as Dr. Bharat Shah said. Hats off to him. I think he has really hit the nail that HBPM is the way to go. Thank you very much for your patient listening. Hello? Hello? I can't hear anyone.
Yeah, you are audible.
Oh, sorry.
So it was just think that the home pressure monitoring may not be very good, but now with the learning of patient and they have the recording very well, and we can check them in office also. This is very good. In fact, regarding evening surge, the latest study which has shown in India, a large study, I think we should do a lot of research on this, because the sun is fixed, the earth is moving. It might be related to some other movement of earth. And of course, in India, there are a lot of stresses. And the Indians, 7 days a week, long working hours like that, lot of tension and others. These environmental factors, that has to be improved, because tachycardia, adrenergic stress, they have a lot of for this hypertension, because 1/3 to half of the hypertensive patient have post-distinct coronary artery disease. When we do intervention,
Yes.
they have a very diffuse disease and multiple risk factors. So with this, I will say that this was a very elegant lecture. Any other comment by my co-chairperson, please?
Thank you very much. Dr. Y.P. Sharma, please introduce the next speaker, as we are already running short of time. At the end, we will highlight a lot.
Okay.
Thank you all, sir. Thank you all.
Yeah.
Thank you.
So
next, hypertension guidelines, please.
Yeah, hypertension guidelines. That will be by Dr. Sadanand Shetty. I think discussion we can have later on also. So we listen, because there are a lot of guidelines, Indian guidelines, European guidelines, GNC guidelines. They change. Sometimes we accept them, sometimes there are debate. So I think this will be a good topic, guidelines in hypertension.
Can you see my slides, sir?
Yeah, Sadan Shetty is very much
thank you.
And
Thank
you have put a very nice photograph of multiple guidelines. Nice
Thank
photograph.
you. Thank you, Dr. Mahapatra, and our organization for giving me this very important seminar on hypertension. What I'm going to do for the next 10 minutes is how to dissect out the multiple hypertension guideline. And as you see here in the slide, the target is like a moving target, like it's like a pendulum is moving. But at the end of 10 minutes, I will impress on you that this pendulum is going to stop and give us a very clear cutoff what is the current in 2021, how we should treat hypertension. Of course, as the chairperson said, multiple guideline, and I will mention during this during my talk. Let us see the new guideline. What does it say? All the guideline agree to the principal areas of emphasis on accuracy of BP measurement. As a matter of fact, BP measurement is very fundamental, as Dr. Ponde as well as Dr. Manoria addressed in their earlier talk. Cardiovascular risk assessment is important regarding the BP treatment threshold. Lifestyle modification is recommended, and initial combo therapy. So all the guidelines, these are the areas where there is a clear-cut agreement. So there's no difference of opinion. However, these are the 4 areas what I'm going to discuss in the classification of hypertension, threshold, what is the treatment goal, and what is the treatment strategy. Is there any difference among all the guidelines? Now, coming to the classification, we know the first one which made a lot of difference, like a sort of noise in the among the clinician, is the AHA-ACC 2017 saying more than 130 to 139 diastolic, 80 to 89 as the stage 1 hypertension, which is also to some extent, little bit now sort of, the global, the International Society of Hypertension, which again puts stage 1 and 2 only, unlike the European, Indian, and even the NICE guideline, or for that matter, even the Canadian guideline saying 3 grades, 1 to 3, and they've classified normal, optimal, normal, high normal, whereas here normal, elevated, etc. So basically the AHA saying more than 130 as the stage 1, and that is the difference among the guideline between the AHA and 2018 European, that European saying more than 142, 159, diastole 92, 99 as the grade 1 hypertension, then grade 2, grade 3 accordingly. Whereas the American guidelines saying stage 1 hypertension when the systolic blood pressure is 130 to 139 and diastolic 80 to 89. Now, this is what the International Society of Hypertension 2020, which is published in about May a month, and the practice guideline telling us the normal blood pressure less than 130/85, high normal, what Americans said stage 1, and 2 grades only in this particular ISH, unlike the European and the Indian guideline, where there are 3 grades between 140 to 159 and 90 to 99 as a grade 1 hypertension. Now, Indian guidelines also more or less are going to the same thing, suggesting the optimal, normal, and high normal, more or less the same as the European counterpart, as well as the maybe the NICE guideline, etc. Now, if you have to look at the important the reading, what you should know, particularly since Dr. Ponde highlighted the value of ambulatory and home BP monitoring, what is the reading between the office, ambulatory, home? You say is the hypertension. Office BP of 140/90 is equal to home BP of 135/85, and also the daytime mean of ambulatory 135/85. So remember, roughly 5 millimeter less than the office is the home BP as well as the daytime mean. Whereas a night BP, if it is more than 120 systolic and more than 70 diastolic, is considered as an hypertensive. And if it's a 24 mean, is a 130/80. So these figures we need to know, because these figures will put the diagnosis of whether like, are you based your reading on the office or on the basis of home. This particular slide was shown by Ponde regarding the hypertension guideline, the Canada. Basically, they are given importance to diabetes. If there is a diabetes, whether it is automated or non-automated, more than 130/80, they consider as an hypertension. In a non-diabetic, the automated more than 135/85, or a non-automated 140/90. So they are given about 5 millimeter difference between the non-automated and automated. And some people believe even 5 to 10 difference may be there between the home and the office. Very, very important slide. In fact, if all delegates understand this, I think I've done the job, because the theme of World Hypertension Day 2020 is to take measurement of blood pressure very, very properly. Take the blood pressure measurement properly, control it properly, and live longer. And that is the theme. This is also highlighted by my previous speaker, my friend Dr. Ponde. And this is what all important, like how we are supporting the back, how the cuff is tied, how the patient is resting his foot, whether it's the automated or whether it's the mercury manual auscultatory, should be quiet room and relax for 3 to 5 minutes. Take 3 readings. The first we can sort of discard, and the later 2 measurements at an interval of 1 minute, and so on. Very, very important. It may look like fundamental, but to me, hypertension, you make or break everything on the basis of your reading. And if you're going by the office BP, is more important. So just to summarize, in the diagnosis of hypertension, the difference between the guideline is that all the guideline tells more than 140/90 as is the stage 1 or grade 1 hypertension, except for the AHA, that is 130/80. But when it comes to the risk, more than 130/80 by all the guidelines. So essentially the message in the diagnosis, you look at the risk of the patient and then say whether more than 140 or more than 130 as the stage 1 or a grade 1 hypertension. Let us go to the threshold for the treatment initiation. Again, the European and the American go by, again, the whether high normal or the grade 1 hypertension. Therapeutic lifestyle is important, but when more than 130/80, if you've got a high risk like coronary artery disease, CKD, stroke patient, you will intervene. And if not, go according to the indication, like you start therapy. This is also same by hypertension Canada, saying that for low risk, more than 160/100 is the threshold, and the target, again, which we'll discuss in the next part of our talk. And the high risk, like the patient who has got the atherosclerotic cardiovascular disease more than 15 to 20% at the end of 10 years, more than 130 is the threshold. So also in a diabetes, 130 is the threshold. So basically, again, highlighting the fact, Indian guideline also suggesting the threshold for blood pressure depends upon the risk of the patient. So second important message, that treatment initiation means at what stage you are going to start the treatment, again, depends upon what is the risk of the patient. So again, coming to the previous one, diagnosis based on the CV risk, whether stage 1 or grade 1, Threshold for BP again depend on the risk, like general population more than 140/90, high risk more than 130/80. So both diagnosis and the threshold remain the same figure, 140/90 and 130/80. Now let us come to the treatment goal. Treatment goal is again, depends upon whether age less than 65. This is according to the European guideline and the AHA. Again, making AHA very simple for everyone, 130/80 or so. Whereas, European probably CKD, CAD, maybe diabetes, you go a little low down. But one important message what European guideline has given very clearly, systolic not less than 120 and diastolic not less than 70. This is alluded in our very first talk. Manoria very rightly said, Jacob phenomenon. So 120 systolic, 70 as a diastolic cutoff. There's an important message of the European guideline. So all this again depends upon the risk of the thing. As I mentioned here, if a high risk patient, then you'll get down the blood pressure less than 130/80. This is also same Indian guideline, and this is what the ISH global hypertension guideline. So essentially coming to the target of the blood pressure, it depends upon the CV risk factor and the age. So remember, general population more than less than 140/90, less than 134, establish ACVD or heart failure. So coming to the third message, now after the classification, after the threshold, BP target, same figure. So remember this figure, 130/80, 140/90, risk and general population without the risk. Now coming to the last one, treatment strategy. What is the standard treatment we know today? Like, drug like ACE or ARB plus CCB, or, either single or in combination, which is probably the standard of approach what we are doing. And that's what also been highlighted by the ISH 2020 Canadian classification. And as far as possible in the current guideline tells us single pill combination, either dual or a triple combination. And we are fortunate in India, we have got, so many double and triple combination to improve the adherence and the control of blood pressure. And Indian guideline also tells us about all the 5 group of drugs, specifically the younger individuals, beta blocker. This has been highlighted by Dr. Ponde also, and I'm a strong proponent of beta blocker. And to me, it's a nebuolol, not even bisoprolol, and that's my choice because of various reasons. So in young hypertension, it's usually the preferred drug because we have got high renin hypertension, and the older individual low renin hypertension, so CCB and diuretic, and then the combination dual or triple, and the combination is the way forward, and that's what. So coming to this treatment strategy, the summary, 5 class of drugs all can be used, but since beta blocker, newer beta blocker is not highlighted by other, but it's a strong reason for us to use, particularly the nebuolol. And then of course the younger individuals, high renin hypertension and lower this one. So coming to the guideline, only guideline which there is a divergent is in the diagnosis, and that is again by the American versus the European. But rest all European, Canadian, Indian, ISH, everything are following this. But when it comes to the treatment goal is 130/80, that is a convergence. So essentially speaking, there is not much of sort of difference among the guidelines. So just to give you the take-home message, more agreement between the guideline than there is major difference. It is a way you interpret it. All guidelines strongly recommend lower BP target for high-risk patient and a similar emphasis on proper BP measurement. I would like to again highlight proper BP measurement, laboratory diagnostic, etc. are the therapeutic lifestyle, pharmacological management, proper BP measurement. Office BP is the standard BP, though Dr. Ponde said is going to be absolute. To me, ambulatory and the home BP are additive to the office. So there's no question about not taking BP. Simple, it is a thing device to do at clinic, either automated or non-automated. Never low threshold to diagnose and treat hypertension, more than 130/90, are very, very relevant in India high-risk population. And I'm very personally very, the proponent of more into the American, basically because of the high-risk population among Indians with the diabetes, metabolic syndrome, dyslipidemia, etc. Maybe 130/90. Whereas in the general population without the risk, you can take 140/90. Aggressive BP goal may be the difficult to achieve in all Indians, but we must make a concerted efforts to make this recommendation. Thank you very much.
Thank you.
And very clear message you have given that 140/90 in high risk and 130/80 in low risk.
Yeah.
Secondly, I would just like to emphasize that when there is a grade 1 or initial stages of hypertension, lifestyle modification for at least 6 months should be intensely tried, because that will be the best one. And we should focus on the comorbid diseases.
Yeah.
Just as an interesting point, not in that way, in COVID era, the mortality with hypertension and diabetes was very high. In fact, we could save very sick cardiac patients with the antiplatelet thrombolytics, which we advocated from PGI initially, 2B3 inhibitors to general in India as well as abroad. But the hypertensive patients, they died. Many patients, diabetes. So for COVID also, when hypertension is there, we should label those as a not mild COVID. They should be moderate or severe COVID if hypertension is there, and they should be treated aggressively for COVID as well as hypertension. So the mortality of COVID and hypertension will not be different as compared to the normal population. So that is at the present era, hypertension with comorbidities.
I have a question for Dr. Shetty. Some elderly patients, it is just impossible to bring down the blood pressure below 160 or below 170.
Yeah.
Sometimes they maintain a systolic blood pressure of 180. Where do these guidelines stand in these cases?
Dr. Barisha, whenever we interact with our international experts, what they mention is that even in elderly, systolic blood pressure is, important to get down to what we are talking about, the target of treatment, like in a less old patient. So it all depends upon individualizing patient, frailty of the people, whether they can tolerate, and therefore few of the guidelines says even 140, like a 90 range, like in a particularly people beyond age of 85 and so on. But when we get the systolic blood pressure down in elderly people, possibility of diastolic also going down, which we know always, there is no drug only specifically for systolic hypertension, though CCB and thiazide like diuretic, chlorothalidone indapamide may be the drug which is predominantly we use in elderly hypertensive, but systolic blood pressure reduction even in elderly is a recommended. And therefore in 2017 ACC made a general state of 130/80 for all. So point is we have to individualize, like as Dr. Sharma mentioned, and a comorbidity, whether patient can tolerate, whether there's in a postural fall and etc. But we have to see they may be also having a CAD, try to see the diastolic doesn't go less than 70, or maybe in such patients we go up to 60 also. But it's a difficult area what we have to treat. But the point I want to highlight again, try to get the systolic blood pressure to the level what we are recommending, even less than 65. And that is why, generalization for everyone, general population, like, target range, depending upon the risk comorbidity is 130.
Thank you.
Thank you, Dr. Shetty.
Yeah.
I think now we move on to the next topic, because I think time will be this was shortage. There will be shortage.
Dr. Yas, I would intervene here. The discussions always will be at the end.
End. That's
end. Otherwise, you cannot cover up all the lectures.
Because already we are behind schedule.
Yeah, please.
Secondary hypertension, stepwise approach by Dr. V.T. Shah. Over to Dr. V.T. Shah, please.
Can you hear me now?
Yeah.
And can you see my slides?
Yes.
Yes. So thank you very much, Dr. Mahapatra, for giving me this opportunity on a not so discussed topic in hypertension. So I'm going to talk in the next 10 minutes about secondary hypertension and a stepwise approach. So my idea would be to just give you an overview, because this topic, my slides are not moving. Okay. Sorry for that. I think I have to go back again and try it out. Whether
go to the slideshow and share the screen.
Yes.
We are seeing the slides.
Yeah, now. Yeah, thank you. So we all spoke about primary essential hypertension, which is 95% of the hypertensive population, where we have multiple genetic and environmental factors, but no specific cause. Whereas in secondary hypertension, we have an identifiable specific cause. It forms 5 to 7% of the hypertensive cases which we see. There are many reasons for the secondary hypertension, which we have to look for in all the primary hypertensives which we diagnose. So the most common thing is drug abuse or some kind of side effects of the drugs. Renal disease, with Dr. Bharat Shah, we know that renal parenchymal disease, polycystic, chronic glomerulonephritis, chronic interstitial nephritis, diabetic nephropathy, obstructive kidney disease, renovascular disease, renin-producing tumor, primary sodium retention. In vascular causes, coarctation of aorta. In neurological causes, increased intracranial pressure, porphyria, familial dysautonomia, lead poisoning, Guillain-Barré syndrome. In endocrine, we have thyroid disorders, adrenal disorders, Cushing's, congenital adrenal hyperplasia, primary aldosteronism, pheochromocytoma, hypercalcemia and hyperparathyroidism, carcinoid tumors, extraadrenal and exogenous hormones of estrogens, androcorticoids, sympathomimetics, MAO inhibitors, and so on. Pregnancy-induced hypertension also is secondary hypertension, and in certain stressful situations, we do get secondary hypertension. So these are the causes, but the mechanisms of secondary hypertension are almost the same, except in few conditions where there are specific hormones which give rise to the hypertension. So increased vascular tone, sodium and water retention, abnormal sympathetic activation, abnormal RAS activation, and endothelial nitrous oxide mismatch. So these are the basic mechanisms. And amongst that 5 to 7 causes, depending upon the age group, depending upon geographical distribution, you will find there are different incidences or prevalence of secondary hypertension. Of course, renal hypertension forms the most common cause, parenchymal or renovascular, endocrine, cons, Cushing, pheochromocytoma also, and drug-induced, specifically oral pills also form that. Now, according to the age group also, you can divide this in children from up to 11 years of age. Most common would be renal parenchymal and coarctation of aorta. And in renal parenchymal, maybe congenital polycystic kidneys or glomerulonephritis would be there. Adolescent, 12 to 18 years, renal parenchymal and coarctation of aorta. Young adults, thyroid dysfunction, fibromuscular dysplasia, especially in females. Renal parenchymal disease also one has to rule out. In middle-aged, hyperaldosteronism, thyroid dysfunction, obstructive sleep apnea in obese individuals, Cushing syndrome, and pheochromocytoma. And in older adults, of course, atherosclerotic renal artery stenosis, CKD patients, diabetic nephropathy, and hypothyroidism. This is the age group. Now, what are the general clinical characteristics when you suspect that this could be secondary hypertension? If you have an early age, I mean, in early onset of hypertension, very young in age, especially less than 18 years of age, 18 to 29 in patients, and where there are no obvious risk factors, family history or obesity, and in increased blood pressure in prepubertal children. So this age group, an early age group should suspect when there are no other risk factors. Resistant hypertension, despite 3 drugs, severe hypertension or hypertensive emergencies, or hypertension with gross secondary target organ damage, and a sudden rise in blood pressure, especially in the elderly people when they are stable, but there is a sudden rise. Or as in sleep apnea syndrome, you will find that the dipping patterns have changed. So these are the basic features. Like we all know pheochromocytoma from our student days, we remember 4 P's: paroxysmal hypertension, palpitations, headaches, diaphoresis, tachycardia, and diagnosis by the urinary catechol metabolites of VMAs and metanephrines, plasma nowadays with plasma-free metanephrines also. Hypothyroidism, fatigue, weight loss, hair loss, diastolic hypertension, more, and muscle weakness. The hyperthyroidism by heat tolerance, weight loss, palpitations, and more of systolic hypertension with tachycardia. Hyperparathyroidism, kidney stones, osteoporosis, depression, lethargy, muscle weakness, and we diagnose that by serum calcium, parathyroid hormone levels, and so on. Acromegaly, increase in growth hormone levels, more of enlargements of head, feet, hands and feet, tongue, headaches, visual problems, fatigue, and so on. So coarctation of aorta, classical in children and young adults. We see there is a mismatch between the femoral and the brachial pulses, and confirmed on 2D echocardiography and CT scan. Cushing's syndrome, weight gain, fatigue, weakness, hirsutism, amenorrhea, moon phases. This could be either iatrogenic or could be spontaneous. And the test to be done is dexamethasone suppression test. So these are the things. And of course, obstructive sleep apnea with history of snoring and doing a sleep study. Aldosteronism will come to, and renovascular disease will come to. Now, what are the drugs? NSAIDs, oral pills, steroids, sympathomimetics, cyclosporin or tacrolimus, erythropoietin, ephedra, mohang, bitter orange, cocaine or amphetamines, and excess of alcohol. So these are the secondary, these are the drug-induced causes which one has to look for. This is again a flow chart depending upon the age group and depending upon the cause which you suspect. You try and go ahead with the investigations and confirm the diagnosis. So renal causes, two forms, parenchymal and renovascular. Amongst the parenchymal, chronic glomerular nephritis, chronic interstitial nephritis, pyelonephritis, nephrocalcinosis, neoplasm, glomerulosclerosis, analgesic nephropathy, polycystic kidney disease, gout with renal failure, and obstructive nephropathy. So this could be various causes in different age groups, and one has to suspect this in all hypertensive, primary hypertensive patients, and do a screening of the renal parameters. So renovascular, commonest cause is atherosclerosis in the middle and the elderly age group. Takayusi's arthritis, also one of the common causes in India. Fibromuscular dysplasia, other causes like aortic renal dissection, thrombotic or cholesterol emboli in the very elderly octogenarians, post-traumatic, post-transplant stenosis, and post-radiation also would be causes. So we clinically, we look for a bruit, mainly diastolic renal bruit is more specific than the systolic renal bruit. You look for microalbuminuria, macroalbuminuria, and you do a color Doppler ultrasound, CT angiography, MR angiography, and a 99 technetium DTPA renal scan test also would help you in this diagnosis. Of course, the confirmatory test will depend upon what non-invasive parameters you have, but finally we look for a conventional angiography, which is the gold standard to detect renovascular. Captopril screening test also is one of the tests, but less commonly done nowadays, with many more other non-invasive tests being there available. Classic case of renal artery stenosis. This is fibromuscular dysplasia. If you see here, let me see. Yeah, if I can get the, yeah. So the classic beaded appearance of fibromuscular dysplasia. Okay, so now these are the endocrine causes. Now adrenal dependent causes, pheochromocytoma and sympathetic paraganglioma, primary aldosteronism, then hyperdeoxycorticosteronism, could be congenital or could be because of tumor, and Cushing syndrome, then apparent mineralocorticoid excess. So there are many such causes, genetic and acquired, following drugs also. Cushing syndrome, as I said, parathyroid dependent causes, hyperparathyroidism, Pituitary causes acromegaly and Cushing syndrome. Secondary hyperaldosteronism, renovascular hypertension, thyroid disorders, and obstructive sleep apnea. So pheochromocytoma, another one of the common things which we should look for. Yeah, okay. So it is episodic hypertension. There could be postural fall, pallor, throbbing headache, palpitation, and perspiration. So perspiration, palpitation, postural fall, and pallor, 4 Ps of that. We look for screening like plasma and urinary metanephrines and VMA levels. And then, of course, you can do PET CT scan and to confirm the diagnosis. Tumor localization is done by CT scan and MRI of the abdomen, or MIBG labeled I-131, which you will hear from Dr. Mahapatra, all these tests. And as far as the preoperative preparation, oral phenoxybenzamine 10 milligram once daily. If you don't have that, oral alpha blockers followed by beta blockers could be the drugs. Primary aldosteronism, another important thing which we should always look for. So when you screen your primary hypertension patient, please look for serum electrolytes always, and just don't do serum urea, creatinine levels. Look for hypokalemia, look for persistent hypokalemia with metabolic alkalosis. If you get this, then you should suspect, and if it is persistent, you should suspect that this could be one of the causes. So, and how do you investigate? You do the plasma aldosterone to plasma renin activity, which could, if more than 20 to 25 is highly suspicious. And then you can do, of course, the other confirmatory test, the response to oral sodium chloride load, fludrocortisone or captopril test. You can do nuclear scan. And the most commonest way this is diagnosed is by the CT abdomen. CT abdomen has been done for various other causes, and the radiologist picks up the adrenal enlargement, and then you have to investigate these patients, whether they are compensatory, physiological, or whether they are producing hormones, and then we do this test. So the treatment is surgical removal, and we start spironolactone to this patient, which minimizes the hypoaldosteronism and restores potassium level. Cushing syndrome, the classic sudden weight gain, truncal obesity, moon faces, and hypertension is present in 80% of these patients. The 24-hour urine-free cortisol level is more sensitive and specific. And then you do the low-dose dexamethasone suppression test. Give 1 milligram dexa at 11 p.m. and draw a sample of blood in the morning for cortisol measurement. If more than 100 nanomoles, it is positive. And then followed by CT and MRI of the head and the chest to look for pituitary or ectopic or the abdomen thing. So these are the various surgical. I will not go into this. Coarctation of aorta will be discussed by the vascular people. There is a special talk on that. But if you see here, this is the coarct in children, congenital. Sometimes in adults, it could be post-radiotherapy also. Pregnancy and hypertension is a separate topic by itself, but enough to know that pregnancy-induced hypertension is also one of the secondary causes, especially during pregnancy. Pills, thyroid disorders, stress-induced. I will not speak much about that. And finally, the initial assessment of a hypertensive patient should include a complete history and physical examination to confirm the diagnosis of hypertension. And before you label this as primary or essential hypertension, secondary hypertension has to be ruled out, especially including the onset at a young age, less than 20, abrupt onset of hypertension, blood pressure, difficulty in controlling them, requiring more drugs, more blood pressure, more target organ damage. If all these are there, then one should definitely suspect and rule out secondary hypertension. And the investigation of choice would be depending upon what etiology you are looking for, whether it is renal or whether it is endocrine or whether it is obstructive sleep apnea and so on. So with that, I would end my lecture. Thank you very much.
Thank you, Dr. V.T. Shah. As again, we are running behind schedule of time. Let us go to next topic. Dr. C.N. Manjunath, he will assess cardiac evaluation in hypertension, physician's perspective. Over to Dr. Manjunath. At the end, we will have a brief discussion.
Dr. Rajsekhar, Dr. Manjunath is busy in a nodal meeting of COVID in Bangalore, and he has sent the message he will not be able to.
Okay, next we will go to Nikhil Gokhale. Nikhil Gokhale, that is retinal evaluation. Nikhil Gokhale.
Yes, good morning.
Yeah, please share your slides.
You can see my screen now?
Yeah, very much
okay.
seen. You can go.
Okay. I'd like to thank Dr. Mahapatra for giving me this opportunity to speak on basically changes of hypertension in the eye. So I would go through some of the ocular manifestations commonly seen, the various diagnostic equipment we can use, the pathology of retinopathy, grading systems available, show you some images and indications for cross referrals, and a bit on what we should be doing in the coming future. So we are aware that hypertension can of course cause hypertensive retinopathy. However, it can also cause hypertensive choroidopathy, optic neuropathy. It's a risk factor for vascular occlusions in the eye, which may be venous or arterial. It can cause anterior ischemic optic neuropathy. Patients who are diabetic, they are at extremely higher risk of a faster and a higher risk of progression. Similarly, it has roles in age-related macular degeneration, glaucoma, and during surgery, we sometimes get suprachoroidal or expulsive hemorrhage, which can be seen more often in these patients. Direct ophthalmoscopy has been historically the most commonly used instrument by both physicians and ophthalmologists. We know it's inexpensive and easily accessible. Today, of course, as ophthalmologists, we use more of slit lamp based fundus examination lenses, which give us a more binocular and a stereoscopic view, and of course are used mainly by ophthalmologists. Traditionally, we also have fundus photography, which is very helpful for documentation, can do computerized analysis. However, the equipment is fairly expensive and is mostly available with retina specialists in ophthalmology subcategory. However, today we have several mobile camera based photography devices which have made the job fairly simple and inexpensive, and also provide fairly good quality of digital images which can be useful for documentation. Some of these patients may also require additional testing such as fluorescein angiography and optical coherence tomography tests to document or to sort of pick up certain changes which may be happening in the retinopathy. Traditionally, when you do direct ophthalmoscopy, we need to try and do it with a dilated pupil, try to look at the optic disc, and then try to look towards the periphery, come back to the disc and scan other quadrants. And the last, we normally try to look at the macula, the center point being called the fovea. However, with the onset of COVID, virtually most ophthalmologists have stopped doing direct ophthalmoscopy, and we rely more now on slit lamp based examination, which keeps us a little away from the patients. The retinal circulation is unique because it does not have a sympathetic nerve supply and depends more on autoregulation, and we have a blood retinal barrier. So when the blood pressure goes up, there is an immediate vasospasm which constricts the arterioles. However, if it is chronic, over a period of time, these changes become into sclerosis and thickening of the muscle wall. Eventually, the muscle endothelial intima breaks off and there is a leakage of fluid into the vessel wall, causing necrosis and obliteration of lumen. So once the arterioles or the small arterioles are blocked, there is ischemia in the retina, and this leads to further consequences and leakage of fluid. So in the acute phase, or when there is early changes, you might just see arterial changes in the form of diffuse narrowing. However, when there are sclerotic changes, because the artery veins are in a common sheath, we start seeing AV changes or the arteriovenous crossing changes. Because of thickening of the wall of the arteriole, we also start seeing copper or silver wiring. And when there is ischemia, we start seeing exudative changes, which may be in the form of hard exudates, cotton wool spots, and in the malignant phase of hypertension, we see basically choroidal infarcts, and we may see disc edema. These patients, as I mentioned, are at risk of getting vascular occlusions in the eye, vitreous hemorrhage, and retinal detachment. The early classification of hypertensive retinopathy was given by Keith Wagner Barker and had 4 grades. The grade 1 was just arteriolar narrowing. The grade 2 had focal narrowing and AV crossing changes. The grade 3 had additional retinal hemorrhages, exudates, and cotton wool spots. And the grade 4 was papilledema. Because it's sometimes difficult to distinguish grade 1 and 2, it was simplified by Wong into 3 grades, the mild, moderate, and severe, where the mild grade basically indicates arteriolar changes and crossing changes. When you go to moderate, you start getting hemorrhages, cotton wool spots, hard exudates, and microaneurysms. And when you look at severe patients, of course, you get optic disc swelling. So this picture just shows you some of the common changes that we see, such as the disc, the vascular changes, and exudative changes. The very common question that comes to our mind is, should we be doing ophthalmoscopy or should we be doing photography for all patients or for patients who have hypertension? So this is a very common issue. So if you look at patients who have very mild forms of hypertensive retinopathy, we realize that the ophthalmoscopy is not very reliable. There can be subjective variability, and it does not provide us of any record of what the changes which are there. So it's not a very effective tool for picking up very mild changes. In contrast, a photography can give us objective evidence. It is highly reproducible, and it can help us to do a computerized analysis of the AV ratio, which can have a high sensitivity in picking up these mild changes. When you look at moderate retinopathy, where you have all these hemorrhages, exudates, and so on, the ophthalmoscope will definitely pick up most of these patients. However, the photography will have the additional advantage that serial photography can tell us what is happening over a period of time, whether the changes are improving or the changes are resolving, which we cannot document by any hand drawn diagram in our practice. Of course, with disc edema, the ophthalmoscope is unlikely to miss it. However, again, the photography can have advantages that you can pick up the extent of the disc edema and the changes in the disc appearance, which may occur over a period of time. So the photography definitely has a lot of advantages as compared to an ophthalmoscopy. And I think the mobile-based or the simple camera devices that are now available probably need to be used more often, not only by ophthalmologists, but I'm aware that even physicians have invested in some of these devices, which can give a good documentation. So just to show you a few pictures of, so the normal AV ratio is about 2:3, which is 67 or 65%. So you can see in some of these pictures that the AV ratio is showing that significant arterial attenuation, thin arterioles as compared to veins. So you can see that when you're doing an ophthalmoscopy, a quick glance, you're likely sometimes not to pick up these changes, or you might have a sort of variability. However, when you document and take a picture, you can even have a software to measure the diameters and compare and give you the AV ratio, which will be much more accurate and sensitive and specific. A few pictures of moderate retinopathy, which I said one cannot miss. For example, hemorrhages, exudates, and soft exudates. Severe retinopathy, you would see disc edema. Again, to note here is that as the condition progresses, the disc may change picture, and patients with chronic disc edema, might start showing disc pallor and optic atrophy. So these are again changes which can be very well documented if you have serial photography. Some of the other conditions that one may see in the eye in patients with hypertension, such as branch occlusions, branch retinal vein and branch retinal artery occlusions. We can see the central retinal artery occlusion with the cherry red spot, central venous occlusions. We can see diabetic retinopathy, as I mentioned, can progress very rapidly, and these patients are at high risk of developing complications in the eye. And we can also get optic neuropathy in patients who have hypertension. We understand that the retinal arterioles are anatomically and physiologically similar to those in the cerebral and the coronary circulation. So probably the target organ damage may be reflected by the retinal vasculature. And therefore, when studies have shown that when patients have mild grades of retinopathy, we see a moderate or a modest increase in the risk of stroke, coronary artery disease, and cognitive loss, whereas patients with moderate grades of retinopathy have a much higher and a stronger correlation with these morbidities. Of course, patients who have severe retinopathy are at a high risk of mortality. As an ophthalmologist, whenever we see a patient who has retinopathy, we normally would write a note to the physician so that they can take appropriate action looking at his overall global management. As a physician, I think if you have a mild hypertension with the patient, however, complaining of vision loss, headaches, and diabetes, probably best to refer them. And patients with more severe forms of hypertension and nephropathy also need a referral for ophthalmology to evaluate them. We understand that retinopathy may be an indication for starting antihypertensive treatment. It's not routinely done by all the physicians. However, it's important to refer because these patients probably require more aggressive management in view of higher risk of target organ damage and death. And I think in future, as ophthalmologists, probably we need to have more reliable and accurate ways of picking up mild hypertension changes in the very early phase. If we can take pictures and measure the arteriolar diameters, probably we can give much better feedback to the physician, who can then probably decide what is the best management for that given patient. And I think as ophthalmologists, probably we need to be looking at this. I think it's an area of not much interest among ophthalmologists. I think we need to pay more attention to this. And I think I come to know about this probably more often, that we will now look at this for patients with hypertension. Thank you all.
Thank you, Dr. Nikhil Gokhale. So he has given a crisp presentation. We'll go to renal evaluation by Dr. Sharad Sheth. Dr. Sharad Sheth, are you there?
Yes, yes.
Please share the slides.
Yes, yes. Yeah, just a minute. I'm sharing my.
No problem. Yeah, very much visual.
Visible? Am I audible?
Yeah, audible and visual.
Thank you very much, Dr. Mahapatra, and my chairpersons, special Dr. Bharat Shah. Hypertension renal evaluation. Kidney, this Arthur Guyton in 19th century told us that kidney is involved in genesis of any types of hypertension. So all forms of hypertension are ultimately consequence of resetting of pressure natriuresis relationship. Dr. V.T. Shah said that secondary hypertension, kidney is responsible almost in 95% of cases. But I feel that even primary hypertension, kidney is the main culprit. Because of this junk processed food that we eat, taking too much of sodium and less potassium, even primary hypertension, it is mandatory to do the renal checkup. And if you see here, a normal salt intake, okay, but the moment you take higher salt intake, the pressure natriuresis curve shifts to the right if you have a lesser number of nephrons. So right from beginning, if you are a premature child with oligonephrons you are born with, and then you develop metabolic syndrome where there is a deficit renal insufficiency, you tend to develop what is called as a salt-sensitive hypertension. So the renal checkup is absolute mandatory. So we know that hypertension in people without renal dysfunction also is around almost 50 to 60%. But when it comes to CKD, almost 90% have hypertension. The unfortunate thing is they are unaware of their deteriorating kidney condition. And to assess the renal function right in the beginning or screen them for that is very important to prevent further progression of deterioration of renal function. So hypertension, we all know, is a strong independent risk factor for ESRD, and patients with CKD develop hypertension much earlier during the disease, and which leads to further worsening of the renal dysfunction and cardiovascular morbidity and mortality. So hypertension prevalence in different stages of CKD, from stage 4 to 5, it's almost 84% to 90% of them are hypertensive. So it goes like that. The systemic hypertension leads to intraglomerular hyperfiltration and hypertension, leading to nephrosclerosis and loss of renal function. The common two problems, diabetic and hypertensive, this exactly happens. The efferent arteriole vasodilates, especially this happens in diabetics because of tubuloglomerular feedback, because SGLT2 will reabsorb all glucose and sodium. So lesser sodium will reach the macula densa, and that will dilate the efferent arteriole. So blood entering the glomerulus is at much more the higher pressure. And at the same time, because of angiotensin 2, there is efferent arterial vasoconstriction. So both these factors leading to intraglomerular hypertension and microalbuminuria. So way back in 2006 and 5, people have said, again, that urinary albumin excretion is a predictor of development of hypertension. Let it be primary or secondary. So low-grade albuminuria is risk of hypertension and blood pressure elevation. 1 in 3 diabetics have hypertension, 1 in 5 hypertensives have CKD. The CKD, just to summarize, how do we diagnose CKD? More than 3 months abnormality of renal structure or function, meaning either urinary abnormalities or radiological abnormalities, proteinuria more than 30, albuminuria more than 30 milligram per gram, or GFR less than 60 ml per minute. We diagnose as CKD. We classify them into 5 stages according to the GFR and proteinuria. And this is a very classical heat map, shows that the green is a low risk, yellow is a moderate risk, orange is a high risk, and red is a very high risk. The nephrologists normally don't depend on very high-fi investigations. We just need to check blood pressure, and as my previous speakers have said, the home blood pressure measurement is more important. Ambulatory blood pressure measurement is second most important, and we look for eGFR and for proteinuria. So the lower eGFR is, the previous speakers have again said, is associated with resistant or refractory hypertension requiring 3 or more or sometimes even 5 antihypertensive drugs to get the BP under control. There is almost 30 to 40% incidence of masked hypertension, and the nocturnal drop of blood pressure, as Dr. Ponda has said, is not there in CKD. In fact, there is a reverse elevation of nighttime blood pressure values. Again, the previous speakers have made my job much easier. So when it comes to hypertension and kidneys, we got to just monitor eGFR, microalbuminuria, and Dr. Vitisha has again highlighted electrolyte, importance of seeing electrolytes, because potassium hypokalemia may be an indicator of endocrine disorder or a renal dysfunction. The common, again, Dr. Vitisha has enumerated all of them: glomerulopathy, tubulointerstitial, polycystic kidney disease, renovascular hypertension. This is a very crucial slide. How chronic hypertension leads to CKD through 2 major pathways. Chronic hypertension damages preglomerular arteries and arterioles that stimulate glomerular ischemia. Similar to what my previous speaker Nikhil Gokhale said in eye, what happens to the eye? Same thing happens to the kidney. So this glomerular ischemia leads to progressive luminal narrowing and a reduction in glomerular blood flow. Chronic hypertension contributes to loss of autoregulation of efferent arteriole with subsequent transmission of high systemic blood pressure to the glomeruli. This leads to hyperperfusion, hyperfiltration, which leads to structural glomerulosclerosis and progressive loss of renal function. Again, the story is complicated, whether chicken or egg story. hypertension has been recognized as a major factor responsible for decline in kidney function in patients with diabetic and non-diabetic kidney disease. On the other hand, among patients with CKD, high blood pressure may develop early during the course of disease and contribute to adverse outcomes. This is a very popular slide again. JNC said that we all lose around 0.75 to 1 ml of GFR every year. But if the pressure is uncontrolled, we may lose almost as much as 10 to 12 ml of GFR every year. So this kidney has a protective device at the level of efferent arteriole. If there is increased perfusion pressure, efferent arteriole vasoconstricts. If there's a decreased pressure, like all our ICU patients, the efferent arteriole vasodilates to maintain the GFR. So this is called renal autoregulation and maintained by efferent arteriole. But when that fails, the systemic hypertension transmitted into the intraglomerular hypertension leads to loss of nephrons, further loss of nephrons, and this is how the renal damage continues. As we can see here, the primary hypertension usually behaves like a benign nephrostenosis. For years together, it does not produce much of a renal damage. Only when it grows into a malignant nephrostenosis that the renal damage is exacerbated. But in CKD, the slope is very steep right from beginning. So the deleterious effects are observed with even mild to moderate blood pressure elevation in CKD patients. So hypertension is closely associated with progressive kidney dysfunction by glomerulosclerosis and by chronic hypoxia leading to tubulointerstitial fibrosis. So the deadly duo is obviously the diabetes and hypertension, and of course other renal glomerular disease, polycystic kidney disease. So now coming to my today's talk, basically the early screening and intervention is very crucial because it will retard further progression of kidney disease. So all those hypertensive patients, especially beyond 50 years of age, with low baseline eGFR, prematurely born with metabolic syndrome, presence of obesity, diabetes, and family history of kidney disorder or cardiovascular disease are likely to be more vigorously screened for renal dysfunction. And the different markers are, of course, urinary abnormalities. Simple thing by dipstick method, we can see proteinuria or RBCs or leukocytes. Then urine sediment abnormalities, electrolyte and other abnormalities for tubular disorders, imaging abnormalities, and very rarely we resort to kidney biopsy just to diagnose hypertensive nephrostenosis. This is very, very rare. So the early screening and intervention may retard the progression of kidney disease. So again, I summarize again, more than 50 years, diabetes, metabolic syndrome, urinary stones, urinary infections, hyperlipidemia, history of anemia. Many a times anemia, the clue that it is of renal origin is unknown till the case is referred to gastroenterologists and scopies are done and referred to hematologists. And finally, we conclude that it was all because of CKD. Family history of CKD and smoking. See, reverse is true in hypertension. Dr. B.T. Shah has said this is because of salt and volume overload or sympathetic overactivity, renin, angiotensin, aldosterone system elevation, hyperfunctioning, or tubular handling of sodium, potassium, or gain and function monogenic disorders of kidney. So this was a very popular study, that chronic renal insufficiency cohort study showed that almost 85 to 0.7% of CKD patients had hypertension. The simple thing what we nephrologists do now is we don't ask for 24 hours urinary protein excretion because it is messy and gives a wrong reading. So we do albumin creatine ratio. It is now categorized as 30 to 300 and more than 300. 10 is a normal level in normal person. 10 to 30 is mild, 30 to 300 is moderate, and more than 300 is high albumin creatine ratio. The creatinine assists in so that the albumin levels, which would vary with the urine concentration, that problem is obviated when we do albumin creatinine ratio. This microalbuminuria terminology is given up now, mild, moderate, and severe. Then creatinine is an insensitive marker of renal impairment. We all know that till 60% of renal dysfunction occurs, the creatinine remains normal. So we go for this eGFR calculation, and now we have this calculator, this formula. It is on the palm top or laptop. You just feed this formula, and it varies according to the age, sex, body size, and it declines with age. These are very popular formulas, Cochrane and Gold, for dosing of medications we can do on the bedside level. But the most important now is CKD AP formula, which not only utilizes creatinine, but also cystatin in this formula. So as you see, glomerular filtration rate categories worsens as you have worsening of hypertension. More severe or malignant hypertension as a severe renal dysfunction. Now this albumin creatinine ratio and eGFR should be measured while managing these cases also with antihypertensive treatment. So both ways, for diagnosis and during management. Abdominal ultrasound and duplex for renovascular hypertension, for renal sizes, for polycystic kidneys is very crucial, important. So eventually it boils down to urine albumin creatinine ratio, eGFR, and sonography or Doppler study of the kidney. Only cases which have less than 30, that is CKD stage 4 or acute kidney injury or very abnormal urinary sediments or hypertension which is refractory to treatment should be referred to nephrologist. So to conclude, friends, the simple tests like blood pressure measurement, serum creatinine, eGFR, albumin creatinine ratio, and blood electrolytes would suffice, but it should be repeated at least annually. A single reading is not important. We have to do it, at least check it at least 3 times in a year. So hypertension is most common comorbidity in patients with CKD, almost affecting 92% of patients. Prevalence of hypertension increases with declining renal function. Control of hypertension is a major priority in management of CKD because it would slow down further progression of renal dysfunction and would reduce cardiovascular morbidity and mortality. So elevated blood pressure can occur as a result of CKD and also as a potent risk factor for CKD progression. Thank you very much for your kind listening.
Thank you, Dr. Sharad Shah, for highlighting the renal evaluation. Very much he has highlighted. And also I want to put forth some more points. There is also a recent study that is a crosstalk existing between tubular epithelial cells and glomerular endothelial cells. So we must point more towards that also. And also not only microalbuminuria, albuminuria are the true biomarkers. The latest terminology, as he has pointed out, increased urine albumin excretion. There are also new biomarkers. One is trans erythropoietin, another is zinc alpha glycoprotein. They are also remain to be validated very much. And over to my colleagues, that is co-chairpersons, anything comment? And there is only one question in the chat box. First, we will address that and we will go on to the chairperson's discussion.
I think it's very important.
Hypertension guidelines tend to be country population specific. The extrapolation can be erratic. My comment by Professor M.E. Elolkar. Over to the speaker who spoke on guidelines. Please comment on it. Or Dr. Sharma or Shah. Anyone, please share your view.
I would again like to bring out the fact that in these guidelines often don't make any meaning for elderly patients. And I'm sure all of you must be seeing some patients who have severe systolic hypertension, and it is just difficult to bring it to what the guidelines are suggesting. And not only they have systolic hypertension, but they have low diastolic. So most of them have pressures like 180, 190, 200 systolic, and diastolic is 60. I don't know how we can achieve an improvement in their blood pressure when the readings are like this. These patients also have a postural fall, so that makes it difficult to achieve a control because most of the readings that we take are in sitting position.
Yeah, this is very important. In fact, in elderly, the exact value as well as control. But one thing we have noticed since long, the comorbid diseases, when there is a low hematocrit, the blood pressure is higher, hyperdynamic state, tachycardia is there. When you improve their hemoglobin, the tachycardia settles, the HB also settles. So cardiac output, peripheral vascular resistance, systemic vascular resistance, all change. So it has never been kept in that way. Our practice in PGI is that we always raise hemoglobin along with treating hypertension or comorbid diseases cardiac. So with that, settling of heart rate and BP becomes easy. So that is a new, you can say, dimension to the elderly as well as to the general population also.
I would like to re-emphasize the point made by Dr. Sarath said that every hypertensive patient has...
Things are done by the American and European countries, and many countries are based upon the requirement of the population and the economic implications of that in that particular country. This is what I feel. And therefore, these cutoff values in some countries where it is possible for them to afford further medications, they would give that. Other countries, they would not give, saying that it would be too expensive to include 6 million extra cases of hypertension. So I think these guidelines are also motivated according to the economic implications. As far as we are considered in private practice, I think we should do the best for our patients. And even if we take 30/80 as per our Indian guidelines, that would be much more beneficial for our patients.
Okay, one more question in the chat box. Which arm is the best way of measuring blood pressure?
The lower one, the one which gives you the lower blood pressure.
Right arm or left arm? They have asked.
Anyone.
Okay, well and good. Dr. Nikhil Gokhale, you have spoken very good. That is pathology and progression of retinopathy. That is three important aspects: the absence of sympathetic nerve supply, and second one is auto-regulation of blood flow, and third is your presence of, that is, blood retinal barrier. So what's your opinion on vascular endothelial factors, anti-VEGF, especially the curcumin that is manufactured by turmeric? The ladies used to apply. What's your carry home message on it? Nikhil Gokhale, please.
Yeah, I'm not very much aware about turmeric with regard to eye patients. Actually, I'm not really aware. But when you mentioned about VEGF, we are using anti-VEGF agents quite extensively now in ophthalmology. We use bevacizumab, and multiple other drugs are being used in patients who have diabetic retinopathy and vascular occlusion. So these drugs are used extensively. I have no personal experience, or I don't come across about curcumin. If I think our medicine colleagues might be able to probably answer better. I am not aware, sir.
Yeah, it is gaining momentum. The curcumin is the best anti-vascular endothelial growth factor that is being manufactured by the turmeric. That is why the ladies in our area, they used to rub this turmeric very well. I think Dr. Asha Murthy will agree very well. Thank you.
Yeah, thank you.
So any more questions?
Okay, so we'll go to the next session. Thank you very much to all the chairperson, Professor Dr. Y.P. Sharma, Dr. Raj Sekar, and Dr. Bharat Shah for conducting so well the session. So we'll go to the next session. In hypertension, without imaging, without evidence-based modality, nothing is completed. It is halfway. So imaging plays a big role, especially in secondary hypertension or in endocrine hypertension. So in this context, I would call upon Dr. Rakesh Gupta, who is a leading echocardiologist in India, and he's the director, Jorop Healthcare Private Limited, and a senior consultant cardiologist from Delhi, Dr. Rakesh Gupta. Then I would call upon Dr. Asha Murthy. He is a professor and head of SRMS Institute of Medical Sciences. She's an interventional cardiologist, and also in Westminster Hospital as an interventional cardiologist. Then Dr. Priya Jagia, he's a professor of cardiac imaging from All India Institute of Medical Science, Delhi. And lastly, Dr. Consultant in Tamil Nadu Multi-Speciality Hospital in Chennai. He's a senior consultant and chief of nuclear medicine department. And also he is the chairman of the Chennai Physicians Society. So with this, I would hand over to the chairperson to conduct the session. Thank you.
Good morning. I'm Dr. Asha Murthy from Chennai. And good morning to all my chairpersons and all the delegates who are attending this conference. Can you hear me, sir? Am I audible?
Yes, we can hear you. We can hear you.
Okay, fine. Yeah. First of all, I'd like to thank Dr. Mahapatra, Dr. P.C. Manoria for giving me this wonderful opportunity and the organizing team members from WCCIC for chairing this important session on imaging in the hypertension. And as you know that there are eminent speakers in this imaging in hypertension. And as you know, the diagnostic evaluation of the cardiac diseases has become one of the very advanced with the advent of CT, and it becomes an indispensable armamentarium of currently imaging available modalities. So the first speaker is Dr. Mona Bhatia, and she is going to speak on role of CT in the evaluation of coronaries, aorta, and renal arteries. Over to Dr. Mona Bhatia without wasting the time.
Thank you so much. I'm audible?
Yeah, you're audible.
Okay. So thank you, Dr. Mahapatra. And it's truly a pleasure to be here. As always, you've put together a great conference, and hypertension particularly is so important nowadays. So I'm going to go on to my topic, which is the role of CT in evaluation of the coronaries, aorta, and the renal arteries. So arterial hypertension, we know it is one of the largest proportion of cardiovascular mortalities worldwide that is accounted for by hypertension. And in fact, the AHA has said that 77% of patients with first stroke, 69% with first heart attack, and 74% with heart failure have a BP over 140/90. There is a substantial variation in the cardiovascular risk among hypertensive patients, and the European Society of Hypertension and the ESC recommend risk stratification of every hypertensive patient. And the heart, we know, is an important target organ of systemic hypertension. While LV hypertrophy may be well seen together with LA dilatation on the CT, there are a few features that are better seen on both echo and MR. So let's start with the cardiac CT, which is my topic. So if we look at the impact of hypertension, it's not only on the myocardium, but also on the coronaries, and atherosclerosis and downstream ischemic heart disease is what we're looking for, because hypertension is one of the major risk factors when we're looking at ischemic heart disease. Starting with risk stratification, we know the first step of a cardiac CT is the calcium score, and coronary calcium is not an aging phenomena and occurs exclusively in the atherosclerotic arteries. The calcium score is an automated software. It gives us the distribution, density, weighting, and size of the coronary calcification. And in fact, it is superior in predicting cardiac events in asymptomatic women, men, and diabetics over the Framingham risk score. This is irrespective of ethnicity or color, and irrespective of the burden of dyslipidemia, and regardless of how dyslipidemia is defined. Going on to guiding management in these hypertensive who do land up with coronary or epicardial disease, we know that the spectrum of disease can be all the way from normal to severe and critical disease. And while at one end of the spectrum, we don't need to send the patient to the cath, but at the other end, we want an urgent cath. And so we want the chosen test to be one that can reliably rule out coronary artery disease at one end. And at the other end, we want to have a very accurate diagnosis for extent, severity, anatomical, and flow limiting lesions. As far as ruling out coronary artery disease, we know the diagnostic performance of coronary CTA is outstanding. And if you have coronaries that look like this, you have a negative predictive value, which is over 99%. CTA is also reliable to detect the diseased coronaries. And in this patient who's 42 years, hypertensive, but non-smoker, non-diabetic, and is an intermediate pretest probability, can CTA actually even have an incremental benefit over the gold standard ICA? The coronary CTA demonstrated that there was a significant LCX stenosis and a plaque in the RCA. The patient was referred to PCI, and you can see that between the CT and the ICA, there is excellent concordance as far as stenosis detection is concerned. And so in detection of the culprit lesion, both modalities are excellent. Compared to all other non-invasive modalities for detection of coronary stenosis, CTA is better for detection and exclusion of obstructive coronary artery disease. But finally, what we're really looking for are plaques, because plaque rupture accounts for 70% of the fatal acute myocardial infarctions. And what we want to know is which is the vulnerable plaque. A vulnerable plaque, as was seen in this patient, is a low attenuation lipid-rich intraplaque core with a positively remodeled plaque with spotty calcification, a napkin ring sign, and they also show serial progression if you do subsequent CTs. Disadvantage of CAG is that while it is the gold standard for evaluating the coronary lumen, it's only a luminography, whereas with the CTA, what we see is the stenosis and the cause of stenosis. So it's actually luminography and more. And the atherosclerotic plaque actually predicts better than clinical findings and stenosis. Further, beyond just looking at the epicardial vessels, in the management of ischemic heart disease, and particularly in these patients who are hypertensive and come in for evaluation, we want a hybrid imaging, and CT has the advantage because it can not only look at the anatomical evaluation of the coronaries, but also the functional evaluation to understand the impact of stenosis in terms of ischemia, infarction, LV function. And CT allows both static and dynamic evaluation to look for myocardial perfusion, for the detection of a perfusion defect. And then we can do stress and rest CT perfusions. So we can have very similar findings if we're looking at a complete reversible ischemia, as in this case, or whether it's a non-reversible in the presence of a scar. So combining a CTA with a CTP actually has incremental benefit, and the accuracy rises to almost 95% with a negative predictive value of 100%, a sensitivity of 100%. Recent advances also allow CT-FFR to be evaluated, where we can have calculation of the non-invasive 3D FFR of the entire coronary bed from a typically acquired CCTA. And in fact, the FFR CT is superior to all other non-invasive modalities for lesion-specific ischemia. Last but not the least is predicting outcome. And like I said, while LV hypertrophy, even myocardial fibrosis, if you do a dual energy delayed scan and left atrial dilatation, can all be evaluated on the CT. Besides, CT also looks at regional global LV function for long-term prognosis, besides evaluating wall thickness, perfusion defects, and delayed enhancements. So CT is your potential one-stop shop for imaging in hypertension and in subsequent downstream ischemic heart disease. Now, we know hypertension impacts the arteries, and in particular, the aorta is most frequently affected. The need is to have a comprehensive assessment of the aorta. We want to have plaque assessment for quantification of plaque volume. We also want to look for aortic wall syndromes, which are a constellation of life-threatening diseases. And there are other complications such as cerebrovascular, arterioembolic disease, retinal, renal complications. The hypertensive aortic disease may manifest as a catastrophic emergency, and their time becomes critical, and optimal management requires a very prompt and accurate diagnosis. In the diagnosis of aortic pathologies, what we have is we have a large number of imaging tools from echocardiography, MR, angio-TE, but CT today is the modality of choice. The reason being it's a very large volume coverage, a short acquisition time, a high spatial resolution, thin slices with homogeneous contrast enhancement and isometric acquisition, which allows post-processing of source images. The protocol used is a gated study of the thoracic aorta and a non-gated study of the abdominal aorta. And then you want to make sure that you measure it in systole, because differences come between systole and diastole. Again, how do you measure? The 2010 guidelines talk about the aortic diameter between external surfaces to avoid the confounding by intra-aortic thrombus or atheromas. And oblique imaging can overestimate the aortic dimension, so it's really important that the center lines are properly drawn. The aortic root can be assessed, and you need a true double oblique plane in order to evaluate not only the annulus, but the sinus of Valsalva, the sinotubular junctions, the ascending aorta, and the relationship to the aortic root. Thoraco-abdominal aorta all the way to the iliofemorals can be assessed very clearly in the presence of hypertension, and particularly in these patients where you're looking for aortic aneurysms. The upper limit of normal for aortic dimensions is as follows. So I'm not going to go into it, but yes, we have to look at when they exceed this. The acute aortic syndrome is a gamut of conditions. We're talking about aortic dissections, intramural hematomas, penetrating aortic ulcers, and ruptured aneurysms. And some of these can be really life-threatening. So when we're talking about the acute aortic dissections, CT is the modality of choice because of its high diagnostic accuracy, almost in the range of 90 to 100%. We can see the evaluation of the entire aorta and its branches with the flap, the entry, the re-entry, extension to branch vessels, end organ ischemia, and extravasation. So we have classifications, which could be the Stanford classification, which type A involving the ascending and descending, or type B, which involves only the descending. The DeBakey classification is also there. Here you can see a Stanford type A, where involvement of the ascending aorta is seen. You can see the dissection flap, the true and the false lumen. The entry tear is delineated very well on CT. This is a type B dissection, where you can see it's just distal to the left subclavian. And it's also important to differentiate the true and the false lumen. And this is very easily done on CT, where the true lumen is invariably smaller. The origin of the visceral arteries most frequently comes from the true lumen. It has a faster flow and is surrounded by calcifications. Secondary complications include hemopericardium. Then you can have malperfusion of the coronaries, the cerebral, the visceral, abdominal, or limb vessels. So here you can see there's a Stanford type A dissection with the left coronary involvement. Intramural hematomas and the penetrating aortic ulcers need to undergo serial imaging, because they may show regression, progression to dissection, aneurysm, or persistence. So it's really important to keep watching them very closely. This is a type A intramural hematoma with a penetrating ulcer. Aortic aneurysms are also well known in hypertensives, and these are permanent focal dilatations of an artery having a more than 50% increase in diameter, while The fusiform aneurysms is what we usually see, but saccular aneurysms may exist in the event of fungal infections and various other causes. Abdominal aortic aneurysms, again, the annual
Dr. Mona Bhatia, please 1 minute more.
Is related to the diameter. And so you need to know when to treat and when to watch. And then you need to look at what is the diameter. EVAR is an accepted alternative to open surgical repair, and pre-op evaluation involves a very detailed study in order to make sure that you have success of the EVAR. A renovascular hypertension is basically a secondary cause of hypertension. You may have causes such as a renal artery stenosis. You may have fibromuscular dysplasia, which is frequently seen in the mid to distal portion of the renal artery. You may have renal artery dissection, which is the majority are extensions of the aortic dissection, and these are isolated renal dissections where complications of endovascular procedures or blunt abdominal trauma may exist. Obstruction can be dynamic within the renal arteries, particularly if you have a dissection. So here you have a dynamic renal artery stenosis, where between the systolic and diastolic, you can see how the flap actually enters the renal artery. Life-threatening complications include organ ischemia. Here, the right kidney shows malperfusion, and in the one to the right, you can see malperfusion in the left kidney. So these also need to be evaluated. The page kidney refers to a systemic hypertension secondary to extrinsic compression of the kidney by a subcapsular collection, like a hematoma, seroma, or urinoma, and compression of the renal arteries, either major or microvascular arteries, leads to renal hypoperfusion with release of the renin. So the diagnosis again here depends on CT for improved resolution for imaging of small subcapsular hematomas and retroperitoneum. So finally, all I'd like to say is the CT has a significant role in the evaluation of the coronaries, aorta, and the renal arteries in hypertensive cardiovascular evaluation. Thank you so much for your patient listening.
Thank you, Dr. Mona. Can you hear me?
Yes, I can.
Yeah. Thank you for your very excellent presentation and a very crisp one covering the large aspect of the topic on coronaries and aorta. And you gave us a very important message that hypertension represents one of the largest proportion of impact on the cardiovascular, renovascular, and cerebrovascular. And also by CT coronary, you mentioned that calcium score, which is found to be superior in assessing the event rate. And also by CT coronary, we can assess the vulnerable plaque by the low attenuation rich core with positive remodeling, and one-stop shop in hypertension with a high spatial resolution. And also you gave immense knowledge about the aortic pathologies, about the dissections and the aortic diseases. So I will...
good morning, sir.
Yeah.
Am I audible, sir?
Yeah.
Yes, Dr. Prabhu.
Hello.
Yes, Dr. Prabhu.
Yes, you're audible, Dr. Prabhu. Good morning.
Hello, am I audible?
Yes, you're audible.
Warm welcome to all the senior faculties. In fact, I take pleasure in inviting Professor Sanjay Gambhir, a very renowned nuclear medicine physician and our good friend from SGPGI Lucknow. Dr. Sanjay Gambhir is going to speak to us about the captopril renograms. I request Dr. Sanjay Gambhir to go ahead with today's presentation, sir.
Good morning to everybody, chairpersons, WCC, ICC for the kind invitation. Can you yet see my slides?
Yes.
Not yet, sir.
All right.
Yeah. Now we can see your slides, sir.
Okay. Good morning. The role I've been given this morning is to talk about the captopril renal scintigraphy in evaluation, the renovascular hypertension. As the earlier speakers have talked enough about it, Dr. V.T. Shah gave a long list of various causes of hypertension, including renovascular hypertension, secondary hypertension, and renovascular hypertension consists 1 to 2% of that group. So overall, a very small group of patients, but a very important one, because there is a scope, as earlier studies have shown, possibility of better controlling and offering something to these patients. So the underlying pathophysiology has been discussed, and basically the renin-angiotensin aldosterone pathway is the main pathway which is thought to be activated coming into the play to cause the post-stenotic dilatation in the renal artery, so that the pressure head is maintained and the GFR is maintained in the kidney once there is a stenosis in the renal artery and the fall in GFR. So there is a compensation. So there it could be on the one side, one kidney artery stenosis, or on the both sides, as in aortoarteritis. Sometimes we see that scenario in young adults. So pathophysiology is very important because this test or this the diagnostic tool which we use in nuclear medicine to help with labeling the patient is based on the changing pathophysiology of the disease, which though is not as simple as that, and it is now known that there are many pathways which come into play and not only the renin-angiotensin aldosterone pathway. Nevertheless, so angiotensin 1 conversion into angiotensin 2, mediated by ACE, and the downway, the cascade is what has been talked: vasoconstriction, sodium retention, aldosterone secretion, and even the sympathetic nerve system activity, and end organ damage on the myocardium, renal, wherever the end. So it's usually part of the systemic disease, and renal artery may be the culprit. So we're looking at and trying to find that if we can nail that and help this small group of patients. So screening for the renovascular hypertension, that's where our role comes in. And screening has been discussed. So which are the patients where you really suspect, sudden change in the controlled blood pressure, young adults coming first time, unilateral small kidney, and impairment of renal function to ACE inhibitors. That is another indication which nephrologists notice, and they suspect, okay, the renal artery may be involved. So how to go about, and there are many tests. Mona just talked about the CT, and we are going to listen about the MRA also. So as most of you are from cardiology or general physician or our imaging friends, we talk about the scenario in the cardiology, where we look for coronary artery involvement, stenosis with our myocardial perfusion test, and also by the coronary angiography or CT angiography. The scenario comes, we are looking for a for sure sign and symptom or with imaging that yes, the artery is stenosis, and in this particular patient can be helped by dilating or intervening. But there are issues. What has been found till now by the study is that there is no one-to-one causal correlation between the stenosis and the renal vascular hypertension. So that is the main problem. But still, it's a significant finding if one finds a stenosis in a sudden onset or uncontrolled or malignant hypertension young patient. One would like to look for the remedial causes which can help the young patient lead a normal life. So after taking the history, and some people do the Doppler, most of the time that's what is now being done, Doppler MRC study, and the DTP and DMSA studies also come along with that as a screening tool. And with the clinical history and blood pressure, you can increase the suspicion to more than 99 percentile if one of these tests comes positive in the screening. And then you can go for the anatomical tool to really nail whether it's a segmental artery involved or it is the main artery. And along with that, the other ratios which were earlier mentioned by the nephrologist, and from that you can make out that the one or both the arteries are involved. So how the schema works is different from place to place, but as I was mentioning the case of our nuclear cardiology, when we are looking for the significance of the stenosis, and specifically in a moderate stenosis, 50 to 70%, block on our angiographic or CT where we are doubtful whether the intervention would help. We go for the medical treatment or we go for the intervention. Exactly the same issue arises here. In the moderate one, that renal efficiency or obesity is there, then you can, go for drugs. And obesity, no renal efficiency, it is being proposed that captopril renography can help. If it's negative, you observe or put on drugs, continue your drug combination. And if it comes positive, that means it puts the patient in high probability group for the renal vascular hypertension. Then you can go for the MRA. So as shown in the earlier slide and this one, some people would like to do is use it as a screening tool upfront. As soon as patient comes, test dates are available, they will ask for any of these non-invasive tests, including the DTPA and DMSA, and other would really first find that there is a moderate, stenosis, and then they would go and look for the significance of this moderate stenosis by doing the captopril renography. So the mechanism is well known. The renin-angiotensin system is activated. So what we do is we just give the captopril to block that compensatory mechanism, and while doing that, we do our DTPA or MAG3 scan pre and post captopril. So 2 studies are basically done, and the change in the renal functional parameter of perfusion and parenchymal uptake and the clearance from the parenchyma are observed, which are very clearly seen on our imaging studies. And these are very old studies and have been going for quite some time. So one can either use captopril or now enalapril can also be used, injectable one, and there are advantage and disadvantage of it. So once we do that, we categorize the patient into the high probability unilateral deterioration in the renogram. That is high probability, and it can be done by MAG3 or DTPA, intermediate probability. So there are definitions how we categorize this into the high probability, intermediate, and low probability. So it's the high probability group probably which is going to be helped by the intervention. Though, as I said right in the beginning, the causal relationship between the stenosis and the hypertension is not there. So that's why the additional studies are required to find the functionality of that stenosis, that it is a functional stenosis, that the pathophysiology which has changed, and if it can be resolved, will the patient be helped? And as I said repeatedly, one-to-one relation is not there, but still there is a possibility, as studies where this intervention has been done and seen which are the patients which are helped. So these are the groups which have come up. So renogram standard, the zero curve is normal. So which sees change in the peak or flattening of the curve. There are technical parameters. When we say post captopril, the renogram has deteriorated. That means when we call the dilatation of the post stenotic dilatation and the pressure head falls, and which we are causing artificially with captopril or enalapril. So the pressure head falls and the renal function deteriorates. So that is an evidence that there is, yes, a functional significant stenosis of the renal artery. Along with that, there is another thing which is we call the aspirin renography. Very few studies are there. The pathway is through the prostaglandin system, which also gets activated, which was mentioned in one of the slides of Dr. Sharad Seth also. So more than one mechanism can be there. So we have tried this and it works quite well as captopril. So you can choose one of these. Exercise renography is there. So a subpopulation of nephron can be different. Again, Dr. Seth mentioned it. So you have to tease out what is the basic pathophysiological functional thing going around the stenosis, and then accordingly tailor your treatment. So when we come, various landmark trials have been done in stenosis, and basically ACC, HA guidelines have come, and the benefit of revascularization with stenosis. So all have been criticized for not including the high enough patient of the right category. So these trials are very difficult to do. So at the best, what we can draw is a very light conclusion from that. And therefore, the DTPS scan is still very much valid. Either you add it as a screening tool or you add it later once you have confirmed the renal artery stenosis, and now you want to find the functionality. So the comparison of various tools, that's a very big discussion, which one is better and not. The ultimate aim is will the patient get better by intervention, which is that golden test which tells us. So there is no golden test basically which gives us 100% or much higher level than the other, that intervention in this particular group of patient will work. 2014, there is a consensus report on renal vascular by the nuclear medicine groups. Many studies were included, and they said captopril works well, though the specificity, there is a wide, broad range. So it might not work in all patients. So that is a caveat which one has to keep in mind, but it works well. So if you add it to your anatomical screening, after anatomical screening or before, so in combination, both of them will give you better hold and better results. So when and how to revascularize? So again, using anatomical and functional modality is better. Various guidelines are there, European and all. Usually they mention like the captopril renography is not a screening tool, but there are other voices also, and the area is open because there is not a well-known causal relationship between stenosis and the renovascular hypertension. So at the end, I would summarize by saying that the patient with hypertension who have a functional significant renal artery stenosis and who would benefit from revascularization can be helped by the captopril vascular renography, and that subsegment of patient can be teased out along with the help of anatomical imaging. Thank you.
Thank you, Dr. Sanjay Gambhir, for a wonderful lecture on renal vascular hypertension and the role of captopril radiogram. I feel that this is still a grossly underutilized modality, despite there are several institutions which are having this facility. And we'll be having the discussion toward the end of this session. We now invite our next presenter, Dr. Sanjay Vishamitra from Sathya Sai Institute of Higher Medical Sciences. Dr. Sanjay Vishamitra will be sharing his knowledge about MRI in renal vascular hypertension. Dr. Sanjay, please, sir. I think Dr. Sanjay Vishamitra.
Can you hear me now? And can you see
yes,
my
sir.
presentation screen?
Yes, sir, please.
Thank you. So my topic is to talk on MRI in renovascular hypertension. And my aim is, I have no disclosures, and my aim is to review, sorry, 1 second, is to review one case to show you how we use MRI in renovascular hypertension, discuss and compare some of the differences and advantages or disadvantages of contrast enhanced and non-contrast MRI angiogram, and look at some new insights in evaluating the kidney in renal artery stenosis, and also suggest that the kidney is not the only thing that one can look at with MRI, and one needs to look at other regions as well. So let's look at renovascular hypertension. We've discussed this in great detail in this session. It's obviously 1 to 5% of all the patients with hypertension will have renovascular hypertension, and our aim, therefore, is to use modalities which can evaluate it. MRI has no radiation, gives you good 3D reconstructions. Non-contrast imaging is an option for those with poor renal function. Disadvantages, of course, is that it takes longer examination. There are certain contraindications and contraindications to MRI as well. It's more expensive and certainly not as portable as ultrasound. Here is a 71-year-old female who came to us with a past medical history of type 2 diabetes, hypertension, hyperlipidemias, congestive failure, had a history of pulmonary embolism and Eliquis, and was found to have hypertensive emergencies. Very difficult to control hypertension. Her hypertension started in her late 20s, when she was 20 years, in her late 20s in her age. She was already on multiple blockers and multiple treatment of hypertension, and the ED added 2 more antihypertensive medications, as you can see. So she came to us for MR angiogram, and the first thing that you visualize is the fact that the left kidney, which has a very nice appearance to it, compared to the right kidney, which has cystic changes and is clearly also smaller than the left kidney. The MR angiogram is performed in a dynamic manner, and what you're seeing here is the aorta, the renal vein to the left side, and the left renal artery. The left renal artery, as you can see here, has a normal caliber to it. The right renal artery was actually somewhat difficult because it was small to begin with, but you can also see that there is an area of stenosis at its origin, an ostial stenosis. We can then do 3D reconstructions to evaluate, to visualize that area better. And this is the left renal artery showing a very nice normal caliber through its entire course. And you can see the right renal artery has an area of narrowing as compared to the distal right renal artery. This patient then went in for an angiogram where they basically noted that we had some very focal narrowing at the area of stenosis, had a relatively longer segment, which was perhaps 50 to 70%, to the area of significant stenosis was at least 70% plus. Patient then went in for a stenting through that particular region. So the first question that we have that I hope I've shown you is that MR angiogram can evaluate the presence of renal artery stenosis. And as you heard from the previous speaker, Dr. Gambhir, he showed us a very nice flow chart where MR angiography can be utilized. So why not CT angiography in these patients? This is the same patient, the eGFR from 30 to 70, and you can see that there was a varying amount of varying eGFR in this patient, but you can see the dip at the date where the patient got her interventional angiography for catheterization. So this patient had a short episode of acute kidney disease, and this is one of the problems we have with intravenous contrast administration, which is why MR perhaps stands a slightly better role in patients with chronic kidney disease. Can phase contrast be MR be used? We used to use it back in 2006 and 2007 when I was a young imager at that time. Phase contrast MR is very similar to Doppler imaging. So if you just think about Doppler imaging and you can think about the jet phenomenon or the dephasing that one we get on MR in that particular area, you can basically imagine how phase contrast MR can add to the presence of the visualization of stenosis in calling something as significant or not significant. Of late, however, we do not use phase contrast MR angiography. The contrast MR angiography, the ability to give high quality imaging is sufficient for most of us to give an accurate estimation of 50 to 70 or greater than 70%. Usually about 50% and plus is something which we are very confident about reviewing. This is an example of a normal patient with a 3D angiogram. And this is a different patient where you can see the beaded appearance that has already been shown by other speakers of the left renal artery in a patient who's got fibromuscular dysplasia. So we can evaluate FMD as well. This is the same patient shown with occlusion on the left side, a different patient, sorry, shown with occlusion on the left side, a beaded appearance on the right side. And one can evaluate not only for atherosclerotic proximal disease, but one can also evaluate for other causes such as vasculitis and for FMD. So let us look at the sensitivity and specificity of the imaging modality of MR in the evaluation for atherosclerotic disease and in the evaluation for FMD and vasculitis. So the sensitivity and specificity for atherosclerotic disease has been found to be consistently high. Sensitivity is over 90%, not only for the main, but also for accessory renal arteries. Specificity, when you see an area of stenosis and when you try to discuss it as 50% or more, or even sometimes closer to 70%, is very high. With FMD and vasculitis, there's perhaps a little bit more variation depending on the literature in terms of the sensitivity and specificity. The specificity nevertheless remains very high in FMD. Sensitivity perhaps has taken a little bit of a beating. But on the other hand, complications such as the occlusion on the previous examination or the aneurysms that can be associated is extremely high, and one paper even listed it as 100%. What about the use of non-contrast MRI? This is often an area of interest simply because patients may have low eGFR to begin with. And this is basically a study which looked at 400 renal arteries published recently in November 2020 in abdominal radiology. They used a 3T scanner. They used a the steady state free precession sequence, a 3D sequence, which gives you good temporal and good spatial resolution. And they looked at stenosis as anything greater than 50% or less than 50%. And what they found was that non-contrast MRA was able to diagnose the presence, correctly diagnosis in 72 patients. It only underdiagnosed the stenosis in 2 patients who were later diagnosed as having grade 3 stenosis in patients with after contrast enhanced MRA. More importantly, the agreement between non-contrast and contrast MRA was excellent. So one can clearly use non-contrast MRA as a modality to evaluate patients with poor renal disease. What we typically use, and going back to the same patient, I started off by showing here are the non-contrast MRA images. You can see that the left renal artery is excellently visualized, is beautifully visualized. You can see the area of stenosis of the right renal artery at the ostium, and this looks very similar to what I showed earlier in the same patient with the contrast enhanced exam. So we typically do use non-contrast techniques as part of our algorithm, even when we do contrast enhanced MRA. Every once in a while, the patient will move, or we will get not such great quality images with the contrast enhanced MRA, and then we revert back to our non-contrast techniques to be able to visualize the renal artery and give the clinician the appropriate information. What are the advances in renal imaging? This is something of interest because Dr. Manoria, who started off the entire session, gave a wonderful discussion on the importance of looking at the aorta for aortic stiffness, for looking at the heart. And then we had Dr. Sharad Sheth and also Dr. V.T. Shah, who basically discussed the importance of the kidney itself in evaluation of hypertension. This is an interesting article by Abu Mawadad from the Mayo Clinic, who discussed hypoxia in the presence of renal vascular disease. And what these basically show is G1, G2, and G3 are different levels of end-stage renal, of lower eGFR and end-stage renal disease. And this is the corresponding regions of severe stenosis that one can see in all these patients. And what they basically showed is that the BOLD, which stands for blood oxygen level dependent MRI, basically shows you the evidence of hypoperfusion, and hypoperfusion is defined as decreased oxygenation on the BOLD imaging. The higher the value that you're seeing, the brighter the color, the higher the R2 star map, and this is an example of a map which basically shows you progression. One can then include this perhaps in the discussion about revascularization in these patients. And the suggestion here is that based upon the differences and the phenotypes that you can see on BOLD imaging, one can then decide which is the optimal time to go in for an iatrogenic, an interventional procedure for revascularization, or which is the optimal cases that one can use medical therapy. This is an example also from Mayo Clinic, where they looked at autosomal mesenchymal stem cells, which increased perfusion, and this was the baseline. Remember, thank you. Remember, the poorer colors, the brighter the color, the poorer it is. And you can see that after 3 months, this kidney actually increased its function based on the presence of R2 star maps that one could see. But this is perhaps something that one can use to further evaluate patients who are on the cusp of end-stage renal disease. Dr. Manoria discussed about cardiac imaging, and this is just an example of a patient who clearly has hypertrophy of the myocardium, and Dr. Elizabeth Joseph from Bellow was kind enough to give me the T1 maps and the delayed enhancement images. One can see the increased signal intensity, which represents an area of fibrosis. And one can also see the same changes on the ECV maps, which basically are able to categorize these patients as to whether they are true HOCM patients or hypertensive related cardiomyopathy. And this was an example of HOCM, which basically had hypertrophy of the cardiac wall. Similarly, this is something which is an observational study that I've shared with you, which is in progress. It's a clinical investigation, and one can also look for aortic stiffness on CMR 4D flow studies, and maybe of some interest to some of you in evaluating end-stage renal disease. This was a study which we presented in Los Angeles. We were looking at cognitive patients in the Tata MRI study, and what was interesting for us is that patients who had hypertension actually did poorer with in cognition than patients who did not in the cognitively impaired exam, in the impaired patients. And this is just an example of how MRI looks at the presence of white matter changes. So yes, even in the brain, one can basically utilize this this imaging. And this is just another example of two studies which have shown that that adequate evaluation of hypertension can perhaps even reverse this cognitive changes. So in summary, I would like to end by saying that MRA has a high sensitivity and specificity in the diagnosis. MRA has a high sensitivity in FMD and vasculitis. Non-contrast MRI angiography appears to be equally good, though we always use it as an adjunct and we include contrast enhanced MRI imaging. Bold imaging appears to be something which is of great interest for people to look for the progression of renal disease. And I would also urge all of us to look away from the kidney to look for other changes which can also be equally evaluated in MRI. Thank you again for your attention.
Thank you, Dr. Sanjaya. I would like to invite Dr. Priya Jagia from All India Institute to share her comments and conduct the rest of the proceedings of the day. Dr. Priya, please.
Yeah, thank you, Dr. Sanjay. That was a wonderful talk. So it's very important actually because these patients usually have impaired renal function. So with the advent of quiz sequences, now it is possible to look at the renal arteries very nicely. Actually, the sensitivity is now with the newer sequences, it is in the late 80s. So sensitivity and specificity is quite good, and we can do your MR angios without the contrast also, and they can be put on follow-ups also after if you should see a borderline stenosis. The other thing where, I think your topic was renovascular hypertension. So, another areas where we are doing MR is for looking at the fuse. So for the fuse chromocytoma. So that is the investigation of choice. So another area where we are using frequently MRI in patients who are having hypertension. I think we'll have a discussion later on, and it's now my pleasure to invite our host, Dr. G.N. Mahapatra, for the next talk. Dr. Mahapatra is HOD in the nuclear medicine at Seven Hills Hospital, and he'll be talking about the whole body PET CT evaluation in patients with hypertension. Dr. Mahapatra.
Dr. Mahapatra, before your talk starts, I just want to congratulate you for arranging such an excellent, can you hear me, sir?
Thank you. Yes, I am hearing you.
Yeah, you're arranging such an excellent virtual webinar scientific feast with a very good communication skill, and you work so tirelessly and with so dedication. I congratulate you, and everybody should congratulate Dr. Mahapatra for his great arranging this presentation and this conference.
This is happened of all your blessings and best wishes. Okay, now let me just share this. Are you seeing my slides? No.
No, sir. No, yet not.
What is happening now? I'm not getting the. I'm not getting it. Kindly help me. PET CT in hypertension. Okay. Just remove this lower one.
So we are not seeing anything.
Coming to the introduction, see, I will confine myself towards more of a secondary hypertension or the endocrine hypertension, not going to the details of the cardiac and other parameters. So, you know, all hypertension is the commonest cardiovascular disorder affecting about 20% of adult population worldwide. Prevalence of hypertension in India is reported as ranging from 10 to 13.9%. According to NIH Heart Disease and Stroke Statistics in 2017 update, CVD is most common cause of death in the world, accounting for 30.3 to 32.9% of all global deaths, where hypertension is an important risk factor leading to a high risk of mortality. The total number of adults in hypertension is predicted to increase to a total number of 1.56 billion by 2025 compared to 972 million in the year 2020. So less than or equal to 5% of patients with hypertension have diagnosable causes, you know, as secondary hypertension or specifically endocrine hypertension. So secondary hypertension, which is of endocrine in origin, where an etiology can be identified, onset is abrupt, severity is greater without having any age criteria. So what are the different types of hypertension we come across in our clinical practice? You know, 95% of the hypertension is essential hypertension of unknown etiology, maybe hereditary, maybe familial. But secondary hypertension, renovascular hypertension, chronic renal parenchymal disease like chronic glomerulonephritis, chronic pulmonary, which Dr. Seth has spoken, polycystic disease of kidney, coarctation of aorta, Takayasu arthritis causing stenosis or any other cause of arthritis. Then endocrine hypertension, that is called pheochromocytoma, paragangliomas, Cushing syndrome, Conn syndrome, primary aldosteronism. So pulmonary arterial hypertension, primary or secondary due to thromboembolism, I'm not discussing also within this short span of time, as well as the role of PET CT in cardiac, I'm not covering here also in this short presentation. So what are the various radioisotopes used? Iodine 123 or iodine 131, MIBG, meta-iodobenzene guanidine, indium 111, pentriotide, that is octreoscan. Then comes the gallium 68 DOTA TOC or DOTA NOC, sensitivity of 81.7% as compared to iodine 123 MIBG of sensitivity of 63.3%. Then what are the other PET isotopes? Fluorinating fluorodopa, F-DOPA, and F18 fluorodopamine PET CT. Then of course, F18 FDG, very regularly used in our PET CT. Then iodine 131, 6 iodomethyl 19 norcholesterol, NP59. Then the recent one is C11 metomodate at the MTO. So coming with the first in the series, that iodine 123 and iodine 131 MIBG imaging, pheochromocytoma and extraadrenal paragangliomas, they express cell membrane or norepinephrine transporters, that is called NET, through which catecholamines can enter cells to be stored in the vesicle. So iodine 131 MIBG has been used since long because of its good affinity and uptake by the norepinephrine transporters with a sensitivity of 77% and to 90%, specificity of 82 to 83%. Then came iodine 123 MIBG, which can perform SPECT with an increased sensitivity of 83 to 100%. What are the other advantages of iodine 123 versus iodine 131? Optimal gamma emission, lack of beta particles as compared to iodine 131, but the availability is limited. It's a cyclotron produce. Precaution, medication use interfering with MIBG uptake result in false negative. So the Pureka et al., they showed that SPECT-CT detected additional lesion in 81% of the adrenal lesion. So here one patient where you can see here, it's a 42-year-old male patient with presenting with hypertension, young hypertension, and the anterior and posterior views on a SPECT-CT scan showing a lesion here. You can see here a lesion here in the CT scan, and here there is a left adrenal lesion which is superimposed here and showing the lesion with the increased uptake, and the histopathology shows it is a pheochromocytoma, and the operation by operation it has been removed. Now this is another patient where the normal whole body scan does not pick up any abnormal uptake of MIBG, but when you did a SPECT CT, then you find a lesion here with a necrotic area on the left side adrenal and the physiological uptake in the right adrenal region. So the SPECT CT scores over the planar scan. Then comes the next. This is another patient with a big lesion sitting on the left renal kidney, showing a mass lesion. And when you repeated the same patient with iodine 131 MIBG, shows a clear-cut lesion in the iodine 131 MIBG on the right adrenal lesion. So then comes the SRS scintigraphy, that is called somatostatin receptor scintigraphy, considered as a supplement for MIBG scintigraphy in pheochromocytoma paraganglioma patients with suspected metastatic disease. So somatostatin receptor subtypes 3 and 4 are expressed in pheochromocytoma, including adrenal and metastatic DGS. Indium 111 pentriotide, that is octreoscan, has moderate affinity for these subtypes 2 and 5. New somatostatin analogs like 1, 4, 7, 10 octreotide DOTA-TOC or DOTA-NOC has higher affinity for somatostatin receptor. So gallium-68 DOTA-TOC oblique DOTA-NOC has a sensitivity over 91.7% as compared to the less sensitivity of iodine 123 or iodine 131 MIBG, particularly in detecting small lesions with central necrosis and metastatic lesions. So DOTA-TOC scores over MIBG. Here you can see a DOTA-TOC scans where you can find the lesion here is showing a central necrotic area and increased uptake of gallium-68 DOTA-TOC, and also the other side also is showing, and the metastatic lesions you see on the bone. So this is called gallium-68 DOTA-TOC. Then comes the fluorine-18 fluorodopa and F18 fluorodopamine. Immediately whole body imaging you can do, the possibility of quantitative assessment of uptake, absence of artifacts from a scar tissue or from the presence of metallic clips. F18 labeled dihydroxyphenylalanine DOPA enters via amino acid transporter. Study shows usefulness in benign and malignant pheochromocytoma, superior to both iodine 123 and iodine 123 MIBG and FDG. So then comes the fluorine-18 fluorodopamine PET, is a clearly superior to iodine 131 MIBG with a sensitivity of 100% and 56%. Henry et al., they have showed that FDA PET showed a higher sensitivity for both primary tumors and metastatic lesions. They concluded that FDA PET was superior to FDOPA PET and iodine 123 MIBG sensitivity for localizing metastasis. So in fact, the number of lesions detected by FDA PET far exceeds the number of lesions detected by CT or MRI. So F18 FDG PET in the evaluation of vasculitis. So vasculitis is defined as inflammation and necrosis with leukocytic infiltration of the blood vessel. So most commonly Takaysu arthritis is a chronic inflammatory arthritis that primarily involves the aorta and the main blood vessel. So F18 FDG, which I'll show you, PET CT shows the uptake of the FDG in the areas and before the stenosis, and then it can be treated with steroids, tapering dose. So it reveals the extent of the disease and is highly effective in detecting large vessel vasculitis. It can be monitored, particularly of large vessel inflammation and disease activity after the immunosuppressive therapy, such as prednisolone and cyclophosphamide, 110 milligram per day. Following 2 months after therapy, follow-up PET CT can be done. I'll show you example. Here you can see the example here that here there's uptake in the FDG here in the aorta and also here the subclavian vessels. So this patient was put on steroids. Let's see how after steroid how it looks. See, everything is gone. No uptake of the FDG. So that shows a good response to the steroid, and that prevents the further stenosis in the big artery. Now this is a new area, new paper published in Asia Oceania Journal of Nuclear Medicine. role of FDG PET-CT in assessing correlation between blood pressure and myocardial metabolic uptake. Many of our imaging specialists who are attending this, they can take as a real research area where you can find as the blood pressure increases, there will be increased uptake of FDG in the myocardium, which you are seeing here. So, and they have analyzed, that is called group of Abbas Alabi group. Yes, Abbas Alabi group, University of Pennsylvania. They have analyzed 86 subjects with systolic blood pressure 111 to 142 and diastolic from 66 to 86. Patients should be rested in a quiet room to minimize the pre-test anxiety, following the injection of 4 megabecquerel per kg of body weight of FDG with a scan done at 180 minutes. To rule out, but these patients, before that, you have to rule out the patients should not have amyloidosis, sarcoidosis, endocarditis. Then the SUV values are calculated. So what is the significance of SUV parameters by this paper? The clear correlation of increased FDG uptake of the LV with increasingly higher BP. As the BP goes higher, the FDG value, SUV value goes increasing. It has got a prognostic value in identifying individuals who may develop cardiovascular disease in the future. It is the capability of PET scan which gives early information of the disease process as functional changes at a molecular or cellular level, which is not available with other modalities like CMR and echo, as they cannot detect changes until changes happen in overall structure of the organ. So, effect in FDG uptake is found to be strongly correlated with diastolic BP, diastolic pressure, and mean arterial blood pressure than with systolic blood pressure. So, these are the values, SUV values in the range of 6.6 in diastolic blood pressure, and then you can calculate that. Then coming to the Cushing syndrome, hypercholesterolemia is associated with the hypertension in 80% of adult cases. Characteristic findings, what is Cushing syndrome? Night blood pressure decline is significantly lower than that in patients with essential hypertension. So ACTH secreting adenoma, Cushing disease, occurs in 80% ACG thing. Non-pituitary ectopic source of ACTH like small cell lung carcinoma, oat cell carcinoma, carcinoid, thymus are responsible for rare cases. Most ACTH independent cases of Cushing disease result from adrenal adenocarcinoma and carcinoma or micronodular hyperplasia. So this is the radioisotope used, iodine 12031, 6-iodomethyl 19 norcholesterol, very usually known as NP59. That accumulate the adrenal cortical cells in the Cushing syndrome. Techniques for pituitary adenoma. Then the scintigraphy pattern of adrenal adenocarcinoma, unilateral visualization of gland containing the adenoma as a hot spot in the evaluation of patient with persistent cortical excess. After suppose a bilateral adenotomy has been done, but still the patient has got raised blood pressure. So you have to localize where is the metastatic region. You inject NP59 scintigraphy and found the identification of remnants and to guide surgical intervention. Primary hyperaldosteronism Conn syndrome can occur at all ages, commonly 30 to 50 years. Primary aldosteronism is a common cause of resistant hypertension. One of the common causes. Aldosterone secreting cortical adenoma, usually less than 2 centimeter, or bilateral hyperplasia of the zona glomerulosa. So adrenal scintigraphy is again done with NP59 before the 5th day after injection. Unilateral pattern of adrenal aldosteronoma, 5th day injection can show the lesion. So then the last one is C11 metromediate, MTO, has also been used for evaluation of primary aldosteronism. Hennings et al., they evaluated dexamethasone suppression test followed by MTO PET injection in 13 patients with adrenal cortical tumors. All tumors detected by MTO PET, SU max or higher, normal adrenal cortex were suppressed after dexamethasone. Thyroid disorder, as you know, 1/3 of patients with hyperthyroidism, they will have hypertension, which often resolves after achieving euthyroidism. The main indication of nuclear medicine technique is to differentiate thyroiditis from Graves' disease. So do a radioiodine uptake with iodine 123 or iodine or increase uptake at 2 hours of 24 hours suggestive of Graves' disease. Or just simply do a technetium thyroid scan. No uptake in the thyroid area suggestive of thyroiditis. And uptake in both lobes of thyroid shows Graves' disease. So treat with antithyroid drugs, with beta blockers or iodine 131 therapy, the blood pressure will come down to normal. So concluding, nuclear medicine techniques plays an important role for evaluation and management of patients with secondary hypertension particularly of endocrine hypertension. Iodine 123 and iodine 131 MIBG with or without PET-CT is routinely employed for imaging pheochromocytoma. PET-CT with F-DOPA or FDA is better than MIBG scintigraphy, particularly searching for extra-adrenal metastatic lesions and small lesions. SRS with gallium-68 dotatak, which I showed you here, appears to be useful for extra-adrenal metastatic, of course, small lesions. NP59 is very good for the primary aldosteronism. NPA. So role of FDG PET-CT, which I showed in detecting arteritis and the other forms of inflammation, damages the large arteries, can be detected with F18 FDG so that appropriate treatment planning can be started to prevent stenosis. So as I showed you, as a new evolving area of research in assessing the correlation between the blood pressure and early myocardial FDG metabolic uptake before significant structural changes to happen in the myocardium. And thyroxine and adrenaline uptake is routinely employed in management of hyper or hypothyroidism. Thank you very much for your kind attention.
Thank you, sir. Thank you for the wonderful presentation. Since we are running behind schedule, I think we'll have the discussion. If we have time, we'll have the discussion later on. Now I call upon Dr. Prashar. Dr. S.K. Prashar is Senior Consultant in Cardiac Imaging in Delhi, and he'll be talking about role of echo in evaluation of diastolic dysfunction. Sir.
Well, thank you. In the very limited time available to me, I'll give you just a bird's eye view of a diastolic heart failure. Now, as you know, about 6 decades back, when many of you were not born, the heart failure were divided into 2 groups: a forward heart failure, that was not pumping out enough blood for the cells, and then there was a technology known as the backward heart failure. It was ventricle fails to pump all of its blood because the filling was restricted. So because the filling was restricted, it was not able to put the blood. So that was a backward heart failure. This continued for several years, but with the refinement of techniques and echo, it was found that this was more a diastolic phenomena. Hence, the name was changed to a diastolic heart failure. And from a diastolic heart failure, the current terminology is heart failure with a preserved ejection fraction, because now the heart failure is divided into a reduced, mid-range, and a preserved ejection fraction. So this year, for brevity's sake, we'll continue with the term diastolic heart failure. Now, why is diastolic heart failure important? The incidence is about 40 to 50% of all heart failure patients, especially in Western countries. Almost 5% of the patients in the elderly general population have a diastolic heart failure. Their in-hospital morbidity and hospital readmission rates are almost same as a heart failure with reduced ejection fraction, but unfortunately the treatment is not very satisfactory. So when do we clinically suspect a diastolic heart failure? All vulnerable patients with a dyspnea, either at rest or on exertion or heart failure, must be evaluated for a diastolic dysfunction. So this is mainly a dyspnea under rest exertion. So who are the vulnerable patients? The most vulnerable patient, number 1 is hypertension, number 2 is hypertension, number 3 is hypertension, especially with left ventricular hypertrophy. But there are many other causes for this vulnerability of a heart failure with a diastolic heart failure, but this continues to top the list. Now you see, this is patient who was in mid-70s. He mainly complained of dyspnea. He was of hypertension. He complained of dyspnea, and when we did an echo, there was a concentric LVH. This is septum. This is left ventricle. The left atrium was enlarged, and there was a near normal systolic LV function, but dyspnea was the main complaint. And you find, and when we did a Doppler, we'll come to it again later on, the ratio of the E wave to the tissue Doppler E prime was significantly increased, indicative of a very significantly raised filling pressure, because the normal value is usually less than 8. So by the time he could decide his admission, his systolic function normal, he went into pulmonary edema, but was resuscitated. Another patient in the mid-70s, hypertension, mainly complaining of dyspnea. You see this is left ventricle, and you see a concentric LV present. The left atrium is overloaded, and here you find the same thing. The E oblique E prime is the ratio between the mitral valve early diastolic velocity, which is known as an E velocity, which depends upon LA pressure, and a tissue Doppler early diastolic velocity, which is E prime. So this E oblique E prime is an indicative of an increased filling pressure or increased pulmonary wedge pressure, except in normal individual. So both of them, these patients had a pure diastolic heart failure, no LV dysfunction. So in hypertension, why? Because in a hypertension, there is a chronic elevated left ventricular afterload. This leads to increased LVH and LV mass. There is a myocyte hypertrophy and collagen deposits. They ultimately leads to a replacement fibrosis, and this fibrosis ultimately leads to a progressive stiffening of the left ventricular myocardium, as a result of which, because the stiffening of the myocardium, the filling of the left ventricle is hampered unless it is hence is known as an LV filling pressure. So the major determinants of a diastolic heart failure are a relaxation abnormality and decreased compliance or an increased stiffness of the ventricle, which indicates a more advanced stage of a diastolic heart failure. And because they determine the LV filling pressures, an echo should be able to demonstrate, and it does demonstrate, both these major determinants of a relaxation and compliance abnormality. So the diagnosis of a diastolic heart failure, though invasive studies may be a gold standard, but echo is the most practical modality in daily working conditions, and especially 2D echo, the Doppler, the tissue Doppler, strain imaging and extra. So they are used as a routine in a daily practice rather than invasive study. And these are some of the diagnostic features of a diastolic heart failure. Presence of important comorbidities, as we discussed, especially hypertension, heart failure with near normal ejection fraction, a non-enlargement of the left ventricle, and signs of increased LV filling pressure, which is the most important criteria. Other helpful signs may be left ventricular hypertrophy and the left atrial enlargement, which we showed in our patients. So various societies required certain common guidelines for a diagnosis of a diastolic heart failure. One must start with a clinical evaluation, taking a history, finding out what is any comorbidity, then doing a good echo. A normal echo is very much against the diagnosis of a diastolic heart failure. So we see for a hypertrophy of the left ventricle, we see LA enlargement, we see for a good contractility of the LV a normal ejection fraction or a wall motion abnormality. So this gives us a reasonable idea that yes, there is going to be a diastolic heart failure. And these are some of the other 4 parameters like a mitral Doppler, a tissue Doppler with E oblique E prime ratio, a left atrial volume index, which is a subject because LA is subjected to chronically increased pressure, and a pulmonary hypertension. It is said that in absence of any pulmonary disease, the presence of a pulmonary hypertension, especially in a Western country, is the most common cause is a diastolic heart failure. So these are the parameters we take. And important point is that never rely on a single parameter to be relied for a diagnosis. Always use multiple parameters for evaluation, and that is why multiple algorithms have been developed to aid you in the diagnosis. So one of the good algorithm produced by the Mayo Clinic is that, as you see, we see for 4 things. We see a tissue Doppler velocity. The normal or septal region is more than 7. We see for E oblique E prime ratio. We see for TR jet velocity, which should be less than 2.8, and the LA volume index, which should be less than 34. So these are the 4 parameters we take beside the clinical thing, and the more than 3 are normal, the patient has got a normal filling pressure. first thing we have to find what is the feeling pressure, and we must write in our report whether it is a normal feeling pressure or increased feeling pressure. And when more than 3 are abnormal, it is an increased feeling pressure. And both depending on some echo criteria, we can grade also these. And when it is indeterminate, that is 2 are positive, 2 are negative, in those cases, we take other parameters like a pulmonary vein, Valsalva, strain method, and a diastolic exercise, to which we'll come just come to it just now. Also, this basic chart will tell us whether a diastolic heart failure is present or not, and what is the extent of the failure. But there have been attempts to simplify the diagnosis, make it more clinically oriented, reduce indeterminates, and avoid sophisticated tests. And many of these things have come up. But one common one is what is known as a heart failure with a preserved ejection fraction score, in which these 3, 5, 6 findings are seen, and a point system is given upon the presence of each of these findings. And when this score is more than 6, that means it indicates a preserved diastolic heart failure. What is the advantage of this simple technique is it is a rapid bedside technique using simple, universally available clinical and echo characteristics. It is well validated with invasive studies, enables the robust discrimination of a diastolic heart failure from a non-cardiac cause just by a simple bedside method of things we can diagnose a diastolic heart failure. Then one must mention this PH because LA is behind the left ventricle and bears all the strain. So many of these strains of values are very common very importantly done in these cases. And we take a LA strain in the reservoir function, and this can also give us a diagnosis of a diastolic heart failure, aid in the diagnosis, and also can help at the grading of the diagnosis. There are different grades of a diastolic dysfunction. As the grade increases, the peak LA strain goes on decreasing, and it has emerged as a very important adjunctive technique for a diagnosis of a diastolic heart failure. So I mentioned few words about diastolic stress echo. In a normal individual, when you stress the patient, the mitral E velocity increases because of an increased blood flow. The tissue Doppler remains the same, so the ratio remains the same. But in the heart failure ejection fraction, this ratio increases. So the need for a stress echo is because it can unmask an increased filling pressure on exercise, because almost 25% of patients show increased filling pressure only on exercise. So resting echo can be very inconclusive, but exercise can be very helpful to mask a diagnosis. And these are the various techniques used for this. And these are some of the indications. But in 2 conditions, we don't do it: a patient with a normal heart and normal diastolic function, and patients who have already got an abnormal. But mainly a person having a dyspnea at rest, which is not explainable by Doppler, then we do this. So in the end, the various diastolic function parameters, all of them can be looked, whether it is a relaxation abnormality, stiffness, or any of these, they can be easily picked up by various parameters, both by a 2D echo and a tissue Doppler, so that echo plays a significant role. So in summary, a diastolic heart failure continues to be a very peculiar disease, either over or underdiagnosed. Comprehensive echo techniques always aid in diagnosis. Newer techniques are used in special situations, and they are proved to be very beneficial. Increased PA pressure in absence of COPD is an indirect and good criteria for diastolic dysfunction. Post-exercise studies can be very informative in a subgroup of patients with dyspnea, and hence it is always better to use various variables and various other techniques so that you don't miss a diagnosis of a diastolic heart failure. Thank you very much for your patient learning.
Thank you very much, Dr. Prasher. I think we are running short of time, so we'll just summarize 2 aspects to the entire discussions which we had. So we had a radiology part of it, we had nuclear medicine part of it. So as far as radiology is concerned, we have two aspects to these hypertension, looking at the etiology and the sequelae of hypertension on the heart. So as far as etiology is concerned, we have talked about CT and MRI because of the spatial resolution, high spatial resolution. Actually, CT would be recommended if you have young patients, if you have peripheral renal artery stenosis is expected. For the visualization of the main renal arteries, you can do either CT angiography or MRI angiography. And you can do a non-contrast MR in patients who do not have normal renal function. And the sequelae, MRI has already been discussed with by Dr. Sanjay Vishwamitra. As far as nuclear medicine is concerned, sir, Dr. Mahapatra would like to probably add, just summarize 2 points.
No, I think Dr. Prabhu is there, the chairperson.
Yeah, Dr. Prabhu.
Dr. Prabhu will be the better person, the chairperson.
Yes, sir.
No, I think nuclear medicine, Dr. Sanjay Gambhir has beautifully stressed underline the importance of captopril renogram, and which nowadays captopril is not available. He also explained us the availability of enalapril and other options, and also enlightened the role of not only concentrating on the glomerular filtration, we also concentrate on the tubular function. And Dr. Mahapatra, as a legend by himself, he has done a wonderful presentation. Since we are running short of time, there are a couple of questions that have come up in the chat box. One says that both arms giving different BP measurements, which is to be considered. I think Professor Rashega sir is there. He'll be able to enlighten us more on the clinical aspect. Professor Rashega sir, in the chat box there is a question.
You can take an average and take it into account.
No, actually, when both the pressures are different, more than 10, you will have to evaluate. And wherever the pressure is more, you use that hand. Suppose we have right hand more, you always check the pressure in the right hand. And if the difference is more, you'll have to evaluate for any different reason why that is there. So if it is less than 10, the higher arm should be taken for every calculation.
A warm welcome to Dr. Murugan sir. I didn't notice in the beginning because your video was mute. That is why I prefer.
No. When Mahapatra was there, I don't want to show my face, you know.
You should so. Okay. So now your time has come. I go to the next session.
Yes,
it's a very important session again by a legend, Professor Dr. Muruganathan.
Yes.
So in this context, I would like to call upon Professor Dr. P.C. Manoria, who is
Dr. Mahapatra sir, only one brief comment in the chat box. Actually, curcumin has less bioavailability of less than 20%. If so, it is being used at home. It has to be used with black pepper, as it will provide piperin, which is natural bioenhancer of curcumin of more than 70%. That is a comment.
Okay.
And anything about it, sir?
Yes, already we have told that is the turmeric, and curcumin has got a vascular endothelial growth factor, so it has got an impact. So it can be even combined with pepper.
See, unfortunately, both the diet product is from India, but somebody patronized in US and marketed in Amazon. Very, very sorry state of affairs.
Then only we realize and buy from there, not from India.
Yes. I see Asha Murthy also. Okay. Hello.
Yeah.
Okay. So now I would call upon Dr. P.C. Manoria,
yes,
who is the past president of CSI and senior consultant cardiologist from Bhopal, to chair the session along with none other than Dr. R. Rajsekhar. Over to Dr. Manoria and Dr. Rajsekhar.
In the meantime, can you enable me to share my screen, please?
Yes, sir. Dr. Hearty welcome to Dr. A. Muruganathan, my mentor, Governor, ACP, India chapter. He is going to highlight on role of community health provider in home care hypertension. Yes, sir, you can share the slide.
Yeah. Can you see me the slides, please?
Slides is seen, but you can share the full screen.
Slideshow.
Yeah.
Slideshow.
Yeah, sure. Is it okay now?
Yeah. No, full.
Yeah, now it's okay.
Do we exit now?
Okay.
Go ahead.
Thank you very much. I see a lot of stalwarts in the podium. My chairperson, P.C. Manoria, Dr. Rajsekhar, of course, my good friend who has invited me, Dr. Mahapatra. The topic given to me is role of community health provider in home care hypertension. I don't know why Dr. Mahapatra has chosen me of all the people on a community health provider in home care private for hypertension. I think I like this topic because I am involved in one of the biggest associations who implement hypertension control in India. So I will come to that one by one. So the burden of hypertension, everybody know in India, there are more than 20 crores of people, and 1/3 of Indian patients had raised pressure, and urban compared to rural control is not good. So these community providers are really good, doing good job in rural health in the hypertension care. So the community healthcare provider, the who, why, what, where, when, and how. The community health provider definition is a frontline public health worker who is trusted member, has unusually close understanding of the community served. This trusting relationship enables the CHW to serve as a liaison, link, intermediary between health and social services community to facilitate access to service and improve the quality and cultural competence of service delivery. And they also builds individual and community by increasing health knowledge and self-sufficiency through a range of activities such as outreach program, community education, informal counseling, social support, and advocacy. So they are very good. They only can do. That is why community healthcare worker is a unique profession where they have got a communication skill, they have got the interpersonal relationship building skills, service coordination and navigation skills, capacity building skills, advocacy skills, education facilitation skills, individual and community assessment skills, outreach skills, professional skills, evaluation skills, knowledge base. More than they are able to talk regional language and they get connected to the patients very easily. So the cultural mediation, providing cultural appropriate health education, implementing individual community assessment, conducting outreach program are their programs. So community healthcare workers, they have a lot of programs, they do this. The unique value in healthcare and public health system, spend more time with individuals, family, home, and community and clinical settings. That is why I always call 3 C's of the community. Their connectedness, the credibility, and the commitment of the community healthcare providers are excellent. Now they have got so many names in every country. They give different names. They say one of them say peer educators. They say promoters, outreach workers, navigators, and many more. Many names, but many hats. And they are different from other healthcare workers. So you always appreciate community healthcare workers. They are doing an excellent job in the field of hypertension, in the field of rural health delivery, and things like that. So I'm restricting myself only to the hypertension. There is an association called Indian Hypertension Control Initiative, an initiative started by the government of India along with the state governments, WHO, ICMR, Save Lives, and Vital Strategy. I am one of the consultant of the Saved Lives. That's why I know this. And by June 2020, ICHS had been implemented across 31 districts in 6 states, Kerala, Madhya Pradesh, Maharashtra, Punjab, and Telangana, and planned to be scaled up to 100 districts all over the country. So this home care is very, very important during the lockdown in the COVID times. And what they do, they go to the houses. Not only they go to the houses and they see the patient, and also they send SMS, WhatsApp, and the government of India and the health sector are giving incentives for the healthcare workers. Suppose if the patient doesn't come out for follow-up, if they don't do, if they don't have phone or the transport, they themselves go to their house and deliver the drugs for 1 month. So that's how the sub-centers in India, we have now sub-centers are converted into wellness center. Then after that PSC, then Taluk center and district center. That is the branches in the healthcare system in India. So what they do, the initiative, I tell you an example. The Lakshma, a 65-year-old woman suffering from hypertension, usually goes to the primary health center for her routine monitoring of blood pressure and monthly drugs. She has been taking medicines for the past 2 years without any hindrance. But because of the COVID, because of the lack of public transport, she had no means to visit the health center. So with only 6 days of drugs doses left, she was very anxious because if she misses the drug, she says she has got palpitation, headache, and nervousness. So patients with comorbidities such as hypertension and diabetes are always at the higher risk of becoming severely ill in the novel coronavirus. With COVID-19 impacting health scenario, the continuum of care of non-communicable disease has been significantly affected, and these healthcare providers are doing excellent work to combat all these problems. The decentralization, recognizing the disruption or to assess the essential healthcare service, the ICHI has adjusted its approach of drug dispensing strategy to improve patient-centered care, maintain the continuum of care and treatment adherence. Under this initiative, access to routine health services was improved through the decentralization of routine services such as blood pressure monitoring, drug refills at the health and wellness center. These strategies led to the significant improvement of regular patient follow-up at HWCS and patient compliance and their medications. Normally what we do, we have a protocol. We have developed a protocol with the central government and state government, with the local experts. Every state has got a protocol. What do you mean by protocol? Simplified protocol for easy supply of drugs all the 365 days in the primary health center in the villages. Every state has got their own protocols, but normally, mainly they do CCBs and the ARBs, first line drug, and then third drug is chlorthalidone. So if the BP is more than 140/90, what they do in Telangana protocol state, they give first step amlodipine 5 milligram. If the BP is not under control, they increase to 10 milligram of amlodipine. If there is no improvement, step 4, they give telmisartan 40 milligram. If there is no improvement, they give 80 milligram telmisartan. And if still there is no improvement, they do chlorthalidone 12.5 and then 25. If still not there, they refer the patients for evaluation for secondary hypertension or hypertension specialist. Without forgetting, they also give in the regional language what is lifestyle modification, how to take. This is a simplified protocol. By doing this, all the healthcare workers are aware of this program, and they take the medicines, 30 days medicines, and go and give it to the healthcare in the home. And they also check the blood pressure, and they also bring the reading to the health officer, and they give titrate the dose and then go back and do. If they don't come, they send a WhatsApp message, they send the phone calls. And as I said, sometimes if they cannot come, they bring the patient to the health center for the doctor to check up. So wherever there is a lack of transport, lack of communication, these healthcare workers are doing excellent job to control the hypertension by way of monitoring, by providing enough information in the regional language, as well as providing the drugs. And of course, a gradual improvement was seen in patient registration, was a little slow, but now it is close to 37% started accessing healthcare service at their nearest health centers during the latter phase of the lockdown. 70% of patients are under treatment with protocol medications in Nagpur division. We acknowledge the support of the WHO IHI team implementing the door delivery system, says the Sanjeev Kumar, Divisional Commissioner, Nagpur, Maharashtra. So you can see the picture which we have taken realistically, that running out of drugs, and the consequence of that, I could get drugs from Asha and ANMS at my doorsteps, shared by Lakshma, one of the beneficiaries. Same way, doorstep delivery of services by healthcare workers by the IHSCI team developed a framework to ensure that patients get their monthly drug refills during lockdown. Advocacy was done at the state and district levels. And then actually nurse wives, ASHA workers, the healthcare team as a whole, they are doing excellent job. And CVHOs, cardiovascular health officers, under the IHSI support, the follow-up and doing wonderful job in every state where we are implementing. And this is Telangana, the drug delivery was good, says the Yogita Rana, IAS Commissioner, Health and Family Welfare, Telangana state. So every state, the health authorities and the bureaucrats are very happy, and especially they appreciate the teamwork done by the primary health center headed by CHO and the ASA healthcare workers and rural healthcare providers. So home BP monitoring is the key word. Now, people are started using, these nurses also teach at home how to do a home BP monitor. If they don't have a home BP monitor, they take the monitor and then they check the pressure, they do the reading, and then they give the medicines. They consult the doctor over the phone and then through WhatsApp and titrate the dose and give the patients. So capacity building, or the healthcare workers are excellent. They are provided with hands-on training to give drug pills and also to check the blood pressure, to monitor everything they do. So their work for the, so their work is very good. Then of course, this is again another state where they have said The healthcare workers, as good said, Balbir Singh Sidhu, Health Minister, Punjab, appreciate the healthcare workers, especially our IHSI project. So they build the bridge between clinical care and community prevention. This is the Tom Breeden, who is the head of the vital strategy, who has developed in 2009 when he was in CDC, the pyramid, how it can work. Eat healthy diet, eat take high blood pressure tablet, cholesterol control, immunization, everything, put together. So this is the role of CFGs, that is patient with, the other care management, home visits. They control all these things, through the circle. Again, the impact on the care, if you see the chronic illness, the CHF makes a home visit and also do the instructions and then educate them and then give their progress reports. And this is how it's done. And we have done so many studies. All the studies shows by the home care healthcare workers, the control of hypertension, not only hypertension, cardiovascular problem also, it's good. The change in diastolic pressure, change in systolic pressure, if you see it's 3.3 and 5.6 in 6 studies. In 12 studies, there was a change in diastolic pressure of 1.2 to 2.1. And they also do lipids, they also do CVD risk, BMI, and overall comprehensive cardiovascular healthcare. So blood pressure outcomes and lipid outcomes were very good with the help of the healthcare workers. And now we create hypertension teleclinics in small villages, so that from the town, the doctor or hypertension specialist also looks after the village, and the village care worker goes there and brings the patient to the teleclinic center and make them see the doctor and also discuss. So these are the ways this community-based health workers are working. And we are also doing the non-health workers, the electronic device study. And these are the ways which I think the control of hypertension in India should be better. Right now it is 12.5. I think sooner or later we will achieve in 20 to 25%. And the 6 states only have implemented our Indian National Control Management Initiative. I think sooner or later all the states will take this project. And was in the 6 states where we are doing only pilot study in 25 districts in each state. So by 2022, we are hopeful that all the states will take this project and implement this project, where the healthcare workers' role is very good. So thank you for the opportunity. This is a unique topic, which I think Mahapatra has given me. It is not book in book. It is only our experience, which we do in the Indian Hypertension Management Control Initiative, where in these 6 states, we have got a very good experience. And our experience says ASHA workers and healthcare workers and rural health providers are the key people to implement, especially in a lockdown, where they go to the home and do the excellent job. Thank you for giving me an opportunity. Thank you, Mahapatra. Thank you, Chairperson Rajshekhar and PC Manoria. Over to you.
Thank you, sir, for highlighting the role of community health providers, especially in providing the drugs at home care. And also, Dr. Muruganathan, Governor, has already implemented the donating home BP monitors in so many markets, police station, post office, almost all over Tamil Nadu, he has donated. We are bridging the donations. So thank you very much. And Dr. Manoria, please.
Dr. Manoria is not here. He has an
Okay,
emergency.
well and good. There is one question in the chat box. It was left. And role of garlic as an antihypertensive.
Yeah.
Yes, it is included in DASH diet, dietary approach to prevent systemic hypertension, because garlic is allium sativum. It contains, the odor is due to ELISA, but it does not give any antioxidative property. But garlic, as it is antioxidative, antimicrobial, and immunomodulatory properties.
And,
So
also it has got cholesterol reducing.
Yes, sir. Yes, that's why I told that.
Yeah.
Thank you.
Lipid.
Yeah, thank you, Dr. Rajshekhar, for sharing this excellent session, and thank you, Dr. Muruganathan, for an excellent, uncommon lecture, role of community health provider. I would go to the next interesting session on medical management of hypertension. It's a very interesting session. We have very eminent speakers here. So I would now call upon Dr. Sandeep Bansal. He is the Professor and Head Department of Cardiology, Bardhaman Mahavir Medical College, Delhi. and a senior consultant cardiologist at Safdarjung Hospital, Delhi, along with Dr. A.K. Pancholia, who is a senior consultant physician, cardiologist, diabetologist from Indore. And over to you people to conduct the session. Thank you.
Thank you very much, Dr. Mahapatra. And this indeed is a very important session wherein we go through the management, the actual brass tacks, as we would say, of management of hypertension. And without much further ado, I would invite the first speaker, Dr. Johann Christopher, to tell us about the ABC of antihypertensive therapy. Dr. Christopher, please.
Good morning, chairpersons. Morning, Dr. Mahapatra, and all other esteemed consultants. Am I audible and clear?
Yes.
Yes.
The first slide is very interesting because it is not many years ago when one of the very senior professors said that the greatest danger to a man with a high blood pressure lies in its discovery, because then some fool is certain to try and reduce it. So also a very eminent US cardiologist many years ago in the 1930s said that hypertension is only an important compensatory mechanism. So we have come a long way, ladies and gentlemen. And what is important is from 2000 to 2025, you can clearly see from 60 million odd patients with hypertension in the Indian subcontinent, we have gone to almost 100 million. And this exponential rise is more than what the other countries have gone through during the same period. What is even more lamenting that as physicians, possibly we have not been up to the mark because our awareness is low, the treatment is also low, less than 50%, and the control is abysmally low. And this is reflected both in the urban and rural. There is an urban and rural divide. However, the rural is also catching on. So we really need to do more about creating an awareness about the disease and treating this adequately. If you look at the etiological factors, you can see there's a wide array of etiology, including the sympathetic nervous overactivity. And this has been brought up in the Indian hypertension study, which was done recently, and showed that Indians have almost a 60% sympathetic overactivity compared to what is seen in the Western world, and so also the importance of beta blockers. Now, secondary hypertension, obviously, I'm not going to touch, but it needs to be seen when the blood pressure is not adequately controlled by adequate doses of drugs. The determinants of blood pressure are very important because if you look at the product of heart rate and stroke volume and cardiac output, each element, for example, the heart rate, can be manipulated by medical means by the wide array of medication that we have. And the peripheral resistance, as you know, is very well manipulated by the calcium channel blockers. The RAS system is obviously central to hypertension. And if you look at the red arrows, these are the places where we can intervene in terms of the ACE inhibitors, and here the ARBs blocking the angiotensin 2, and also the aldosterone antagonists. So we have very good agents that can work in the RA system and bring down the blood pressure. The key to all this is obviously angiotensin 2, and it has a wide array of pathophysiological mechanisms that it undergoes, including the kidney and at the tissue level. And it's very important that the use of the ARBs are very important in the management of this disease. Every millimeter of blood pressure is important. And so also this graph shows you that every 20 millimeters hike in systolic and every 10 millimeters hike in diastolic creates a twofold increase in the cardiovascular risk. So it's very important as physicians to get the blood pressure down as low as possible. The permutations and combinations that are available are clearly seen in green. So you could have the thiazide with ARBs, the CCB with ARBs, the ACE inhibitors with CCBs, the ACE inhibitors with thiazide, and beta blockers, obviously not the current choice favorite, but can be used in different situations, in compelling situations. The definite thing here is you do not want to use an ACE and ARB together. Recently, obviously, we have the long-acting diuretics, and these are drugs that should be preferred in the D category compared to the routine thiazide, which are hydrochlorothiazide. So chlorthalidone and indapamide
not only have a better blood pressure lowering ability, they're longer acting and the hyponatremia risk is low. What is also true is the meta-analysis shows that only the chlorthalidone can actually decrease the coronary events and all-cause mortality compared to the plain thiazide diuretics. And as you've seen, the ambulatory blood pressure reduction is better with chlorthalidone than with hydrochlorothiazide. So we have had a lot of these guidelines, the 2013 European Society, the 2013 American Heart Association, the 2014 American Society of Hypertension, and obviously the JNC8 committee in 2014. And let's see how we can sort of integrate that. The JNC8 and the JNC7 was fairly similar in that the same 4 choices of drugs could be used. And thiazide was the initial choice for JNC7, but in JNC8, all 4 choices are available. In the ASH 2014, you can clearly see when you are less than 60 years, an ARB or an ACE is preferable. And when you cross 60, CCBs and diuretics, preferably chlorthalidone, is preferable. So also the NICE British guidelines talked about the ACE ARB less than 55 years of age and above 55 years, the calcium channel and the diuretics. The European Society again maintains all the 4 categories with beta blockers in special situations. I would like to focus on the Indian guidelines of hypertension, which some of the panelists have been participated in and developed these guidelines. And this was published in February 2013, wherein younger patients, again defined as less than 55, would be better off to start with an ACE inhibitor or a beta blocker. As I told you, the Indian data shows 60% of our patients have a sympathetic overactivity. And the older patient would start off with either a calcium channel or a diuretic, again, the preference for chlorthalidone and indapamide. At step 2, you would add a C or D to A. And at step 3, you would add C and D. So it's A, C, and D in step 3. And you would add a spironolactone in step 4 if the patient is resistant hypertension. And this is also the place wherein you would start investigating for secondary hypertension. Moving on to the 2018 European Society, and this was a large task force which looked at it. And here it is, grading is used, grade 1 to 3, starting at 140 millimeters and ending at more than 180 millimeters. And what is also important with the grading, they also gave us a very nice integrated method by which we could not only look at the grades, grade 1, 2, and 3, but also the stages, which was uncomplicated, asymptomatic, and established disease. And based on this, you could actually decide how early you want to intervene in terms of medication. For example, in a stage 1 uncomplicated patient with high normal BP, the patient is at low risk, and therefore medical therapy can be delayed. However, in a patient who has stage 3 established disease, even a mild increase in blood pressure is very high risk and needs to be treated. And this is the kind of recommendation that came out of it, that you had lifestyle advice for all the 4 grades, but drug treatment could be delayed in high normal and grade 1 unless it is a very compelling situation like a patient with established atherosclerotic cardiovascular disease. In grade 2 and grade 3, however, medication need to be started, preferably a single pill combination, preferably 2 medications in the initial part also. What is important to understand about hypertension is the hypertension-mediated organ damage, which is the left ventricle hypertrophy, stroke, nephropathy, and established cardiovascular disease like a myocardial infarction or patients with stenting or bypass. Compared to the 2013 and 2018, the 2018 recommendations have repeated office blood pressure measurements, automated office blood pressure measurements to avoid the use of mercury-based measurements, and also the use of out-of-office blood pressure measurements. And again, in the high normal category, to start medication early if the patient has ASCVD. And also in patients with grade 1, if they have a target organ damage, again, early institution of drug therapy is to be done. The older patients who had a little latitude in terms of the blood pressure goal of almost up to 159, here the blood pressure goals are similar and you need to start these early. So although in the 2013 less than 140 was recommended, here you could start blood pressure medication at 140 and you would really move towards 130. And this is the same thing that goes on for even the elderly patients. While we had a latitude of 150 in the earlier guidelines, it's now less than 140 for all age groups. And obviously diastolic blood pressure is less than 80. The more important change, however, was the SPC, or the single drug combination. Here, preferably two drugs, either an ACE or a calcium, or an ARB with calcium should be the first drug to be used. The addition of spironolactone again was new compared to amiloride in the earlier guidelines. And also device-based therapy really has a grade 3 recommendation. That means it's really not recommended compared to a very aggressive invasive procedure in the previous guidelines. What it also did show is that whatever the underlying comorbidity that you have, 140 blood pressure was the treatment threshold above which you need to start treatment. There was no controversy about that. It is only relaxed to 160 if you're above 80 and frail with a low body mass index. So whatever the age, up to the age of 80, 140 blood pressure is the time to start treatment. At 80, it is more than 160, and you can go down to 135 in a patient who has high risk factors. So this is the treatment strategy here, a single pill to be used in the initial therapy in grade 1, and you could have either ACE or ARB plus a calcium channel or a diuretic. In stage 2, again, it is a simple pill, a single pill with ACE, CCB, and diuretic. And you could have two pills in step 3 when you have resistant hypertension. In CAD, you would institute beta blockers very early, and in CKD, you would institute a diuretic very early in this patient, making sure that you already have an ACE and CCB. In patients with the reduced ejection fraction and heart failure and hypertension, again, an early institution of diuretic and beta blocker apart from the ACE or ARB. In patients with atrial fibrillation, again, early institution of beta blocker or a non-dihydropiridine calcium channel blocker can be used. The ACC is a little different, and here we use the term stage. So normal is less than 120 and elevated is more than 120. Stage 1 is more than 130 and stage 2 more than 140. There are no grades. And when you compare both, although the treatment threshold is initially different at 130, the goals basically are still less than 130/80. Again, the American group across the Atlantic are quite aggressive irrespective of the age group. The International Society of Hypertension 2020 is more closer home. And you had, again, the two grades like the Europeans. Grade 1 was anything more than 140, and grade 2 was anything more than 160. But it also gave us flexibility in terms of essential and optimal. And essential was in those spaces in rural and suburban India where you don't have a wide variety of classes of drugs available. Any drug could be used, and they could be used early in any kind of combination. And here the drug therapy involved, step 1 is the dual low dose combination with preferably half the dose of ACE inhibitor or ARB and half the dose of calcium channel blocker. The step 2 would be a full dose of ARB and a full dose of calcium channel. And step 3 would be the addition of diuretic, and step 4 would be spironolactone, similar to the prior guidelines. So what is really new is that please use longer acting thiazide-like drugs like chlorothalidine and indapamide. They have a good peak of action and their hyponatremia rates are lower. Single pill combination SPC should be used right at the word go in the first line treatment, preferably a combination of ACE and calcium channel blocker, or ACE with diuretic, or an ARB with calcium channel and an ARB with ACE. So the latest guidelines, as you can see, have slightly different definitions, but the treatment goal is the same. 130/80 is the treatment goal in all. A large amount of money has been used in the last 10 years for hypertension, resulting in a lot of deaths. And we really know that hypertension causes most of the stroke deaths, almost 60%, and 1/4 of the cardiovascular deaths. So we need to be careful. We need to look at the targets. And more importantly, apart from ACE, ARB, PCB, and the thiazide, we need to use beta blockers in our patients and single pill combinations, which are easy to use and ensure better compliance. We need to make our diagnosis in out of office measurements. We need to look at the home blood pressure. We need to look at ambulatory blood pressure, and more importantly, start using automated office BP measurements to ensure that there is a less inter-individual variation. Thank you very much for your patient hearing.
Thank you, Dr. Christopher. We'll take questions at the end, and I invite now Dr. Piyush Jain from Delhi to speak on newer drugs, the management of hypertension. Dr. Piyush.
Dr. Piyush, kindly unmute yourself.
Yeah,
Sorry, can you hear me now?
Loud and clear.
Yes,
Okay,
yes, we
very
can.
good. Thanks a lot. Okay, so I'm going to speak in next 10 minutes or so about the novel antihypertensive drugs. And by way of introduction, let me say that what is the need for new antihypertensive drugs? That is the first question. From 1980s onwards, in the past 4 decades, changes in antihypertensive drug treatment have largely focused on attempts to develop better calcium channel blockers, better ACE inhibitors, better ARBs, or a return to forgotten thiazide diuretics like chlorthalidone, but nothing very substantial by way of new classes of drugs, new targets for treatment. And this is reflected in our inability to control blood pressure effectively in all antihypertensives, substantial number of patients with resistant hypertension, and therefore the clinicians often rely on drug combination, 2 drugs, 3 drugs, 4 drugs, even 5 drugs sometimes. And then it goes without saying that the capability of the current antihypertensive drugs to prevent the organ damage is rather limited. You can measure that in terms of relative reduction, 10%, 20%, 30%. But if you look at the absolute risk reduction, it is more or less than 10%, say for example. And this is not surprising because hypertension is basically derived from a very complex system of RAS, which is more complex than we usually think in terms of how to manipulate it in terms of ACE inhibition and ARBs. And we also know the limitations of ACE inhibitor and ARBs, like ACE escape phenomenon. ACE inhibitors result in increase in the angiotensin 1 level and activation of the ACE-dependent pathways to convert angiotensin 1 to angiotensin 2, so thereby reducing the efficacy with continued use. Similarly, ARBs, they increase the plasma renin activity as a feedback phenomenon, which increases the angiotensin 2 levels. And competition between angiotensin 2 and ARB for AT1 receptor results in a decrease in the efficacy of AT1 receptor. So if you really look at what is really the development, it's not, to my mind, it is not finding or marketing new calcium channel blockers like azithromycin or ranitidine or cilidipine, or going back to the older agents like chlorthalidone or some thiazide diuretic. Actually, we should be targeting RAS in a more effective manner, because RAS overactivation plays a central role in the pathogenesis of hypertension. And therefore, I agree with that current drug development is focusing on the areas of novel targets of RAS that serve the dual purpose of not only better blood pressure control, but also improve the function of organs which are burdened by hypertension. That means end organ damage, which may or may not be directly related to a decrease in blood pressure by RAS inhibition. And as I said earlier, RAS is a more complicated system than perceived by most of the clinicians. Just to give you an example, what about the role of AT2 receptor? It is thought to be beneficial. The expression of the AT2 receptor is maintained at low level under healthy conditions, but it is drastically upregulated as a compensatory and protective phenomenon for diseases, for cardiac disease, renal disease, and it does promote the tissue repair, cell differentiation, and promotes diuresis and natriuresis. So that may be one of the targets. But unfortunately, so far, there are 4 AT2 receptor agonists which are being used in clinical trials, not in clinical, but preclinical trials. So I will not go further into that, but focus more on what is known as ACE2, angiotensin 1 to 7, and MARS are protective axis. Now, what is that? See, basically, you have an ACE inhibitor, you have ACE2 inhibitor, ACE2 enzyme also. Now, ACE2 enzyme has a high affinity towards the peptide angiotensin 2 and converts that into angiotensin 1 to 7. And this also converts angiotensin 1 into angiotensin 1 to 9. And that ultimately gets converted to angiotensin 1 to 7. Now, this axis of ACE2 angiotensin 1 to 7 and MAS R axis basically has a protective action theoretically. Now, can we really manipulate that into something that is going to be beneficial for patients with hypertension with or without end organ damage? Well, let me say that with this introduction as to what are the potential targets that are being used, and then I will come to the trials, the clinical trials in progress, and the future, glean into the future as to what can be available to us in very near future. So you have, several novel peptide and non-peptide based agents that are currently at different stages of development. And I will go towards these one by one. I already talked about AT2 receptor agonist. Let me say about ACE2 Ang1 MAS R axis activators. Now, there is an ongoing clinical trial which is testing a recombinant form of ACE2, which is supposed to be beneficial for the reasons I mentioned for the treatment of cardiovascular disease. And it has shown promising results in reducing the progression of diabetic nephropathy, reducing blood pressure, and reducing the progress of cardiac fibrosis. But this is in initial stages, so it is possible that we may have something like that in future. But the peptide Ang1 to 7 directly, a recombinant form of that is also showing promises in treatment of cardiovascular diseases, including the hypertension patients. It has also got an antiarrhythmic action, and it also inhibits the cardiac remodeling. And there is a non-peptide agonist of MAS R, which mimics the action of the endogenous Ang1 to 7 by vasodilatation and natriuresis in many tissues. But still, we don't have any phase 3 clinical trial with this. Now, what about the natriuretic peptides and their synthetic analogs? Now, natriuretic peptides, they cause vasodilatation, they have natriuretic effect and diuretic effect, and they have a potential therapeutic alternative in hypertension treatment. And they also are protective, and they protect against glomerular injury, which is also a very important target for endpoint in patients with hypertension. Now, but they are destroyed very rapidly in the circulation. So we have designer natriuretic peptides, and one of that is MANP, which has been demonstrated to be safe and highly efficacious in reducing the blood pressure with a single subcutaneous administration. And it also got a renal protective action and also reduced the aldosterone level. Neprilysin inhibitor alone is also beneficial theoretically, but in clinical trials, it has not been shown to be beneficial in reducing blood pressure and end organ damage. And the combination of neprilysin inhibitor along with valsartan, that is available. There is no trial going on with this, but I feel that there is a potential for this because this combination also has got a protective action. Now, coming on to the soluble guanylyl cyclase A stimulation, which is instrumental in releasing the cyclic AMP in the cells, and this is activated by the nitrous oxide. This is something that has got a great potential, and the soluble SGC stimulation have shown promising anti-fibrotic, anti-hypertrophic, anti-inflammatory, and anti-hypertensive effects. Then there are dual-acting bispecific peptides, and this peptide engineering with a multivalent strategy. That means not only they activate the guanylyl cyclase A, but also they also activate another form of guanylyl cyclase, which is called GCB. And this combination basically is not the only one. We have a combination peptide which mimics the action of BNP as well as ANG1 to 7. So, a great potential for reducing blood pressure and target organ damage. Now, coming on to non-steroidal mineralocorticoid receptor antagonist. Now, this is something that one needs to focus on because it is in advanced stages of phase 3 trials, and effectively they don't have any effects on urinary electrolyte excretion, so less risk of hyperkalemia and better blood pressure reduction. So randomized clinical trials, and one of the newer non-steroidal mineralocorticoid receptor antagonist is phenereston basically, which showed a significant improvement in subjects with worsening chronic and renal disease conditions. Comparison was made with eplerenone. So, we have other things like aminopeptidase inhibitors, insulin-resistant aminopeptide inhibition also. But let me just close this by saying, just 1 minute more, that what is actually happening, how many clinical trials are actually happening with these novel strategies, and what are their phases? Well, there are at least 27 clinical trials which are ongoing, 10 of which are phase 1 trials, 12 are phase 2 trials, and 5 are phase 3 trials. Not all clinical trials are, of course, being conducted in hypertensive patients. Several of them are recruiting patients with various cardiovascular and renal disorders. And I feel that at least 2 or 3 of the molecules that I have mentioned, they are going to find their way into the market after proper phase 3 trials. And these may prove to be better or at least competitive with the current antihypertensive agents, particularly of the RAS inhibitor reason. But, so there has been a tremendous development that is going on in BP control and prevention of end organ damage. And there is a scope, and clearly a scope, for further improvement as suggested by need for multiple drug therapy and the residual risk despite the best available therapy. And the main target of these newer hypertension management strategies is multiple RAS targets beyond the ACE, ANG1 and AT1 receptor axis. So I will close here, and maybe it's open to question. Thank you very much. Thank you very much.
Thank you, Dr. Piyush Jain, for that wonderful talk. And at this time, I'd like to invite Dr. Jimmy, the Manilal, please.
Thank you very much. I'm going to talk on managing resistant hypertension. As we all know, the diagnosis of resistant hypertension is made when patients take 3 antihypertensive drugs with complementary mechanism of action, one being a diuretic, and still do not achieve control, or when the BP control is achieved with more than 4 medications, equal to or 4 medications. So that's the standard definition of resistant hypertension. Now we talk of resistant hypertension, we must be careful that we exclude patients with pseudo-resistant hypertension. And pseudo-resistant hypertension, there's a significant people who have white coat hypertension and they can be detected by ABPM. And then of course there's pseudo-hypertension because of non-adherence and therefore pill counting, multiple drug, single tablet combination therapy. So non-adherence, in my opinion, is a very strong reason for resistant hypertension. Then of course there are truly resistant hypertensions in which you must find secondary causes, because this is the group where you'll find secondary causes, unlike those patients who you see in your day-to-day practice. So it's important to look at these. Refractory hypertension, malignant hypertension, I think is going to be discussed later. Now, when you approach a patient with resistant hypertension, you must establish true resistant hypertension. Is the BP being monitored accurately? You have to rule out white coat hypertension. You have to consider pseudo-resistance, and you have to consider secondary causes. So that's the way we need to approach it. When you talk of pseudo-hypertension, non-adherence, as I mentioned, is the most common cause. Inadequate regime, that means not giving adequate dose. You may give 3 dose tablets, 3 drugs, but you might not give adequate dosage, and that cannot be therefore considered as resistant hypertension. And of course, you have all these interfering NSAIDs, etc., which might worsen the problem. Then of course, you have pseudo-hypertension, where the arteries are very calcified and not easily occluded by your BP cuff. And therefore you get severe hypertension when you monitor, but no end organ damage. And when you treat them with antihypertensive drugs, they often get worse. So clearly you should look out for this group of sort of pseudo-hypertension. Once you think that this patient has hypertension, you must rule out secondary causes. The most common one is the parenchymal renal disease. We know what investigations to do. Then of course we have to look at renal stenosis, renal artery stenosis, which may be atherosclerotic or fibromuscular dysplasia. And most important, don't forget sleep apnea as a very common cause of resistant hypertension. So this must be looked for in all our patients who have resistant hypertension. Then, of course, we have to look at high aldosterone states. There may be primary aldosteronism, which may be an adrenal adenoma or a bilateral adrenal hyperplasia. We need to investigate that by looking at the aldosterone-renin ratios. Then you have to look at secondary hyperaldosteronism, maybe a secreting tumor, a renal artery stenosis can produce secondary hyperaldosteronism. And then, of course, you look at glucocorticoid metabolism, Cushing syndrome, and congenital hyperplasia. So these are some of the important secondary causes that we need to look at. Of course, we look at other things like Liddle syndrome, and of course, pheochromocytoma, another thing which may be missed. And they say that the average period is almost 3 years before a resistant hypertension is diagnosed as pheochromocytoma. Doing plasma-free metanephrines and urinary metanephrines and catecholamines will give you an answer to this problem, or of course a CT scan looking at the suprarenal mass. Don't forget simple things like aortic aortation or aortic syndromes, where simply examining the patient's all four pulses will give you a diagnosis. So all four pulses examination, go back even if the patient's been on treatment for long. So again, look out for primary aldosteronism, plasma renin serum aldosterone ratio is very important. And then of course for pheochromocytoma, as I mentioned, you have to measure the metanephrine. So these are the two common things which we need to rule out in all patients which are hypertensive resistant. Then of course, when we look at patients' treatment, we have to optimize the 3-drug regime. So though we say resistant hypertension is those who do not respond to 3 drugs, it's important what 3 drugs you choose. If you choose 3 random wrong drugs, or if you give inadequate doses, then you can't call this patient really a resistant hypertension. And then of course, choosing the 4th or 5th agent as may be required. Now we all know that this is the most widely used combination of first choice. It's either an ACE or an ARB, along with the calcium channel blocker, dihydropyramine, and there are so many calcium channel blockers now, multiple new ones with other benefits in terms of C-type and T-type, benefits on the kidney, single dose. So I think all this needs to be taken into consideration as well. And then of course you should have a thiazide light diuretic like indapamide or clothalidone, which as we know has been shown to be better than a thiazide. So clearly this would probably form the basis of any patient who's got resistant hypertension, a single tablet combination of these 3 drugs, because you want to keep the adherence in control, and therefore you want to reduce the pill burden. So this 3 combination, in my opinion, will probably form the basis of any treatment of resistant hypertension. Then of course you have to add the 4th drug, and we know there's a lot of benefit of spironolactone being added to that. As we can see that spironolactone produces a significant reduction of blood pressure. It's a dual renin-angiotensin aldosterone blockers with offered by spironolactone is beneficial. You can of course start with a small dose and gradually build it up even up to 100 milligrams if necessary. We also know from previous data that spironolactone has benefit in terms of endothelial dysfunction, and this can be a further beneficial effect of aldosterone antagonist. Don't forget, in males particularly who have gynecomastia or women who develop menstrual problems with aldosterone antagonist spironolactone, you can safely use eplerenone, which will have much less side effects compared to spironolactone. Then, of course, we have to think of other 4th drugs because the patient is not responding to your first 3 drugs. You can use vasodilators like hydralazine. And I think it's a pretty effective drug in my opinion. Then you certainly could consider the addition of hydralazine. I've not mentioned beta blockers here, but beta blockers also, in my opinion, are extremely important when you're talking of resistant hypertension. And I think another combination of a beta blocker with hydralazine as a second combination in the evening, along with the first combination that I mentioned. So I think a beta blocker hydralazine combination will be a very optimal combination. Then of course you have centrally acting drugs, of which moxonidine is the most useful today. But again, benefits of these are very variable. Alpha blockers are very commonly used in resistant hypertension as a 4th drug. And these are particularly useful for patients with renal dysfunction because they don't affect the creatinine and they don't affect the potassium, which many of these other drugs might do. So clearly we have an option, and I think we have to individualize patients. We also know that treatment of resistant hypertension, there's a big role of the sympathetic nervous system. And I think therefore drugs like clonidine, which of course is not used, moxonidine, which has become a very favorite drug as a 3rd or 4th, as a 4th or 5th drug in patients with resistant hypertension. And I personally believe that beta blockers are extremely important and should be continued to use, especially in those with high sympathetic turn, especially those who got hypertension and high heart rate. I think controlling heart rate is also an equally important factor. Now, again, in order to maintain compliance, as I mentioned, it's very important to use a single pill combination. So if you're going to use 5 or 6 drugs for severe resistant hypertension, patient will not take 6 drugs a day. So the best thing to do is to give a combination of 3 tablets in the morning, means 3 drugs in one single tablet in the morning, and in the evening, a combination of either 2 or 3 drugs in one single tablet. So with 2 drugs, one morning and one evening, you should be able to control most of these patients. Again, there is a question of administration. We all know that RAS blockers are better in the evening. We all know that those who are not dippers and who got a rise of morning blood pressure, better to give them an evening dose. So again, you can take one of the combination pill and give it at night or in the late evening, and one in the morning, particularly with the diuretic. So you can split the drugs in order to get better compliance and in order to get better effects, especially in those who got nocturnal hypertension. Then, of course, if the patient doesn't respond to any medical therapy, then you have to do intervention. We can do renal intervention. We can do renal artery stenosis, stenting, and carotid sinus stimulation. I'm not going to talk more on this because this is going to be extensively discussed in the next few talks. So to quickly summarize, if you have a patient with resistant hypertension, first you confirm that this is really a treatment resistance and not other factors like pseudo hypertension, etc. Once you rule that out and you know that it's a true hypertension, look for secondary causes, of which don't forget primary aldosteronism, Cushing syndrome, coarctation of the aorta, and pheochromocytoma. Then you assess for target organ damage and try and reduce the target organ damage. When therapy is concerned, of course, the overall lifestyle manifestation is extremely important. It must be a first part of your thing: exercise, weight loss, salt restriction. Combination of 3 drugs, which I said best being RAS blocker, calcium channel, and diuretic. Second channel, maybe you should use, I would not use this as a second step. I would say right from the beginning, use chlorthalidone or indapamide. Then, of course, you add your spironolactone or eplerenone. If the patient is still not controlled, then, of course, again, as I mentioned, beta blockers, in my opinion, are still important, particularly in those who got high heart rates as well. Hydralazine can add on or be combined with beta blockers and hydralazine. Minoxidil we don't use here. I think much more frequent we use moxidil or an alpha receptor blocker like prazosin. So a single combination treatment in the morning of ARBS, indapamide, and calcium channel blocker, and in the evening either beta blocker hydralazine or a moxidil or a prazosin. So these combinations would therefore control most of the patients, and you have to make sure that we prevent resistant hypertension from going into malignant hypertension, which is also going to be discussed very shortly. So thank you very much indeed.
Thank you, Dr. Dalal, for nicely covering this important topic of resistant hypertension. We now move on to the next presentation, and I invite Dr. Dayasagar Rao from Hyderabad to speak on drugs not to be given or drugs to be avoided in hypertension.
Good afternoon, everybody. Are my slides visible?
No.
Are the slides visible now at least?
No, sir, not yet.
Not yet?
No, no, no. We can't see your slides.
a very unusual topic and probably, but it's an important topic, but because this continues to be a problem for good control of blood pressure, because these drugs interfere with the effective control of blood pressure. There are many classes of drugs which may cause aggravation of the hypertension if they are used simultaneously along with antihypertensive drugs. Some of them I have listed it as sympathomimetic drugs, NSAIDs, corticosteroids, hormone therapy like estrogens and progestins, and dietary supplements, and some of the antidepressants, not to forget about immunosuppressants and usage of biological agents like angiogenesis inhibitors and tyrosine kinase inhibitors. So the mechanisms how these drugs interfere with control of blood pressure, it may vary from the type of drug used, but the mechanisms include vasoconstriction, which results in potentiation of increased systemic vascular resistance. It can also cause, some of them can cause sodium and water retention. Some of them can raise the levels of norepinephrine and serotonin, which are vasoconstrictors. Or sometimes they cause increased production of angiotensinogen, like in the estrogen high content oral contraceptive pills. And very rarely a drug-drug interaction, because they share the common metabolism to the CYP enzyme 450, and either the drug action can be potentiated or the drug action may result in inhibition of the antihypertensive effect. These are in general, the various mechanisms involved when we simultaneously co-administer the other drugs which are used for other associated comorbidities in a hypertensive patient. There are some drugs which should be avoided specifically in some clinical situations. Like in pregnancy, you cannot be using AC inhibitors or ARBs or direct renin inhibitors. It is important to remember that pregnancy-induced hypertension, you should not be using diuretics for control of blood pressure, basically because the circulating blood volume is already contracted, and usage of diuretics in these patients with pregnancy-induced hypertension might make things much worse. Coming back to the usual drugs which might interfere with the antihypertensive drugs or the sympathomimetic drugs used for various reasons, and common source of the sympathomimetic drugs are the cold medicines and the cough medicines. They generally result in a very insignificant change, but it does happen in some patients, inappropriate rise in the systolic blood pressure and an inappropriate increase in the heart rate. And interestingly, there is no change in the diastolic blood pressure in most of these patients where they use associated sympathomimetic drugs. But the maximum increase in the blood pressure by the usage of the drugs is approximately about 3 to 4 millimeters of mercury. Now, there are some other drugs like amphetamine derivatives, which are used in narcolepsy or attention deficit disorders or hyperreactivity disorders in children and adolescents, which might contribute for aggravation or poor control of blood pressure. The mechanism of increase is, as I said, there's a sympathoma. These are all stimulants of the CNS, and they raise the sympathetic activity, and then they cause a rise in the systemic vascular resistance, contributing to that. Perhaps one of the common drugs that are used in daily practice, especially in patients who are hypertensive and associated osteoarthritis, wherein they are prescribed NSAIDs, and these NSAIDs are certainly dangerous, not only for the kidney, but also they can also prevent the appropriate control of blood pressure in a given individual patients. The NSAIDs probably non-specific, and some of them are COX-2 inhibitors. And COX-2 inhibitors are certainly much better than non-specific NSAIDs, but they are not free from this poor control of blood pressure. The mechanism is COX-2 inhibitors leads to inhibition of the natriuretic effect, and they also cause sodium retention. And this leads to induction of hypertension if the patient is normotensive, or aggravation of the hypertension leading to a poor control of hypertension. A meta-analysis of COX-2 inhibitors on blood pressure in 19 clinical trials, approximately about 1,450 patients, has shown that BP elevation is more with COX-2 inhibitors as compared to non-specific anti-inflammatory drugs. And even among the COX-2 inhibitors, rofecoxib has got a greater elevation than celecoxib. And BP monitoring during NSAID or COX-2 inhibitors is become mandatory. And probably you need to educate the orthopedic surgeons and the rheumatologists to be careful or to monitor the blood pressure a bit more frequently when they are prescribed simultaneous COX-2 inhibitors in a patient who otherwise was taking antihypertensive drugs. Perhaps what is not realized by many is administration of corticosteroids, where nowadays it has become common for many disorders, including COVID. These steroids cause sodium retention and fluid retention. And some of the cortisones have got strong mineralocorticoid effect, causing water and salt retention that might contribute to the aggravation of blood pressure or loss of control of blood pressure control. It's important to note that some of these drugs have got more of a glucocorticoid effect, and some of them has got less of or more of mineralocorticoid effects. So if at all one has to use a corticosteroids in a patient who is hypertensive, probably it is worthwhile using dexamethasone instead of fludrocortisone for any other reason. And the mechanism of aggravation of these thing is, apart from volume expansion, some of these steroids also cause stimulation of the mineralocorticoid receptors that causes salt and water retention and thus increase in the blood pressure. Perhaps one of the common drugs used as a oral contraceptive pill and their rise in the blood pressure is not unknown to many. Approximately 5% of the women who take oral contraceptive pill with a high dose estrogen, which was the original product or the earlier preparations of the oral contraceptive pill. When the high dose of estrogen is used in the oral contraceptive pill, the systolic blood pressure can rise by almost 6 millimeters of mercury, and the diastolic blood pressure by approximately about 5 millimeters of mercury. And 5% of the women who take oral contraceptives develop new hypertension if the estrogen content of the oral contraceptive pill is high. And more so if the patient has got a past history of pregnancy-induced hypertension, or if there is a family history of hypertension. But it is important to remember that in the nurses' health study, a study of 70,000 female nurses between the age of 25 to 42 years, the relative risk of developing a hypertension was 1.8 times if it is a current user of the oral contraceptive pill. It is important to remember that hormone replacement therapy, including estrogen replacement therapy, does not cause any change in the blood pressure because the estrogen content there is much less. Compared to 50 micrograms in the original oral contraceptive pill, the estrogen content of this HRT is only about 10 micrograms, and along with progesterones. When you administer it, there is no change in the blood pressure. But then it is important to remember that one of the studies was women health study. Hormone replacement therapy is not a good drug in females because they are all prothrombotic. And at one time, we thought hormone administration to these postmenopausal women would lead to a healthier cardiovascular outcome. But the study has shown that it does not cause any benefit. On the contrary, it causes a lot of harm to these females in the postmenopausal period. The mechanism of increase in blood pressure by these things is mostly by estrogen, leading to increased synthesis of angiotensin by the liver. And this leads to increased production of angiotensin II, which, as you are all aware, it causes severe vasoconstriction. But then again, this kind of a thing happens only when the dosage of estrogen is high and not when the dosage of estrogen is low, like in 10 micrograms, as such in most of these HRTs. Perhaps a lot of people don't realize that immunosuppressants like what we use, cyclosporin and tacrolimus, which are used as immunomodulators in some of the autoimmune disorders and in organ transplants, can induce severe hypertension. That the incidence of hypertension is high when you are using cyclosporin, which is on the order of the 50% of them do develop hypertension, or the hypertension becomes much worse. And when you are using a tacrolimus, the induction of hypertension is approximately about 35%. The mechanism again is decreased excretion of sodium in water, and that causes this rise in the circulating volume and vasoconstriction, and that leads to aggravation of the hypertension. Some of these antidepressants and anorectic drugs, they are called serotonin norepinephrine reuptake inhibitors, and the mechanism of increasing the blood pressure is elevated levels of norepinephrine, and thus probably you need to consider changing over to some other antidepressant drugs or hike up the dosage of the antihypertensive drugs. Erythropoietin, especially recombinant human erythropoietin usage, results in increase in the hematocrit levels, and thus an increase in the dosage, and then may also cause elevation in the blood pressure. And a corresponding increase in the antihypertensive drugs is mandatory whenever you are using erythropoietin, leading to aggravation of the hypertension. Lastly, but not least, is some of the drugs. Antihypertensive drugs are metabolized by the CYP enzyme 45, and any co-administered drugs can potentiate the drug effect or can nullify the antihypertensive effect. So it is important to remember that what drugs are co-prescribed, so that any alterations of those drugs might result in a better control. Some of the biological therapies what we are using now are angiogenesis inhibitors and tyrosine kinase inhibitors can lead to hypertension. Tyrosine kinase inhibitors classically are used in chronic myeloid leukemia, imatinib and dasatinib. They cause increased SVR, systemic vascular resistance, by salt and water retention. Some of these tyrosine kinase inhibitors and angiogenesis inhibitors can also cause endothelial dysfunction consequent to decreased production of the nitric oxide. Finally, monoclonal antibodies, especially bevacizumab, can raise the blood pressure markedly, and there is approximately about 1% of the patients who are using bevacizumab that can develop hypertensive crisis. So a poor control of blood pressure, history demands that you take what are the co-administered drugs to that patient, which might be contributing for poor control. And lastly, in our country, herbal supplements are not uncommon. They are prescribed by many general practitioners and physicians. They can also cause a rise in the blood pressure through the mechanism of salt and water retention, and also through the central stimulant action. Finally, caffeine is not the coffee that we drink that causes rise in blood pressure, but that rise in blood pressure is only transitory. But the energy drinks what some of these youngsters take, they contain a lot of caffeine, and that can raise the blood pressure significantly. The mechanism of action is they do block the adenosine receptors, and then the action of the adenosine. So they do block the vasodilatation, and they also seem to increase the cortisol and adrenaline, which might contribute for the poor control of blood pressure. And finally, the co-administered drugs which contain high sodium, like antacids, laxatives, and soda bicarbonate tablets given by the nephrologist, might add up to this high sodium food that might aggravate the blood pressure. So it is important that we evaluate properly all these patients what drugs are taking. So in conclusion, hypertension may get out of control when you are administering drugs which raise the blood pressure through various mechanisms. So close monitoring of blood pressure. Stop the drug if possible, or change over to lesser drugs which do not raise the blood pressure. Especially if you are using a rofecoxib, probably change over to celecoxib if their usage is necessary, is absolutely mandatory. But for some of the drugs, we cannot stop it, like the immunosuppressants or the biologicals, because their usage is mandatory for effective control of the organ transplantation rejection, and their usage may be necessary, like in diabetic retinopathy, wherein we use angiogenesis suppressants. So in those cases, good monitoring of the blood pressure and effective control of other risk factors might go a long way in preventing the occurrence of cardiovascular complications secondary to poor control of blood pressure. Thank you once again for your patient listening. Thank you.
Yeah, thank you very much, Dr. Dayasagar Rao. And for the final talk in this session, I'd like to invite Dr. Sunil Modi to tell us about the management of malignant hypertension.
Thank you very much, Dr. Bansal, Dr. Pancholia, and the organizer, Dr. Manjunath. Thank you for giving me these 10 minutes to 11 minutes for malignant hypertension. Now, malignant hypertension is a term which has been used to describe a very much elevated blood pressure, and by definitions, it is beyond 180 systolic and beyond 120 diastolic, with multiple complications, some evidence of organ damage, and a poor prognosis. Now, conventionally, in order to make a diagnosis of malignant hypertension, the papilledema should be present. I'm not very sure whether the current definitions do write papilledema to be necessarily present or not, but conventionally, yes, papilledema should be present if you want to call it malignant hypertension. Malignant hypertension is not so common, because of various reasons, efficient therapies, more awareness, whatever you want to call, but we don't see that often as we used to see in good old days. The projected incidence is 1 to 2 cases per million per year. If you take the whole statistical data, then the emergency department visits with malignant hypertension have doubled in the last about a decade. Now, that may be because we have more emergency department units and people are more aware. They go faster to the emergency triads. It may not be actually increasing the incidence of malignant hypertension, but the visits to the ED have definitely increased to almost double in last decade. Now, typical examples of these malignant hypertensions are cerebral infarctions, acute pulmonary edema, eclampsia, and so on and so forth. Now, why only some of these hypertensive develop malignant hypertension? Nobody knows the reason. It is very unclear, but there are postulations that there is some genetic predeterminations, there is absence of some beta, gamma, I don't know the details of that, but elevated adenomedullin levels, elevated natriuretic peptide levels, abnormalities of oxidative stress markers, so on and so forth. These are just the postulations that why only some of these hypertensives develop malignant hypertension. Now, many reasons for malignant hypertension, as we know that it is just the other spectrum of the usual hypertension. If you don't control blood pressure for a long time, it is likely to convert into malignant hypertension. So medication non-compliance, renovascular diseases, renal parenchymal diseases, including glomerulonephritis, systemic sclerosis. I have seen one case of systemic sclerosis developing malignant hypertension recently. The SLE, hemolytic uremic syndromes, endocrine dysfunctions, pheochromocytoma, primary hyperaldosteronism or Conn syndromes, renin secreting tumors, so on and so forth. There are many etiology, many reasons for malignant hypertension, but we should continue remembering that the uncontrolled and neglected hypertension is one of the most common reasons. The antihypertensive medication withdrawal, sudden withdrawal of antihypertensive, which we saw in this COVID era. The patient went into the COVID ward with the COVID and he was on 5 or 6 antihypertensives. For some or the other reason, all were withdrawn and they landed into problems. Coaptation, drugs, as Dr. Dayasagar Rao just told us, amphetamines, central nervous system disorders, head injuries, cerebral infarction, cerebral hemorrhages. So there are many reasons that patients land up into malignant hypertension. Now, pathophysiologically, it is very important because it is pathologically, it's sudden increase in the systemic vascular resistance with the vasoconstriction mechanism, which leads to hypoperfusion, pressure natriuresis, and ischemia. The most common organ damage is because of these pathophysiological changes. The Classical vascular feature is fibrinoid necrosis of the small vessels, which we see, in the fundus as the papilledema also. Another feature of the hypertensive malignant hypertension is the loss of autoregulation in the brain, which can present as hypertensive encephalopathy. So these are the various pathophysiological mechanisms through which the malignant hypertension shows its bad effects. Most patients with the persistently elevated blood pressure for years before presenting with hypertensive emergencies. The initial questioning in the history should focus on finding the indicators of the organ damage, because that's what is most important at the time of emergency. We should try to focus on which organ is likely to be affected: headache, nausea, vomiting, visual disturbances, chest pain, back pain, suggesting aortic dissection, dyspnea, orthopnea, visual disturbances. Review all prescription and non-prescriptional medications, adherence of these medications since last doses. Ask about recreational drugs like amphetamines, cocaine, phencyclines, or oral contraceptives. In one scientific review, the most common presentation of hypertensive emergency or malignant hypertension was chest pain in 27%, dyspnea in about 1/4, and another 1/4 came with a neurological deficit. So most common presentations in the emergency would be one of these three features. How do these patients confirm pressure in both the arms and probably in the lower limb also to avoid missing aortic dissection? Fundoscopic examination, which we all used to do in good old days. I'm not sure whether current generation does any fundus examination or not, but it's not so difficult to find, the papilledema in a non-dilated pupil bedside. We diagnosed many cases in the past in our younger age of malignant hypertension just by looking at the non-dilated pupil. Assess for murmurs, gallops, signs of heart failure, look for pulmonary edema, look for abdominal bruise, and of course, look for neurological findings, which can lead you to the higher diagnosis of hypertensive encephalopathy. This is a typical picture of the fundus showing papilledema, a very advanced grade 4, Keith-Wigner classification grade 4 retinal changes. Now, how do we evaluate these patients? The basic tests remain electrocardiography, ECG, X-ray, urine analysis. Electrolytes and creatinine are very, very important. Cardiac biomarkers if we suspect acute coronary syndrome. We can even add anti-proBNP in current era, where we can diagnose early acute heart failure. Toxicology screen if you suspect any, these recreational drugs or any drugs poisoning. CT MRI of the brain, head injury for head injuries, for neurological symptoms, hypertensive retinopathy. Contrast CT or MRI for ruling out, any dissections if you are suspecting that, or maybe in the late phase if you want to diagnose renal artery stenosis and some of those secondary causes of hypertension. The management of malignant hypertension requires a very efficient interprofessional team that includes internist, ED person, nephrologist, cardiologist, and probably a neurologist if there is a neurological involvement. For asymptomatic patients, admission may not be necessary, although we do advise in most of these patients to be in hospital for a couple of days. But then it's not strongly recommended in case patient doesn't have any symptom along with the blood pressure of more than 180, 120. Those with the symptoms need to be monitored and specialists consulted as per the suspicion of the end organ injury. Adequate therapy, including the choice of medications and the length and the type of medications, depends on the specific hypertensive emergency and the suspicion of the end organ damage. No trials exist comparing the efficacy of various agents in the treatment of malignant hypertension. Although the drugs are chosen on the basis of their rapidity of action, ease of use, special situations, or convention. We'll just come to that in a moment. It is not recommended that, just a moment, let me just, okay. It's not recommended to decrease the blood pressure too fast or too rapid, as ischemic damage can occur in vascular territories, where those territories which have become habituated with the elevated level of blood pressure for a long time. For the majority of hypertensive emergencies, the mean arterial blood pressure should be reduced by approximately 10 to 20% within first hour, and by another 5 to 15% over next 24 hours. This often leads to target blood pressure of less than 180 by 120 for the first hour and less than 160, 110 in next 24 hours. One should rarely try to bring it below 130, 80 in the next 24 hours time frame. The common intravenous medications which we have been using and which we still use are sodium nitroprusside, nicardipine, labetalol, esmolol. And I'm not going into details of doses of these drugs, which are so well known to us. If there is any possibility of underestimation of blood pressure, then you can still use arterial line, which is not very common to use in the hypertensive emergencies. Short-acting nifedipine should be avoided, as there is a risk of rapid, unpredictable hypotension leading to ischemic events. Even short-acting enalapril injectable, which we were told that it can be used, is not a very good drug or in these hypertensive emergencies because of uncontrolled drop of the blood pressure. In special situations, acute phase of ischemic CVA, acute aortic dissection, acute myocardial ischemia requires a different tailor-made protocol to reduce the blood pressure in these hypertensive emergencies. Differential diagnosis remains acute kidney injury, dissection of aorta, chronic kidney disease, subarachnoid hemorrhage, pheochromocytoma, and renal artery stenosis. Multiple complications can arise when the target organs are affected, including encephalopathy, hemorrhage, MI, heart failure, unstable angina, dissecting aneurysm. The prognosis of patients with malignant hypertension is very much guarded. The 5-year survival is estimated to be around 75 to 84% with the current efficient treatments, and without treatment, the life expectancy is less than 24 months. Most of the deaths are the result of heart failure, stroke, or renal failure. As we know, friends, hypertension continues to be #1 killer in the world, in spite of all kinds of diseases that we have encountered, including COVID, I believe. And we cannot forget, all these historical people dying of hypertension emergencies or actually malignant hypertension. Thank you very much for your kind listening. Thank you very much. And questions are welcome. I hand over the screen to the...
So thank you very much, Dr. Modi, for nicely covering this important topic of malignant hypertension. Now the session is open for questions. My question to Dr. Piyush Jain, you have focused more on the RAS system. So for the new drug development, the management of hypertension, now the researchers are working on a new drug development that is actually targeting the brain renin-angiotensin system, that is angiotensin 3. And one of the drug is the fibribastate, which is actually targeting the 3 areas, the vasopressors, vasopressin, and the cardiac contractility. Your view on that? Dr. Piyush Jain?
Sorry. I was put on the mute, So basically, the drug that you're talking about, I did not cover it, though it was mentioned as one of the agents. It's an aminopeptidase inhibitor, which inhibits the conversion of angiotensin 2 to angiotensin 3. Now, the angiotensin 3 is basically a peptide which has got effects on the brain RAS, and by blocking the brain RAS, you are expected to have a control of blood pressure. But this is has been observed only in the preclinical models of hypertension. So far, it is not been tried in clinical trials, phase 3 trials as such. There is clinical trial which is likely to be initiated on these lines, and this is definitely a potential treatment for hypertension.
besides the points that I mentioned, So aminopeptidase inhibitor or APA inhibitors, as it is called, is a potential therapeutic application, certainly. But for the future,
it is a brain A aminopeptidase inhibitor, PRIBSTAT. Only phase 2 trial is over. Phase 3 trial is said to be avoided. So prevention to angiotensin 3, that is PRIBSTAT.
Actually, phase 3 trial is planned, but it is not initiated so far. So,
Dr. Dalal, you have focused on the importance of beta blockers in management of resistant hypertension. 2018 European guidelines clearly endorse the bisoprolol and even the doxorubicin in the management of resistant hypertension. What is your viewpoint on?
Beta blockers, in my opinion, still are very commonly used in India, and I certainly use them myself. I think bisoprolol is an excellent beta blocker for treatment of hypertension. It's a single dose beta blocker. It has got effect on the central aortic pressure. It reduces the heart rate. It has got minimal effects on electrolytes and lipids. So in my mind, it's an ideal drug. And certainly alone or in combination with a diuretic, which is available or along with an amlodipine or other calcium channel blocking drugs, I think it's important. And I think also more emphasis has been put on the heart rate control in hypertension, which somehow we hadn't been looking at too much in the past. And I think good heart rate control is an important part of controlling hypertension. So I personally think beta blockers should be a part of resistant hypertension where you're using, say, 5 drugs. I think one of them should be a beta blocker.
So regarding one point, resistant hypertension, we all know third drug should be a diuretic. Even if the third drug is a diuretic, hydrochlorothiazide or thiazide-like diuretic, like indapamide, the spironolactone can be a fourth drug because as Sabin Hook has narrated, it is a pannexin 1 channel inhibitor because pannexin channel are ubiquitously expressed in our body, especially smooth muscle and endothelium. Because pannexin channel, if it is inhibited, it inhibits adrenergic stimulation, which in turn inhibits ATP, so it prevents vasoconstriction. So spironolactone is a good fourth drug in resistant hypertension. This is the recent study by Sabin Hook.
Absolutely agree. I think spironolactone would be the definite fourth drug without doubt, even if the patient is on a diuretic. And then, of course, fifth drug would depend.
Yeah, it is not only that, it is also a mineralocorticoid receptor antagonist, apart from epirlinone and also finrinone. So these are, finrinone has got a more mineralocorticoid receptor antagonist because it both exists in kidney as well as cardiac muscle. That is, it has got both action, it exists more.
Finrinone is a bit like in between spironolactone and epirlinone, more effective epirlinone and less side effects than spironolactone.
Dr. Mahapatra, should we continue with the questions or?
It is already time is over. They can go to the next session.
I have one question, Dr. Dasagar here. This question is directed to Dr. Sunil Modi. I have seen that one of the causes of malignant hypertension, he has put primary aldosteronism. It is said that you will never get a malignant hypertension in primary aldosteronism. One of the reasons given is it is a low renin stage, and renin-angiotensin system activation is mandatory for production of the malignant hypertension. So correct me if I am wrong, Dr. Sunil Modi.
Yeah, you're right. It is very rare, but the uncontrolled primary aldosteronism hypertension can also lead to complications. See, the definition of malignant hypertension is still very, very variable. So any organ damage, they say that any organ damage, be it be LVF, be it be cerebral or anything, is included in the malignant hypertension. So uncontrolled primary hyperaldosteronism can also lead to this stage. It may not lead to papilledema, it may not lead to very severe this thing, but it has been described in the causes of malignant hypertension. I'm sure it is very, very rare. I mean, I agree. Renin is one of the mechanisms, not the only mechanism, but renin is one of the mechanisms for sustaining high blood pressure. Sir.
Dr. Mahapatra, please unmute. You are not audible.
Mahapatra,
Mahapatra, you are not audible.
Yeah, can we go to intervention in hypertension next?
So,
Am I audible?
Yeah.
now you are audible.
now you are audible.
Okay. So for chairperson, I would invite Dr. Gaurang Shah. He is the senior consultant urologist and head of the department, Saifi Hospital, Mumbai. Along with him, I would request Dr. Pancholia to chair also in the absence of Dr. C.N. Manjunath. So over to the chairpersons. Dr. Pancholia, you can start. Yeah, Dr. Gaurang Shah is here. Yeah. Okay, Dr. Pancholia, you can start the session by calling the first speaker. Dr. Pancholia.
Because I'm sorry, I don't have the
Okay, the first speaker. Okay, the first speaker is Dr. N.N. Khanna from on subject on vascular intervention from Indraprastha Apollo Hospital, Delhi. Dr. Khanna.
Okay, thank you. Can you hear me?
Yes, we can.
Yes, we can.
Okay, thank you very much, Dr. Mahapatra, for inviting me for this lecture. And also, it's an honor to be presenting in front of you and Dr. Pancholia and Dr. Shah. Let me share my screen. And in the next... can you see my screen?
Go to the slideshow. Yes, yes.
So in the next 8 minutes or 10 minutes, I'm going to be talking about interventions for resistant and hypertension. And this is a very interesting topic. So let us just quickly go through the different epidemiology of hypertension. And I'm sure this slide must have been sort of shared earlier as well. If you see world over, about 1/3 of the hypertension patients are untreated. About 1/3 are treated, but they are not well controlled. And only about 1/3 are treated and well controlled. It is also very interesting to see that every 20 millimeters systolic or 10 millimeter diastolic increase in blood pressure correlates with doubling of 10-year cardiovascular mortality. And it dramatically increases the risk of stroke, heart rate, heart failure, and kidney failure. And only, there is a very high prevalence, and in the world over, we have about 1.6 billion people who would be suffering from this disease by 2025. Okay. So what we see here is, again, the same thing, the cardiovascular mortality almost doubles by just increase of blood pressure by 10 millimeter of mercury. In the meta-analysis on cardiovascular mortality, it was seen that this is from 61 prospective observed studies, and it was seen 10% reduction was there observed in the risk of stroke and 7% reduction in risk of ischemic heart disease by only 2 millimeter reduction in the office systolic blood pressure. So we can understand how important it is to control this blood pressure and how difficult it is to actually achieve the targets in the real world population. Again, these are the breakdown of different causes of uncontrolled hypertension. Dr. Dayasagar Rao, Dr. Sunil Modi, and other speakers have actually talked in detail about it. So I'm not going to be talking about it. But if you exclude all these other causes of uncontrolled hypertension, then comes the cause, a real cause, which is a true resistant hypertension, where 4 or more drugs actually fail to control the blood pressure properly. Now, if you look at the failure of current approach, pharmacological approach to successfully treat hypertension, it varies from 29 to 53% world over, and these are because of various mechanisms, and I'm not going to be going in detail about it. My topic is restricted to interventional treatment. The most common treatment which we do is if you have young children with coarctation of aorta and they have hypertension, Many a times, if you treat and relieve this coarctation early, the hypertension actually gets better control, but rarely cured. And many patients would have a renal artery, stenosis, and if we can timely dilate and stent these renal arteries, then these patients can do well in terms of control of blood pressure. So I'm not going to be specifically talking about these two interventions because this is done very routinely and everybody knows about it. The other conditions where renal arteries can be involved is non-specific aortoarteritis in fibromuscular dysplasia and IgG4 immunopathy. And with there again, renal artery stenting comes or angioplasty comes in big role to control hypertension in these patients apart from the medical therapy. Now, there has been a lot of controversy about the role of renal artery stenting, especially after the Astral and Coral trial. And what has emerged out of the data is routine renal artery stenting in a hypertension patient does not help. The way to predict whether it's going to help or not is to do a selective renin sampling from each renal veins and see if the selective renal, there is a selective hyperrenemia from that sample. Then in that situation, the renal artery stenting may help. Otherwise, if there is an uncontrolled hypertension with 4 drugs in good doses with renal artery stenosis, again, that's an indication for doing renal artery stenting, provided the stenosis is more than 70% and the gradient is more than 20 millimeter of mercury. And these days, a lot of role has come in using FFR for renal artery stenting. And the FFR cutoff value here is 0.8. So, and the third classical indication is if you have a hypertensive patient who goes with renal artery stenting, who goes into bilateral, who goes into recurrent pulmonary edema, again, this patient requires definitely it's a class 1 indication for renal artery stenting. And if the patient has a bilateral renal artery stenosis or a transplant-related kidney which has stenosis with hypertension, this requires renal artery stenting. So, now the newer interventional therapies are renal denervation, which was quite, which came with a big, hope and hype initially, but then it went into disrepute and again it's coming back. We also have barostimulation devices and also ROX couplers and carotid body ablations. So I know there's a talk after this about renal artery sympathetic denervation, so I'm going to be quick and not talking much about it. The sympathetic nervous system supplies catabolic signal to the body acting whenever rapid response is needed. And this response also includes hypertension. Now, sympathetic system is the key driver for hypertension. It leads to renal artery vasoconstriction, sodium fluid retention. It enhances the renin release and also stimulates systemic sympathetic response. And all these 4 factors are important in producing resistant hypertension. Now, if you see this, there is a sympathetic activity. If you see sympathetic activity per minute in any class of hypertension, right from normotensives to high normal blood pressure people to hypertensive, borderline hypertension, and all stages of hypertension, you have what you see consistently is that there is a higher sympathetic activity per minute in these patients. And this was not, this is not a new knowledge. This was not known at least 90 years ago when classical works were done and published in different journals from Harvard Medical School in 1931 and also by Dr. Smithwick, and he did a series of 1,366 surgical splenectomies for essential hypertension, and there was a good relief, and also in 1952, which was published in the British Medical Journal. So this used to be a good surgical technique to control hypertension when the good drugs were not available. But then good drugs came and the newer insights came in medical therapy of hypertension. And this concept was maybe forgotten for a long time till we had an interventional device which could selectively ablate the nerves which are present in the adventitia of the renal arteries. And this would decrease both the afferent and efferent decrease or ablate the afferent and efferent pathways of the central nervous system supplying the renal nerves. And this would decrease the central sympathetic activity and decrease the blood pressure in this resistant hypertension. So this is a diagrammatic view where the sympathetic nerves are present in adventitia, and that is why many catheters were designed to deliver a radio frequency energy to ablate this renal. The nerves in the sympathetic nerves are in the renal artery. The first study which was done by a Medtronic, which through a simplicity catheter. And what it was a very simple catheter with just one point for ablation, and this was rotated and it was in a spiral form and pulled back, and this ablation was completed in 4 to 6 minutes. This is one of our patients which we did probably for the first time in the country. It is simple to do, but there is no control. There is, of course, a safety mechanism built in the machine. The results were variable, and what it does histologically, it sort of stimulates, and if there is a destruction of coagulative destruction of the sympathetic nerves in the adventitia and also in the peri-adventitial tissue. This study was done first as a first-in-man study, and then a larger studies which were known as first-in-man simplicity hypertension 2 and simplicity hypertension 3 US randomized clinical trial, which actually turned out to be a negative trial, and it was seen that there was no benefit in doing this sort of a procedure. Although it was a conventional and intuitive thinking that this procedure used to work in surgical patients. So that is why it was sort of revisited, and different type of catheter designs were made so that the ablation could be more circumferential and it could be more complete, and also that we could avoid injury to the vessel, other parts of the vessel. We can have a simultaneous cooling of this renal artery at the time when we are giving radio frequency energy to ablate the adventitial nerve. So now it's coming back. So we have a device from Covidian which has a simultaneous cooling, which is balloon-based to center this catheter. And also we have a new electrode from Medtronic, which has helical and elliptical electrodes, which is working very well. So apart from this, there is other way to actually control blood pressure is, that we have, the baroreceptors at the carotid bulb. If we can somehow dilate it mechanically and keep it dilated or stimulated, in both ways, we can actually give stimulus to the brain that the pressure is high at that point, and this will lead to a counter down regulation of sympathetic stimulation and decrease the blood pressure. So we have implantable devices which sort of stimulate and the baroreceptors in the carotid, and we also have self-expanding stents in the carotid for amplification of baroreceptor response in these patients. So we have this device which is known as the Mobius HD device from Vascular Dynamics. It comes in 3 sizes from 5 to 11.5 millimeter in diameter, and it is placed in a very easy way in the carotid bulb, and it stimulates and reshapes the carotid bulb, leading to a fall of systolic as well as diastolic blood pressure. 9 patients have been done up till now by these devices, and it has been shown that there was a clear reduction in medication, the number of medication, and also the dosage in these patients. And the safety, there was no safety issues, and distal protection devices were not required. The last device is Routh's coupler, where we create a 4 millimeter arteriovenous anastomosis in the iliac or femoral veins. And it is seen that this is in a non-sham procedure that it drops the blood pressure by 30 millimeters of mercury. And it has a controllable shunting mechanism. This has not been approved by FDA, but it is there for investigational use. And I'm sure in future this will also be a very simple device to actually treat resistant hypertension or malignant hypertension in patients. So So I've just told about this ROX coupler. There have been trials which are going on this ROX coupler, and it appears to be a very, very prudent device. Now, these sort of courses we do, this is the Asia Pacific Vascular Interventional course, where we talk about mechanical and interventional procedures, and we do workshops for not only interventional procedures for hypertension, but for various other vascular disorders. And this has grown to be the largest endovascular course in the entire Southeast Asia. And I would welcome all of you on the last weekend of June this year for our 13th session of this meeting. Thank you very much.
So thank you very much, Dr. Khanna, for your excellent presentation on the interventions in management of hypertension. We now move on to the next presentation by Dr. C. Narasimhan from Hyderabad, who speak on renal artery denervation in management of resistant hypertension.
Thank you very much, sir. Am I audible?
Yes, yes.
Okay, are you able to see the slides? I think a fair bit of this is already covered. So I'll just present our experience of about 25 cases done over the last 15, since 2012. The failure of simplicity trial is very simple because we do know that the nerves travel in the adventitia, and there is a very heterogeneous subgroup where simplicity recruited patients and the adherence was poor. But most important is the only 19 out of 340 procedures, all 4 quadrants of the renal artery were successfully treated and generally as recommended. Second thing is, just because the company gives a device, you put it in and start the lesion, it doesn't mean it delivers the lesion. So you turn on the current. What is the validation that you have actually ablated the renal artery? You need to monitor contact force or the impedance, none of which were monitored in the original catheters. Therefore, it behooves a basic question. Yes, the concept may be right, but there was some problem in terms of methodology. This was offset because several other trials later on, including Simplicity off-med and on-med, which were sham controlled, showed a significant reduction in blood pressure at the end of 3 and 6 months. And this has been consistent in the recent trials. But there are, like any physician, you need to be concerned about a procedure. You need to tailor it according to the renal nerve anatomy, renal nerve distribution. Catheter design becomes important. Lack of test measures, we need to do something called high frequency stimulation to find out which part of the renal artery is innervated, because there are no biomarker or marker at the end to say that the procedure is successful. And renovation is always a possibility. So the routine contraindications, we used to have a rigorous Dr. Chakravarti, who was our nephrologist. Every single patient was screened by a nephrologist. Transtubular gradient of potassium and other things were checked. All secondary causes ruled out. And then they were referred to us for renal artery denervation. I don't know. So how is it done? It's fairly simple. You take a shoot of the renal artery. Because you're going to do an innervation, we used to routinely, this is painful procedure, deepen the sedation and anesthesia before the procedure. Continuous fentanyl drip. We used to give a dose of nitroglycerin and deltiazem to prevent spasm. And with a routine renal guiding sheath, we take it and we start the ablation where the renal artery starts bifurcating or trifurcating. So that is the distalmost area, and then we ablate up to the ostium. How is it done? What? This is frozen. Okay. So all the patients, 4 to 6 lesions are delivered circumferentially. Now, whenever RF current goes from the intima to the adventitia, it is basic physics that the impedance will drop. So we observe for a drop in impedance. If the catheter is in the lumen and it is not creating a lesion, then you will not see an impedance drop. Either you need to deflect the catheter or increase the power. We go up titrate the power up to 12 watts to see a meaningful fall in impedance of 10 to 15 ohms. At least that tells you that the lesion has been created. So this is one of our first patients, started 170 and uncontrolled blood pressure, progressive reduction of blood pressure with periodic visits and with the same blood pressure reading. This is again the number of drugs before the procedure, pre-procedure blood pressure, BP at 1 month, 3rd month, and 6 months. Significant reduction in blood pressure in most of the patients, and the number of drugs also come down at the end of the renal artery denervation. This is our first cohort we had published in the Indian Heart Journal. This was a dramatic example of a patient who was referred to us, a dialysis dependent patient who was coming to us with recurrent pulmonary edema despite adequate dialysis. Now, one question we ask the patient is, after dialysis, what happens to the blood pressure? So if a patient comes with high blood pressure and when the volume is removed, the blood pressure comes down, it is a volume dependent hypertension. But despite taking out enough volume, the blood pressure shoots up, that you have pre-selected a renin-dependent hypertension, and that entity is called interdialytic hypertension. This patient had one such episode, and after renal artery denervation, we had a significant drop in blood pressure to the point, especially after the first day, we got worried whether there was some serious problem. We had to take her up, do an ultrasound, give a saline, and all those things. There are some patients, having done this for quite a few patients, the anatomy defines that in some patients with early bifurcation, we may not be able to completely denervate with the technique that we use, but it's fairly simple. If we know the physiology of RF, we should be able to ablate in a vast majority of these patients. How is it done? We take the catheter distally. Suppose this is the circumference of the distal renal artery before the bifurcation. We mark it on the board, southern, at 6 o'clock position, 3 o'clock position. We don't go around circumferentially at the same location. We withdraw the catheter and deliver it at different levels till such time we come to the ostia. The anatomy defines that the aortico-ostial ganglion is slightly anterior. So we need to deliver lesions around the ventral aspect or the aortico-renal ganglia, which is anatomically defined. We can't see it on the fluoroscopy. Empirically, we deliver lesions around the anterior portion up to the os of the renal artery, and then take a picture and complete. This is the initial cohort. And unfortunately, what happened was after that, we left an institution and we have not been there. There is a re-interest from the present group. We are going to restart this. The biggest advantage is you use your conventional tools, no expensive material, a simple renal guiding and a regular RF catheter. You can successfully denervate a vast majority of our patients. So this is one of our, the first author is a postgraduate who was calling and following up these patients. And this is the blood pressure recording over a period of both systolic and diastolic blood pressure over a period of 6 months of follow. So there is an anatomical basis and a pathophysiological basis for renal denervation. However, as hypertension is a very complex problem, we need a multidisciplinary team to kind of identify the real patients who are likely to benefit from this. Efficacy is being shown in several trials. Over a period of 6 months compared to the drug therapy, the denervated group fares better. And the biggest bane of this procedure is how to assess the efficacy of denervation. Because now we have been doing high frequency renal stimulation. If you go to the neurologist, there is something called GRAS stimulator. They use for stimulating the nerves and nerve conduction study. We use a similar principle to identify where these nerves are located and denervate those areas. And the CV outcomes, we feel that if you choose your patients right, you are likely to improve the outcomes in these patients. Part of the reason why the initial studies have had a negative results are multifactorial. patient selection, methodological problems. So it's still a process and evolution. We find that over a period of time, this is likely to evolve as an adjunct to regular medical therapy in refractory drug-resistant hypertension. Thank you very much for the patient listening.
Dr. Gaurang Saab, please introduce.
Yeah. Our next speaker is Dr. Shailesh Raina, Director Urology, Robotics and Renal Transplantation, Jetflog Hospital and Research Center. He is a senior urologist in Sir H.N. Reliance Beach Candy, Lilavati and Wockhardt Hospital. A graduate from Armed Forces Medical College, Pune in 1975, trained in urology in Mumbai, Bristol, Royal Infirmary of Bristol and Institute of Urology, London. He returned to India from UK in 1988 and has been in practice as a urologist since then. Pioneered urology in the country, president of the Pelvic Floor Society, formerly governing council member of USI. He is trained in robotics at Strasbourg and Arles, Belgium. So I introduce Dr. Raina. Dr. Raina, please give your talk.
Thank you very much, Dr. Shah, and thank you for inviting me. Are you able to see my slides?
Yes.
You're able to see my slides?
Yes, yes.
Thank you for inviting me. And I must admit that I was pleasantly well educated in the last half an hour I'm sitting on hypertension. I loved my previous speaker's talk and I have a lot of questions to ask him. Dr. Mahapatra, thank you for inviting me. But I have just two topics to speak on today regarding interventions. One is the adrenal. And let's have pheochromocytoma and paraganglioma as adrenal tumors that cause excessive release of catecholamines. Let's be honest about it. When we go for operating these patients, we have our physicians by our side, but we have a better understanding of the whole disease once we do and interact with our physicians. In our center, we have the VM, the vinyl mandelic acid as the and the epinephrine, norepinephrine levels as the basis of investigations. We do the CT, but for metastatic paragangliomas, MRI is our objective of choice. For functional imaging, we have the scintigraphy, MIBG 123, somatoreceptor imaging. And sometimes, even with these nuclear devices, we even treat malignant paragangliomas. Now, for pre-op management, I must admit, we start off with our alpha blockers. After good control, we go to our beta blockers. But in those patients who have a low ejection fraction, in those patients who have a cardiac problem, we do not give too much of beta blockers. Calcium channel blockers are given by the physician. We have a high sodium diet and increase of fluid to restore the blood volume pre-operatively. We avoid drugs that release catecholamines like steroids, amitriptyline, and cocaine into cocaine addicts. Now, the biggest problem here is in pre-operative assessment. What about those patients who are biochemically silent, who have no such problems, who are not really hypertensive, but yes, who have a few, but they are silent? Do we need to treat them? Looking into a lot of literature and in our center, yes, the goal is to minimize intraoperative hemodynamic instability. And I think these patients with a bit of alpha blockers preoperatively will be good candidates for surgery. In the management of hypertensive crisis, I love the talk of my earlier speakers where they spoke on spironolactone as the last big drug now in hypertension. I must admit, after having a good alpha blockage and after a week of alpha blockage, beta blockage for about a few days, in our surgery point of view, the only thing here is early ligation of the adrenal vein. And this, without touching the tumor at all, is really performed very well by robotic surgery. There are a lot of studies which show the persistent postoperative hypertension varies between 30 and 60%. And it had been shown that tumor size and preoperative levels of catecholamines were associated with postoperative hemodynamic stability. Now, this is robotic surgery. This is clamping I've just clamped the adrenal vein. And once you've clamped the adrenal vein, there is less catecholamines in the body at that particular moment of time. Robotically, the advantage, of course, is that the tumor, as you can see, being removed right now, that's the tumor, that's the adrenal. We hardly hold the adrenal gland at all in these cases. So once the vein is ligated without much of traction on the tumor, there is we've hardly gone into hypertensive crisis. You can do it robotically, you can do it laparoscopically. There is no difference in the long-term results. Though I must admit, for pheochromocytomas and functioning adrenal tumors, I prefer robotically. My next talk is on nephron-sparing surgery. There is no doubt that today we're looking at nephron-sparing surgery for small renal masses. Even for larger renal masses today, we are still looking at nephron-sparing surgery because radical nephrectomy has an increased risk of chronic renal disease. This is how we look. This is how we grade our small renal masses, but it's not only by size, it's also by location, endophytic, exophytic. Here the problem is there a positive effect of blood pressure in partial nephrectomy? There are a lot of studies done. We also have other studies in our cases, except for one article by Nathan. It has been shown that when a follow-up, partial nephrectomy does not bother with hypertension, in the sense, if you got hypertension before partial nephrectomy, it most makes it worse. And if you've done partial nephrectomy, you are not a candidate for hypertension because it's nephron sparing, provided your other kidney is normal. Yes, warm ischemia time. Till 25-minute threshold, we do not have to clamp the artery, the vein at all. So we just only clamp the artery during robotic partial nephrectomy and not the vein. So a warm ischemia time can be extended till 25 minutes. If there's a complex tumor and you clamping the artery and the vein, then we put ice, and till 58 minutes, we are quite okay, so that these patients do not go into hypertension postoperatively. So here is another article which shows that the partial nephrectomy does not result in initial or long-term postoperative deterioration in blood pressure. Now, these are the cases which we have done. These are all sorts of cases. These are exophytic and endophytic. Here, a lot of us do PET scans after the surgery. Sometimes the PET scan doesn't fill it up. For renal tumors is the PSMA PET, which can be of some use. We always do a three-dimensional reconstruction and an ultrasound intraoperatively for endophytic tumors. So in these cases, sometimes when you are doing this, and if you want to make sure that you have removed all the cancerous part, you can inject indigocarmine after ligating, after clamping the renal artery. And if you see here, once this is, sorry. Once you have injected indigocarmine, the normal tissue is green and the tumor tissue is black. So after you coat that out, you can remove just the tumor tissue. So these are the type of cases I'm speaking about. In our cases, we only put a bulldog on the artery. The vein is not put a bulldog at all. We score the tumor and then we remove the tumor. The nephrorrhaphy is done. In large tumors, we have something called the MRATE, which is the modified robotic assisted tumor nucleation. See, don't forget that there's a fibrous tissue between the tumor and the proper renal caps and the proper nephron, the non-cancerous nephron. And here what happens is, between the cancer and parenchymal interface, if you remove all that by enucleation and you have a 2 millimeter sliver of parenchymal tissue on the superficial, then you are quite okay as far as the cut margins are clear. We have partial nephrectomy for central renal tumors. Here, of course, there is no doubt that you have to clamp the artery and the vein, and here you have cold ischemia. You're putting ice along the kidney. In cases sometimes when there are solitary kidneys and you have something like a little cyst here, you're not sure on CT, what we have done is we have done contrast-induced ultrasound. And there we have managed to pick up this little solid lesion inside the renal cyst. And this has been done partial nephrectomy robotically. Sometimes you can actually just clamp this vessel, which means you're not clamping the artery at all. The vein, of course, is not clamped. And just the artery to the tumor can be clamped, so there's hardly any warm ischemia. In some very large masses, as you can see, this is a case of the similar case, a large mass. Though it is the size is big, it is endophytic and exophytic. We still do a partial nephrectomy in these cases. If you see this carefully, it's removed, it's put in the bag. You sometimes are not sure whether you have removed the whole thing properly. So you take extra bit of tissue and you have a report which says that it is cut margins are clear, and also that the other thing which you have taken, the revised margin, is also clear. We can't compromise with cancer. Here is another patient which has a large angiomyolipoma causing pain and causing hypertension, not because of pressure. Here it is a large angiomyolipoma here. These cases are first had pre-operative angiogram done, and then you embolize this vessel, because an angiolipoma is a very, very vascular vessel. You take the patient to the operation theater from the cardiac cath lab itself. It is embolized and straight taken to the operation theater. Super selective embolization is done. If you look at this carefully now, this is the patient which was taken straight from there to the artery and the vein. You can see very clearly this, that yellow thing which you see there is all, that is just where the scissor is all the angiomyolipoma. It's a large angiomyolipoma. It's all removed and robotically suturing has been done. The histopath says there is no evidence of malignancy and it says it's angiomyolipoma. The ultrasound post-operatively after 2 months has no evidence of that angiomyolipoma. This can be done robotically. When you have something like this, which is an endophytic tumor, here is where an intraoperative ultrasound is essential. And then most of these patients where this is the kidney where the fat, this is the thing which has been scored. All that has been scored. It was most only on the posterior side. The kidney has been totally rotated. Only the artery has been clamped with the bulldog, not the vein. And of course, we have gone deep because we had the ultrasound showing us exactly where the tumor was. Histopathology says conventional clear cell renal cell carcinoma. In patients of VHL, which we have done 2 or 3 patients of VHL, there are multiple tumors. These patients are going to keep having these tumors recurred. These patients definitely require partial nephrectomy, and They have no reason to have a radical nephrectomy. If they have a radical nephrectomy, they go in for renal failure. In the last 2 years, we have done 55 nephron-sparing surgery robotically. Artery and vein have been clamped in only 10 cases of complex tumors. There's no obvious hypertension post-partial nephrectomy. Take-home message is nephron sparing as far as possible. Case selection is important. For hilar and endophytic large tumors, intraoperative ultrasound is mandatory. For solitary kidneys and VHL, ultrasound Doppler intraoperative is mandatory. You can do it open, laparoscopic, or robotic. For adrenal tumors, for pheochromocytomas, without touching the tumor, robotic, I would feel, is safer. And nephron sparing and prevention of hypertension post-partial nephrectomy is to be kept in mind. Thank you for a patient hearing.
Thank you, Dr. Dana, for your excellent presentation on the robotic adrenectomy and the nephron sparing surgery. I think all the presentations were wonderful regarding the intervention in hypertension. So as we are running short of time, so Dr. Mahapatra?
Yeah, thank you, Dr. Pancholia and Dr. Gomsa. We'll be moving to the next session. The
Thank you. Thank you.
Can I have one question to ask Dr. Narasimhan?
Okay.
If it's possible.
Yeah, sure. Go ahead.
I was very impressed with renal denervation, renal artery denervation. Dr. Narasimhan, would that be applicable in patients of renovascular hypertension? Would the hypertension in renovascular hypertension come down by renal artery denervation?
We don't know, but we have excluded those patients from the trial because the mechanism is different. But one sure thing is, as a surgeon, you are better suited because most of the nerves are the adventitia of the vessel. When we do an ablation, we are coming from intima to the adventitia. So if you can somehow, with a very minimally invasive procedure, you do cryo or RF, it's ideally suited in the surgeon's hand.
Thank you.
Okay. Now I would request, thank you very much, Dr. Raina and Dr. Narasimhan, Dr. Khanna. So I would like to go to the next session, rehabilitation and home care in hypertension. In this context, I would invite Professor Dr. S.N. Rautrai. He's an interventional cardiology and professor and head of the department of SCB Medical College, Cuttack. And along with Dr. Manish Bansal, he's a senior consultant cardiologist in Medanta, director of the cardiology, Medanta, Delhi. So please hand over to the chairperson to conduct the last session. Thank you.
Yeah, good afternoon, everybody. At the outset, I must thank Dr. Mahapatra for bringing up such an excellent CME on hypertension, where we have learned from many giants in the field. And coming to the last session, I welcome you all along with my co-chairperson, Dr. Bansal. The first talk is by Dr. A.K. Pancholia. Dr. A.K. Pancholia is a good friend of mine. He's a cardiologist from India. He is a regular faculty in most of the national seminars and conferences in the last few years. Now I invite Dr. Pancholia to start his talk on sex and hypertension.
Thank you, Dr. Rautrai, and special thanks to Dr. Mahapatra for the kind invitation to speak on this very neglected but very important topic in hypertension, because there is always a hidden agenda about the sexual dysfunction in the mind of hypertensive patients, but never been discussed with his doctor, and also in the mind of physicians, which we never discuss with the patients. Sexual activity is of the great concern with the heart disease and the blood pressure. The mean increase in the blood pressure at orgasm is around 80 by 50 millimeter of mercury. Sex with a regular partner, the BP may go up to 150 to 180 systolic, but sex with other one or someone else, it may go up to 210 systolic. Coming to the sexual dysfunction and hypertension, regarding the male sexual dysfunction, the problems are related to libido, orgasm, ejaculation, and most often it is related to erectile erection. And this is the IIF, that is the International Index of the Erectile Function, for assessing the sexual function. Prevalence is around 52% according to the Massachusetts male aging study. Hypertension is an independent risk factor for erectile dysfunction with a higher prevalence when it is associated with cardiovascular disease and chronic kidney disease. At least 1 in 2 men with hypertension, they develop erectile dysfunction. According to the NANS criteria or NANS study, the treated hypertensive have more prevalence of erectile dysfunction compared to untreated hypertension. And erectile dysfunction is also correlated well with the severity of hypertension. More the grade of hypertension, more the chances of erectile dysfunction. Coming to the other side of the coin, there is hypertension in patients who are having a primarily the sexual dysfunction, and the erectile dysfunction is an early marker of hypertension. As the onset of erectile dysfunction is detectable even before the onset of hypertension. Structural and functional alterations occurs earlier in erectile compared to the vascular tissue. And the reported prevalence of hypertension in patients with erectile dysfunction is around 41 to 44%. What about female sexual dysfunction in hypertension? High blood pressure also affects the sexual function in women, but it is not been understood. In one of the studies, the sexual dysfunction was found to be 42% of hypertensive women compared to 19% of the normotensive women with an odds ratio of 3.2. What about the pathophysiology behind that? There are structural changes in the penile vasculature, change in the extracellular matrix morphology, functional alteration in the penile resistant arteries, and attenuated relaxation in response to nitric oxide due to increased oxidative stress. Hypertension is associated with significant reduction in the penile arterial inflow, and it is very well correlated with the grade of hypertension and also the duration of hypertension. And these are the morphological changes. What we see, there is an increase in the vascular smooth muscle cell proliferation, increase in the thickness of the cavernous smooth muscle, and increase in the collagen around the vessel. Endothelial dysfunction is the common pathway between hypertension and erectile dysfunction. There is evolving role of angiotensin II as a mediator of the erectile dysfunction. RAS activation in hypertensive patients with enhanced angiotensin II production is responsible for structural and functional changes in the penile vasculature. Increased angiotensin II also causes reduction in the nitric oxide production, leading to endothelial dysfunction and ultimately vascular hypertrophy. Overall, there is an imbalance among the nitric oxide, angiotensin II, superoxide anion, and endothelin 1 responsible for erectile dysfunction. Coming to the hypertension treatment and erectile dysfunction, as you know, there are 6 classes of antihypertensive drugs, but these 2 classes, diuretics and beta blockers, are more responsible for erectile dysfunction. What are the possible mechanisms? So the beta blockers, it reduces the testosterone level, inhibit beta-2 mediated peripheral vasodilatation, depresses the Leydig cell activity and anxiety, while the mechanism related to diuretics, the fluid depletion, electrolyte abnormalities, zinc depletion, and direct effect on the cavernous smooth muscles. How definitive is the thiazide association with erectile dysfunction? And thiazide and thiazide-like diuretics are responsible for erectile dysfunction in 3 to 32% of the patients. And this is the TOMS study, which clearly showed the erectile dysfunction observed more with the chlorthalidone compared to other classes of antihypertensive drugs. How strongly are the beta blockers related to erectile dysfunction? And the studies clearly showed the non-selective beta blocker in carvedilol has an incidence around 13.5%, propranolol 5%, atenolol 3%, and with bisoprolol it is almost 0%. There is a psychogenic factor also contributes in the beta blocker associated erectile dysfunction, what is called the nocebo effect. In this particular study by Silvestri, there are 3 groups of the patients. All 3 groups received beta blockers. The first group don't know that it is a beta blocker and don't know also that it causes erectile dysfunction. The second group know that it is beta blocker but doesn't know that it causes erectile dysfunction. While third group know that it is beta blocker and also know that it causes erectile dysfunction. And we have seen more erectile dysfunction in the third group who knows that it causes erectile dysfunction. What about newer beta blockers? Nebivolol reverses the endothelial dysfunction and erectile dysfunction through nitric oxide production. So it's a beneficial effects. And this is the Mr. Noed study where nebivolol compared with metoprolol, where metoprolol causes more erectile dysfunction, while nebivolol in fact improves the erectile function. What about ARBs, angiotensin receptor blockers? Sexual function dysfunction in hypertensive patients treated with losartan and it clearly showed an improvement in the erectile function and both satisfaction and frequency of sexual activity with losartan. Losartan also improved erectile dysfunction in diabetic patients, and valsartan appears to improve the sexual function in men and women with hypertension with improvement in the IIF score. And this is the brief meta-analysis of the randomized controlled trials, which clearly conclude that ARBs significantly improved sexual activity among participants in intervention group. So overall, when you look at the studies, the antihypertensive which actually improve the erectile function are ARBs, that is losartan and valsartan studies are there, and of course there's the newer beta blockers in the form of nebivolol. Can treating hypertension improve erectile dysfunction? There is a little evidence that treating hypertension will improve erectile dysfunction, although theoretically the vascular remodeling and the improvement in the smooth muscle cell function might enhance the erectile response, but there is no data. Animal data suggests that medical treatment of hypertension may have the potential to reduce the incidence of erectile dysfunction. Hypertension, when associated with sexual dysfunction, are responsible for more cardiovascular events. Erectile dysfunction can be a marker for cardiovascular disease, and this is what the statement by Norman Kaplan: if you have a problem in your erection, probably your heart is going in the wrong direction. And this is the data from the transient and the on-target studies. Erectile dysfunction is associated with a twofold increase in the risk of myocardial infarction and cardiac death in hypertensive men. And this is the Princeton 2 consensus panel, which clearly showed that the controlled hypertensive have a low risk of CV events, while uncontrolled hypertension have a high risk of CV events. And thus, a thorough cardiovascular investigation is advised in high-risk patients. What about therapy? Management starts with lifestyle modification in the form of regular exercise, weight loss, and Mediterranean diet. Coming to the pharmacotherapy, and here comes the role of PDE5 inhibitors. And this is the reappraisal of the European guidelines, which clearly showed that after initiation of PDE5 inhibitors in these patients, they are more likely to take antihypertensive medications and BP control is improved. So overall, there is improvement in the adherence when you start PDE5 inhibitor therapy in hypertensive patients. So adherence to the antihypertensive therapy will be increased. Can PDE5 inhibitors be combined with the ARBs and nebivolol? And the study clearly showed that combining tadalafil with the losartan clearly improves the IIF EF5 score in these patients. And this is the combination with nebivolol, which also showed reversal of the erectile dysfunction in diabetic rates through enhancement of the nitric oxide cyclic GMP pathway. Now, problem in our setup that 25% of the men would wait as long as possible to see a doctor. And despite high prevalence of erectile dysfunction among the hypertensive men, it is not often matter of discussion during consultation with the general practitioner, which I already said early. Sexual function knowledge by general practitioners and cardiologists is relevant and should be ideally assessed before starting therapy for hypertension. So take home points: hypertension is very well linked with the erectile dysfunction. Both are the markers of endothelial dysfunction. Both are predictors of cardiovascular risk. Erectile dysfunction in patients with hypertension may not only negatively impact the ability of the patients to stay on antihypertensive therapy, but can also deteriorate the quality of life. Proper history of erectile dysfunction in hypertensive patients along with antihypertensive drugs is very important, as hypertension itself causes erectile dysfunction. So it is a common clinical mistake by the doctors and the patients to avoid medications fearing the side effects of erectile dysfunction. Thus, hypertension and sexual dysfunction, time to act now, always aim high. Thank you very much.
Thank you.
Thank you so much, sir. Yeah, for this excellent talk on this very important topic. You covered almost every important aspect of this problem, right from the pathophysiology to the therapeutic implications and challenges which are faced in treating erectile dysfunction in hypertension. I think we'll have questions after the second talk, and therefore we now move to the next talk in this session, which is again on a topic which is important but very less talked about. That is home care and rehabilitation in the management of hypertension. And for this, I invite Dr. Ashish Contractor. He is consultant in preventive cardiology at the Sir H.N. Reliance Foundation Hospital in Mumbai. He is one of the biggest names in the field of cardiovascular rehabilitation in our country, and he is an excellent speaker. So it's now your turn, Dr. Contractor.
Thank you. Thank you so much, Dr. Bansal, for the kind words of introduction. And thank you to Dr. Mahapatra for inviting me to speak today and for the excellent follow-up that he and his team have had throughout the planning of this conference. So thank you so much. May I request the IT team to put on the first slide? I had sent you the slides and hopefully, thank you, Nikita. Okay, so the topic that I was given today is apps and mobile tech for home care and rehab. And in the next 10 minutes that I have, I'm going to try and just give you a quick summary of where we stand today and where we would look to go in the future. Next, please.
Your turn.
So unfortunately, we can't, no, the previous one. Unfortunately, we can't meet each other in person these days, but this is just a picture of a hospital in South Mumbai. When things are more normal, please do come and visit. Next, please. So today I'll quickly just touch upon what is telehealth care, talk about telehealth applications in cardiology and some of the current devices and monitors used, try and spend more time on that and a few points in conclusion. Next, please. So, you know, we were all aware of telehealth care and telemedicine. Frankly, we've been talking about it for the last, more than 2 decades. But it required a global life-changing event like COVID to really make it come into the forefront. I am sure that each and every one of you attending this conference today has significantly increased your telehealth practice over the last 1 year. And part of telehealth is also remote patient monitoring. Now, this is something, again, which we were doing in the past, but necessity is the mother of invention, and the last 12 months has accelerated the development of science and technology in this area. Next, please. So when I was given the topic, I went online and did a search for, articles related to it. And we looked at mobile apps for blood pressure monitoring. And I did this was a systematic review. Next, please. And I'm not going to go through. Next slide, please. Yeah, I'm not going to go through this slide in detail, but honestly, the point is that a lot of this information is available out there. Now, what's very interesting is where blood pressure is concerned, at the end of the day, one of the most important aspects of blood pressure care is frankly measuring the blood pressure. So an app by itself cannot measure the blood pressure. You need a device to measure the blood pressure, and the device kind of talks to the app. And that makes the circle complete. Also, what's happened is there has been a plethora of devices that have taken place over the last 5 to 10 years, and especially over the last 1 year, which allows these kind of devices to measure, many different aspects of our health in all aspects of our body. Next, please. Can I have the next slide, please? Yeah. So, this, if you see on the left, this is actually a telehealth session we were conducting. So on the left is my doctor talking to the patient. And on the right, you can see an ECG streaming. So if you just click on the slide, it's just a 5-second video. You'll see there. Yeah. You can see the ECG actually streaming. So we've been using a device, which is called, Fourth Frontier. And that, is made in India. It's actually made in Bangalore. So it's very nice that we have an indigenous device. And for the first time, I've been monitoring this space, frankly, for the last 15 to 20 years. For the first time, I have personally come across a device which is both very convenient to use and at the same time has stability in ECG data. Next slide, please. Yeah. So the device literally is a chest strap, and I'm actually wearing it as we speak. Okay, I'm wearing it as we speak, and if you see my phone, my ECG is streaming live to on my screen as we speak. If obviously I could have reflected on the screen, but I'm not presenting from my laptop, but the ECG is reflecting live. And the nice part is that I can, through WhatsApp, send this ECG to Dr. Bansal or to anyone, frankly, across the world who has WhatsApp, and it will also stream live on them. So we're really able to measure and monitor patients very well because of it. Next, please. So, in person, when we're doing it, we're monitoring patients. For example, here I'm using the standard Philips monitor where we're using telemetry monitoring, and throughout the hospital we can measure, but this did not allow us to measure people at home. So with these new devices, we can actually measure people long distance and at home as well. Next, please. This was a lovely review in Nature Reviews, which I read just, I think, about 10 days ago, which spoke about smart wearable devices in cardiovascular care, where we are and how to move forward. Next, please. And it's a lovely article. I really recommend you read it, and goes into great detail with all the devices that are currently out there in the market, all the commercial devices that are currently out there in the market, and the studies that have been done and what they are used for. So just like a quick sort of roundup, they have devices which even they have medical earbuds. We've got ECG patches. We've got a chest strap like the one I'm wearing. We got a smart watch and band. I've got a Fit out here which does my heart rate data. Today, for example, Geo has come out with this new band. With this, it's giving me ECG, it's giving me SpO2, it's giving me body temperature. With COVID, body temperature has become a big thing. There's a company called HYPERTENSION, which is the first one which tied up with Apple to give you a ECG for atrial fibrillation detection. And this is what the HYPERTENSION sort of strip looks like. So if I just put my finger on this, and I have on my cell phone, on my Apple phone, my ECG can be transmitted. Today, you have a smart ring also, which can do some of these things. And you have sensors which are even embedded in clothing, sensors embedded in shoes. We're measuring physical activity through accelerometer. We're measuring blood pressure. So it's all sorts of data that we're getting. Next, please. So this is the ring I was talking about. It's called an Aura ring. This is literally the size of a ring that someone wears around their finger. You can sleep in it. It gives you all sorts of sleep data. And this is Omron. So Omron has been one of the sort of leaders where this technology of blood pressure monitoring or digital blood pressure monitoring is concerned. And they came out with this watch, which is called a heart guide. And if you kind of look at that picture, you can see there's a cuff inside it. So the cuff kind of inflates and deflates on regular interval when you want to measure your blood pressure. Today, there are many devices which even work in a cuffless manner. Next, please. So AlivePower, one of the largest companies in this data monitoring, and Omron, they've kind of partnered together to do remote cardiovascular monitoring. Next, please. So, today, there are more and more monitors and apps which are helping to increase convenience and accuracy while offering this continuous measurement. We know where blood pressure is concerned. You have things like white coat hypertension. The person comes to you and the pressure is high. They go home, it's normal. Also, the typical way that medicine is practiced, you'd go to your doctor and they'll check your blood pressure reading, and they'll see you again after 2 weeks, 3 weeks, maybe a month, maybe 2 months. So essentially, we are taking calls on clinic measurements. You're seeing a person one time in 2 weeks, 3 weeks, 4 weeks, and making a call. And we all know that one pressure reading could be inaccurate, both on the high or wrong. So when I say inaccurate, I mean not fully representative. Next, please. They had a study which looked at BP measurement in the doctor's office versus BP measurement in the self-monitoring BP at home, both by a telemonitoring as well as just by sort of paper and pen monitoring. And what they essentially found is that regular self-monitoring at home and telemonitoring was better than just standard doctor visit monitoring of BP. And this was published in Lancet 3 years ago. Next, please. So what are some of the barriers for implementation? Okay, the last couple of slides, we'll talk about some of these barriers. One is just what we may call digital literacy. And that's changing rapidly. Today, the vaccines are being rolled out. To even get a vaccine, everybody needs to be digitally literate, or they need to have some family member who goes online. The CoWIN app is there. You need to log on. You need to register. I think one of the two big constraints I practically see in practice is that physicians are often inundated with so much in their practice. There's so many things going on that to kind of separately monitor people, monitor patients, and have that data come in tends to be an add-on burden. And I'm not sure how many, a lot of these apps also don't tend to be very physician friendly at the back end. They're user friendly for the person using it, but often they end up giving the doctor so much data that the doctor spends time separating the, if I may call it, the noise from the data. Okay, when atrial fibrillation was starting detecting by the watch, so many people went saying they've got atrial fibrillation, and some of it frankly was noise as well. There's also an issue sometimes about the legality of some of these things, cross-border monitoring, ethics, privacy issues. So I think as the world is getting more digital, we are learning more about this, and we will get clarity over time. Next, please. So in the future, what are some of, we envision a healthcare system that basically, yes, that assembles a broad spectrum of patient data. Okay, this is parameters including movement, ECGs, lab tests, genomics into an electronic health record, which is then analyzed by an artificial intelligence algorithm. Okay, and now this data is made sense of. And I feel that this data should not directly go to the patient. It should go to a doctor's office who can review the data, but review it in a very meaningful manner, summarized manner, and it can then go onwards to the patient, which can really help take healthcare to the next level. I think behavior modification, we know things like medication adherence in blood pressure are huge issues that patients just don't take their medicine beyond a point in time. So medication adherence is a big issue, and some of the apps act as reminders, they act as motivational messages to take your medicines on time. Active smoking, so it can help you give messages regarding anti-smoking. Next, please. And like I said, all of this needs to be backed up by a human team of providers who review the data. Next, please. Okay, so in conclusion, basically, we know that telehealth technologies play a significant role in increasing access to healthcare and potentially reducing costs. Evidence supports the use of wearable devices. We need more large, well-designed trials to establish their advantages over what I call usual practice. Challenges include concern for device accuracy, patient privacy, cost, and sometimes how to separate actionable data from what we call noise. And some barriers include loss of personal touch. So I think the doctor must be involved as well as privacy and legal issues. Next slide, and this is my last slide. So this joke, I think, is relevant where the doctor is sort of, the patient's telling the doctor, I've already diagnosed myself on the internet. I'm only here for a second opinion. So while we don't want to be lost to technology, technology can certainly help us take practice to the next level. So thank you once again for your attention on this late Sunday afternoon. And thank you to the organizers for inviting me.
Yeah, thanks, Dr. Contractor, for presenting a nice talk, because both the speakers have done very well in their topics. But Dr. Contractor, because there is no question in the chat box, we will have some questions. Yeah. So this is a very advanced talk, but now it is even the measuring the blood pressure with a digital blood pressure is not standardized. At present time, which equipment we should feel standardized? Because I have an iPhone along with this watch, which is, and others having some other, and some having Omron. You told that is really maybe little standardized. So which one will take as standardized? Many people, many patients are coming with BP recordings and also ECG to us, and what we should tell them.
So that's a good question, Dr. Rutre. And from whatever I have read, and I want to make a caveat that this is from what I've read, I think Omron has been a leader in this digital measurement, and this watch that they're talking about, they've had studies showing a reasonable degree of accuracy. I've got to say that I haven't used it myself, so I can't directly comment on it. But the blood pressure measurement, so even some of these, like this thing, says that it gets blood pressure. I think these are early days for validation. Sometimes one can argue that even if they have an error, if the error is within an acceptable zone and it picks up a trend over time, then that can be useful. Like if the pressure is actually 170, for example, and it shows you either 160 or 180, we know that either way they are high. And one can argue both ways that accuracy is important. but sometimes, even just showing a trend in the right direction is important. So for blood pressure measurement, I think we are in early days. For ECG measurement from an FDA perspective, I know AliveCore, this is the one that I showed you, this has got already got a approval. And the device that I'm using and we're using with this, they are in the process of applying for both US approval for it. So to answer your question, I think we will hopefully the next time we have this presentation, if I'm invited, Dr. Mahapatra, we can say that this we've been using for a long, long time, and I can personally vouch that it's accurate. Yeah.
There is one question in the chat box. Please discuss which hand is better to take blood pressure, right or left. So I think it is actually right-handed person the right hand and left-handed person the left hand, because the handedness is slightly higher blood pressure. See, if the right-handed, right hand will show a little higher blood pressure right arm. So we will take the higher one. What is others' opinion?
I don't have a strong view on this, but in some of these studies that they have done, I was just reading some yesterday for this, they use the non-dominant arm for the study. Now that doesn't mean that's the only way. So I don't have honestly a strong opinion on this either way. What you're saying makes sense, that if the two pressures were different, it would be better to take the higher one to err on the side of caution. But I personally don't have a strong view on this.
Dr. Panchula, your view on this?
My view is, now suppose a right-handed person, and if his blood pressure is more on the left hand, I think that will be more correct. Which is not related to the handedness. A right-handed person having a more blood pressure on the left hand. So the side where the blood pressure is shown higher, that is considered to be more correct.
Or Dr. Panchula, can you take the average, right and left hand average?
No, actually, Dr. Mahapatra, clinically, we are supposed to take the blood pressure from both hands and lower limbs, in standing, sitting, and supine position. Only then we get a proper reading. And getting an average out of it, I don't think it conveys any meaning. And it should be ambulatory blood pressure monitoring, which gives a clear picture about what is the blood pressure variations, especially the night dippers and all those things.
No, night is okay. So which one we should take, right or left hand?
Any arm, whichever is comfortable for the patient. And if it is exceeding the limits, whatever has been prescribed, it should be considered. It is my personal opinion. I would like to get the opinion of Dr. Rajshekhar sir. Dr. Rajshekhar sir, he's an ardent clinician, and I think he'll be in a better position to comment on it, sir.
Comment.
We can take
right
an average. It is already answered long. It's very old question. Already answered. We can take an average. You are repeating. Average. That is, during the first talk, it was answered.
I read the question.
Only one question which is not answered now is neprilysin inhibitor. Almost all the questions are answered. Please, anyone who wants to comment the role of neprilysin inhibitor? That is sacubitril. Anyone? Dr. Pancholia, would you like to? Dr. Pancholia?
No, I don't have any much experience. I think we are not using it commonly.
Yeah, sacubitril, mostly it is useful for neprilysin, that is sacubitril with valsartan, that is neprilysin inhibitor, more so in heart failure with reduced ejection fraction, that is paradigm HF trial. So many things are there. That is the essential, the gold 4. The first 4, that is this neprilysin inhibitor. Another one is our SGLT2 inhibitors, and other drug is beta blockers. So all these drugs play a vital role in controlling hypertension and also with the heart failure. That is the golden 4.
Yeah. ARNI is almost getting approved for heart failure with preserved ejection fraction also, but not for treatment of hypertension per se. Patient has to have heart failure in addition to hypertension to be eligible for ARNI as of now.
Yes, we can't start straight away to isolated systemic hypertension without association of heart failure.
Again, I have one last question to Dr. Pancholia. what is the effect this on females of, effect of hypertension is
The
again
sexual dysfunction is also seen in the, but it has not been well tested in the female with the sexual dysfunction.
Okay.
Not much
Actually,
study
yes.
has been carried out.
And now I thank both the speakers and my co-chairperson, and hand over to Dr. Mahapatra.
Yeah, thank you very much. And on behalf of World Congress on Clinical Cardiology and Cardiovascular Imaging things and WCSCC with NCSI, really thankful and obliged to all our esteemed speakers and eminent chairpersons, eminent speakers for giving their valuable time to be associated with us. And definitely would look forward to see them again in the future, near future. And also, I'm really thankful and obliged to our team, Exicon, the WCCICC manager, especially Nikita, Hinal, Danish, Sachin, and overall Urvil Shah, as well as Meduiz, our knowledge partner, Salya and Dr. Mamta Jain. Both of them will be preparing our individual presentations, and it will be uploaded on the YouTube, and also it will be going to your WhatsApp site so that you can save for your future reference or share to your friends who could not make it today to attend it. Thank you very much. Thank you all. Thank you. Bye.